Harshad, are you there?
Hi, John.
Hi, Harshad. How you doing? Good morning.
Thank you very much. Good morning. I just opened to get in early, but I have to get ready still. I have to do something in my home.
Okay.
So I will join you after about 20 minutes.
Okay. Okay.
I hope you're fine.
Yeah, well, we have a new thing today. We have a Zoom lounge,
Okay.
which after you present, I would invite you to come into the lounge to meet some students.
Okay.
And you, in other words, you have to leave this Zoom and go to another Zoom. Do you
Okay.
understand what I'm saying?
Yeah, I understand.
Yeah, after you finish your presentation.
Yeah, but today I'm just a listener, and I'm going to present tomorrow.
Okay, you can do that in the lounge if you want.
Yeah, because today I will not, of course, have other things to do. I'm not going to be continuous joining, but from time to time I get in and I keep the computer on. So tomorrow I have the presentation, I think at around 7 o'clock, as I remember, in German time. So it's
Okay.
in the United States, it's much earlier, but around that.
Okay, we'll see you soon.
Okay, and have a successful day, and
Thank you.
see you.
Okay,
Bye.
see you in a while. Bye. Sam, are you there? Sam, are you there? Hello, Dr. Semi.
Hi.
I'm Dr. John Bennett, Miami.
Oh, it's a pleasure meeting you.
Your first one, right?
Yes.
Good morning, Sam.
Good morning, John. Good morning, Professor Sami. Thank you
Hello.
again for your support.
Good morning.
Thank you, sir.
Good morning, Dr. Elmarsi. It is a pleasure for me to participate in this meeting, and I wish you a good success.
Okay. Okay, we start in about 8 minutes. But let me explain before we start what we're going to do. We're going to have another Zoom where we actually interview people after they speak, Dr. Semi, after you present. We're going to give you another link to go into another room. Leave this Zoom and go to another one to be talked to by students and residents, okay? It's separate from this, if you have time, but if you don't, you can just go.
What is the
But
purpose?
we give that option to speakers to meet the students and meet some residents.
And they can ask questions or whatever.
Yeah, after this, after you finish your talk, I'm going to send you a link. You leave this Zoom and go to another one.
Okay.
Okay, to meet the students. I really enjoy that.
Okay.
Okay, and let's see. And the other one, Sam, I'll just one by one text them and say, do you want to? And I'll text with you. Okay, Sam?
Okay. Please, are you so kind? Can you give me 5 minutes when my time is reaching 5 minutes before the end? Can you give me some sign? Yeah.
Yeah, okay.
Because I have never controlled my time, because I speak always free and not stick in the text and so on. So that it is very nice if you can give me just by hand 5 minutes that I can then summarize and try to finish in time. Yeah.
Okay,
That would be great.
very good. Okay, we have 6 minutes, Sam. Let's see, anybody else? The second presenter is Abby, right?
Yes.
Yeah.
I will take just
She
2
hasn't
minutes.
come in yet, but I'm sure she will. Let me take off the spotlight. That's always on me. Okay, Hisham is here. Wow is here. Dr. Sema, you've been speaking a lot, huh?
Yes, this is at 1 hour. Yeah.
Oh, yeah, of course. Of course. Introduction, intro.
Yeah. Can start.
So how do you like doing Zooms? Right, I mean, just do this here. Hey, Sam, we got 3 minutes, Sam.
Okay, John, I will start now.
Oh, you want to start early?
Yup, I will talk just for 2 minutes.
Okay, that's fine, no problem. Okay, Sam, it's all, I'll count down from 10 and then it's all yours, okay?
Okay,
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
dear brothers and friends, I am honored and very glad to join all of you and all these close friends and brothers in EWNC Skull Base Congress, which is the last gathering of EWNC Academy family for this year. In the beginning, I'd like to congratulate you all for what we have achieved together for every minute in past 6 years. Special thanks for dear brothers James Leo, Ken Yagmolo, Sanford Hesu for their great efforts to help me in putting this Congress together. We are honored today to have all such eminent mentors, professors, and faculty, and more honored to have our mentor, Professor Sami, today to talk about his recent philosophy of skull-based surgery experiences of 15 years, 50 years. Dear Professor Sami, it's over to you. Thank you, sir.
Thank you very much, Dr. Nasir. It is a pleasure, of course, for me to talk to you today to all of you, and I will try to share my presentations now. And okay. Definitely. Okay. Can you see my
It's
presentation?
okay, sir.
Yes. Okay.
Yes, sir.
Okay. Wonderful. Great. Okay.
Perfect.
Okay. Of course, as I mentioned, it's really a pleasure for me to inform the coming generation about the historical background and development of skull-based surgery. A surgical discipline as a skull-based surgery was not existing in my time as I started my personal education. But we had some pioneers from different fields, ENT, neurosurgery, maxillofacial surgeon. They have just tried to do some approaches, but were limited to some pathological entities at the skull base. For example, pituitary adenomas in sellar region, or pathologies, which was as a neurosurgeon busy with that, and pathology of petrous bone of the ENT surgeon. The surgeons were mostly neuro and ENT or maxillofacial surgeon who tried to reach the skull base. Here you see the name of neurosurgeon, and here the ENT, particularly labyrinthine approach 1904 has been introduced by Pans. And also some maxillofacial surgeons have done some very interesting approaches, particularly this year in Paris. But my philosophy of the skull-base surgery was based on overcoming the surgical barriers between individual specialty, as you see here. And the fundamental factors have influenced development of skull-base surgery. Interdisciplinary cooperation was interdisciplinary cooperation. And this started in some places, but in limited area, as you see in the statistics. For example, in Los Angeles, Dr. House was ENT, Hitzelberg was neurosurgeon. Just House made the translabyrinthine approach, and Hitzelberg removed in CP angle the tumor. That was not a real interdisciplinary cooperation. In order to push the activities of interdisciplinary cooperation, we used for the first time the medical terminology skull-base surgery, which was not existing at the University of Mainz. And I have created in 1970, that is almost half a century, more than half a century, in Mainz, together between the ENT maxillofacial neurosurgeon and included a very famous anatomist, neuroanatomist, Professor Long. But important was that I started 1966. We were only few persons in the world in neurosurgery started to use the microscope, and then that was very important, but included this development of CT scan, MRI, and endoscopy, navigation, and the neuroanatomy. They helped us to develop the interdisciplinary approaches. And the most attention was between the paranasal sinus and anterior skull base. And on the other side, the petrous one was between the middle fossa and posterior fossa, and this was and the craniocervical junction. That has been the places when we try to operate together for malformation, tumors, and also for trauma. After having enough experiences, I had the idea to distribute this knowledge which we have collected, and I started to organize the first ever historical course on the skull-base surgery in 1979. You can see my late friend here, Wolfgang Graf, and the late friend of the anatomist of Professor Lang. They are the first ever skull-base neurosurgeon in all over the world were attending in this course. They have been all famous ENT and neurosurgeon who believe that interdisciplinary cooperation is very important and came to Hanover. I had the idea we have to organize this in a society, and then we have in Montpellier decided to organize so-called international skull-base study group to make more approaches for the pathologists, and that is Professor Rabichon from Montpellier, and that is my late Professor Daraf, and here myself and other neurosurgeons. Every 2 years, we have organized a meeting in different parts of the in Europe, and about traumatology, skull-base tumors, and also malformation and different region of the skull, and was very successful. And that was the reason I had the idea. Now I have to motivate my colleagues in all over the world to organize this national skull-base society, with their colleagues, neurosurgeon, ENT, maxillofacial surgeon. And then in that time, I have published the first ever book on skull-base surgery, as you see here, and we wrote here an interdisciplinary approach. We were convinced that this surgery goes on when the people work together. That was the first book published on, and this book was not many chapters, it was the entire book, my personal and experience, as well Wolfgang Graf, and the part of the neuroanatomy, skull-base anatomy, was written by Professor Lang. German society, I have started the skull-base society and was the founding also president, and then all other my colleagues in different countries followed me, and then finally I decided to organize the World Federation Congress in Hanover in 1992, and this was, you can see, they are the leader of neurosurgery, ENT, and different fields of the skull-base surgery in this group. We had participants from 55 countries, and 850 lectures have been presented in this meeting. And this has been done every 4 years. The next was in the United States, Brazil, Australia, Canada, and then came to UK, and then the last one was in Japan, and the 8th Congress was planned in 2020, unfortunately, because the pandemic has been postponed for next year in Brazil. My personal experiences is more than half a century. It was had a learning curve, and this learning curve I would like to share with you. And the learning curve, the philosophy of learning curve was, we have to optimize by after every surgery, the next surgery, to find the best approach, best direction for the solving the problem. And the goal of the learning curve was, of course, achieving total resection of the pathology and preservation, same time preservation of the function. In benign tumors was, and is still, a challenge, but malignant tumor, of course, not always possible. We have learned over the years, more simple approach, less risk of morbidity, and we can achieve also best result. We have learned simple makes it safer, less extensive, unnecessary approaches, less complications. How we can learn to avoid unnecessary extensive approaches? By introduction of operative microscope, which everybody today is available, and endoscope also is increasing in the application. Navigation, even I believe that every department has at the moment a navigation, but we have started. I have the first navigation system ever in my department for more than 40 years ago. But much more, that is very important, but much more by systemic inoculation of the lesion. What are the facts? Why I came to this philosophy that I inoculate the tumor and then try to approach the surrounding area. Facts is that the skull-base spine, a space-occupying lesion, changing completely the normal anatomy. The normal anatomy, what you learn in cadavers, doesn't help you, and it is not also so important. Brain, vascular system, and cranial nerves are compressed and displaced. Fact is, they are under mechanical pressure and therefore very much fragile. Fact is that with enucleation, we decompress all surrounding structures, and in the same time, visualizing the arachnoid membrane, which I say holy membrane for neurosurgeon and skull-base surgeon. All surrounding important structures are not anymore under pressure and can safely be detached from the lesion. The entry zone, and we have to find the best entry zone into the lesion, should be free of arteries, venous drainage, and cranial nerves. And the brainstem dissection should be always at very end of the surgery. Key conclusion is enucleation without exposure of any important structures. I have started to change the first idea of neurosurgery, which as I started, we had always the discipline, we should go around the tumor, expose everything, and then start to remove the tumor. And I have changed this philosophy. And therefore I said, now I enter into the tumor in some safe place, enucleate, and then expose that. For example, here, this case is published in my book, is already 40 years ago. It's so-called medial sphenoid meningioma. Many people recommended we should go along the sphenoid wing, remove the anterior the clinoid forces, and try to occlude all the feeding vessels. And so now I saw that with this technique, many people rupture the carotid artery, create a lot of oculomotor nerve, and so a lot of complications. And I said, now I open the sylvian fissure, and then I go into the tumor, enucleate the tumor, and then find one vessel of the middle cerebral artery. And this is my guideline. And I follow slowly, and then remove the tumor more and more. And I have enough space. And then I come down to the carotid artery. What you can see, this operation is more than 40 years ago, published in our book. You can see today is the same is true for here, enucleation of the tumor, the sylvian fissure. You can see the tumor capsule, and you can see some branches of the middle cerebral artery here. Finally, you see here the anterior cerebral artery is the optic nerve, and here the middle cerebral artery, and here's the tumor, and we can go without pressure of this tumor to the carotid artery and expose the carotid artery completely and then remove the tumor completely. This is the philosophy. This is post-operative done MRI. Now, with interdisciplinary cooperation, we started also in 1968 with my late friend Wolfgang Graf. You see, this tumor extended to the orbit, to the skull base, and through laminar cervicalis, and here. In this case, of course, for us, it's the endoscopic approach through the nose here to removal is a fantastic technique. And we can see the patient has here exophthalmos, it's the tumor. And of course, then we have navigation system. And here after complete removal, you can see this is CT scan after surgery. Then exophthalmos was gone, and the patient is in good condition. But a very interesting development was the different modification of approaches to the anterior skull base. You can see so many variation as a frontotemporal. That is the classical frontotemporal approach, which was also Ghazi Yashar here was very interested in that. And somebody came and said, now we take the orbital roof. And the other came and said, now we take not the orbital roof, we take the zygoma and fronto-orbital-zygomatic approach. And the people then, they believe they are very good skull-based surgeons when they do all this removal of the bone. But I must tell you, there is no necessity still by temporal or still by tumor which extended in the middle fossa, anterior fossa, frontotemporal approach, only frontotemporal. Anything else is unnecessary. And of course, and for me today, you can reach all this area with a simple frontolateral approach, as you see here, and you can remove all the pathology. I will come back. There are some exceptions. For example, if you have a tumor which goes into the fossa infratemporalis, of course, in this case, you can remove the zygoma and bring it back again after you have removed. This is, believe me, it's 1% of the cases, but not in all cases you need to do this approach. But still the simple frontotemporal approach for medial sphenoid meningioma. But for bilateral approach, I have used that for many of years, but with different varieties, as you see here. But finally, I found that is not necessary to do it. And today I use for the frontal processes, I use only the frontolateral approach from one side. For clivus, I tried to use all these approaches, what you see here. And finally, in '92, together with my pupil, Professor Knoss, who was the chair in Vienna, we published then the approaches to the clivus. And also at that time, it was no man's land. And we have described advantages and disadvantages to this area. We try to optimize this surgery. I show you historically, I used frontal-temporal approach in the beginning, in the 70s, you see successfully. Dorsolateral approach also successfully, as you see. And then transpetrosal approach. And then I use even transfacial approach with Lefort-2 approach, which was also successfully, and transethmoidal approach, which also was successfully to remove such tumors and even reach the petrous apex from the contralateral side and remove it. And you can see all these tumors we have removed with these different approaches I told you. You can see this great large tumor, which I used only transethmoidal approach, here complete removal. And in this case of 9-year-old girl, I have learned a lot. That was also more than 30 years ago, although almost 40 years ago. I used here endoscope in '81, and I tried to approach this tumor just to make a biopsy and see what it is. But as I was there, I started to use diamond drill, and slowly, I tried to reach the clivus, and then I was able to remove all this tumor through an endonasal approach with the endoscope and microscope. And from that time, I have decided to use for clivus tumors only the endonasal approach with a microscope and endoscope, and I have been very successful from that time. And this is for me today, the method of choice for the clivus chordomas. That is the first choice. Of course, there are some other alternatives, but they are exceptional. The alternative, I show you this case, which I operated in Beijing in our department. And with this huge, you see, she had abducens paresis on both sides. And you see this huge tumor of the chordomas of the, with an enormous extension in both middle fossa, posterior fossa, and elevate the entire brainstem upwards. And in this case, of course, you cannot do it with the endonasal approach and remove with the endoscope this tumor. In this case, I use my experience of 6,000 approaches to CP angle. I say, okay, when I come here with a simple retrosigmoid approach into the tumor, then the patient, the girl was almost tetraplegic, and I used these floors of the posterior fossa, and that is the position of the patient for the retrosigmoid approach in semi-sitting position. I show you a little bit from this video. You see, this is retrosigmoid approach. First, I open in the inferior part in order to gain CSF and reduce the pressure. I am not going to expose any nerves and so, but I am going to go straight forward into the tumor, as you see here, and then enucleate the tumor in this area. And then slowly but surely, I cannot unfortunately show you all that. This is a fantastic video for learning how you can between the floors, you know, to go caudal cranial nerve here 7 and 8, and then here you see the trigeminal nerve. So from these floors between the nerves, I try to expose I go now to the end of this surgery because it is really long, fantastic exposure. And finally, here you can see that I can reach any part of the tumor, even in the contralateral side. And here, and I will show you now at the end with the endoscope. Here you see that around all the nerves, and so because the pressure is gone, now I can make it. Now you can see the endoscopic approach. That is 7 and 8, and then you can see then also trigeminal nerve. And here you see the third nerve, and here the tumor is completely removed. That is the brainstem, as you see here. That is the floor of the third ventricle. You can see here very well. And that is tentorium here, and that is the oculomotor nerve here. And fantastic, complete, total removal of this tumor with a simple retrosigmoid. This is the exceptional cases that we cannot remove the chordomas with the endonasal approach. That is what I wanted to show you, that we have to make some exception, but generally we can do it in another way. And you see how beautiful all the feeding vessel to brainstem has been preserved. That is the brainstem which was elevated. Okay, here you can see the preoperative MRI, and here the postoperative MRI. The brainstem is decompressed, and the patient started to walk and had now this child the normal life in Beijing. Now, meningioma of the anterior skull base, that's of course, and cellar region. Also here, frontolateral approach, I had a statistic, probably 500 cases of this. I used in the past bifrontal craniotomy, as I told you. But if you ligate the frontal sign, the frontal superior sagittal sinus, sometimes you have a lot of venous drainage, and you can create then also damage of the frontal lobe. And that is the reason that I have decided only use the frontolateral approach. And here there are no venous system, not the venous system are in midline or in the sphenoid wing. And you can see this is the classical approach for a frontolateral approach for this such a tumor. You see, we have a wonderful view to the structures. Here's the postoperative MRI. Even for such a large olfactorious meningioma, I cannot understand people who really try to destroy the entire paranasal sinuses to remove this tumor. I cannot understand their philosophy, because when you remove the entire mucosa of the paranasal sinuses in order to reach the all anterior skull base, and remove the bone and remove the dura, and so first of all, the people are disabled for all life because of paranasal. Secondly, you have a large dura defect, and with the frontolateral approach, in this case, even I use on this orbital eyebrow incision, and I could remove the tumor completely. And that is the patient post-operatively. And here, another example, this is only to show you. This was operated somewhere else. You see the frontal lobe was perfect, but they have used bilateral craniotomy, and look at that partial removal, the change of the frontal lobe because of ligation of the frontal sinus. Finally, I use, even in this case, a frontolateral approach, and then remove the tumor with a frontolateral approach. You can see here, I could remove completely. Even the carotid optic nerve was surrounded that we could remove from this approach. And this is the patient after surgery, and here MRI. In some of the olfactory nerves, if one of the olfactory nerve is preserved, then we can, from the other side, we can expose that and remove the tumor and preserve even the olfactory nerve with the frontolateral approach on the other side. And for craniopharyngioma with a different extension, I have tried all approaches for craniopharyngioma. Finally, I came to a bifrontal craniotomy, which I was successful. For example, you can see here, with even preservation of the olfactory nerve, and here complete removal of the tumor. And you can see here the basilar artery, and you have a wonderful look to the trigeminal nerve and facial nerve from anterior approach. If you enucleate the tumor, you have a space and you can dissect it. This is the post-operative MRI in this case, as you see here. Even the olfactory nerve was perfectly. And the frontolateral approach now I use only for the craniopharyngioma here in this. This patient was also from Alexandria. I can remember I operated this case with a frontolateral approach and removed the tumor completely. You see, this is after complete removal. And here, this complete resection with the frontolateral approach. And he came with me because I had a lecture in Alexandria. He came and he was then presented in the meeting. It was 3 weeks after the surgery. And I show you now here in a case of the esthesio neuroblastoma with intracranial, extracranial extension. Of course, in this case, the best what you can do, just little frontolateral approach, remove the tumor, remove the dura, and close the dura from above, and then take the endoscope and go through the nose and remove the part which is in the paranasal sinuses, and you can control your closure of the dura, and you don't need to make any closure from endonasal approach. And of course, in such a large tumors, we can use bilateral and any other approaches. I show you only that you see that we have also such cases, and we have to solve it with another very complex approach to remove these tumors. And here, post-operative removal of the tumor. And here, this tumor is completely extended anterior and skull base, paranasal sinuses, you can see orbit and so that here bifrontal craniotomy has to be used. That was the enormous extension of tumor, and we have to make the enucleation of the orbits and here remove the tumor. I think this is another story, but there are rare cases, but we are talking about tumors which are circumscribed and they have to be removed with a very delicate approach. In malignant tumors, of course, the en bloc resection is the en bloc resection was our goal to do it, and here you can see that transfacial approach and so on. This is another story, that is the en bloc resection with epithesis, as you can see. This is completely different stories in the malignant tumor. Here, transmandibular approach in this case. Interesting development of the years in the last 50 years is one of also exposure to the posterior fossa and cranial-cervical junction extended approach in CP angle, which I have developed. These all approaches you can see has been described, and I have done this really many, many times. But I give you only the summary what is today the current ideal approach for all this pathology. I was, for example, after we have lost the Transpetrosal approach and we used then the so-called Preoperative approach, I was fascinated with this approach, and I was very successful with the Preoperative approach. And here, on one example that such a tumor I use Preoperative, that is the craniotomy, you can see it. That is posterior fossa, that is the temporal area, and I went Preoperative and transect the tentorium and remove this tumor, as you can see here. And even with preservation of hearing. But we have seen that in some cases, you have to coagulate the vena flapae on some veins. And I had here two complications. One was a young doctor, 35 years old. I removed this tumor, fantastic, without any problem. 1 day later, developed then swelling and so on. We found that he's bleeding because of the venous hemorrhage, which the vena flapae was occluded, but recovered, of course, after 4 weeks. But from that time, I decided never use anymore the presigmoid approach, and I bring back to the dorsolateral retrosigmoid approach, which I use for such a huge acoustic neurinoma successfully. You can see here a patient after surgery, but I said, why I should not extend this approach? And I have then developed this system as I show you here. We have a transmeatal, suprameatal, inframeatal, and craniocervical joint. That is the extended approaches in CP angle. In suprameatal, pineal region, cave of Meckel, and middle fossa. Inframeatal is jugular foramen, petrous bone, and fourth ventricle in craniocervical junction. We use these floors, which I have described many years ago. Between the floors, you can go ventral and remove the tumor. This is a Clivus meningioma, as you see here. I use today only simple retrosigmoid approach, and here you can see the floors. That is tentorium, that is trigeminal, that is the 7 and 8, and that is the caudal cranial nerve. And between these floors, I enter to the tumor, and finally you see the tumor is completely removed with preservation of these structures. You can use that for all these type of Clivus meningioma. There is no need of any other approaches to remove these tumors. Here, that is an example again. Here, this patient was a very old patient, and I have tried here to organize a combined presigmoid approach. But as I started retrosigmoid and removed that, the way it was here open, I could go on and remove this with the retrosigmoid approach. That was a very good lesson I received from this case. But once the tumor is extended in the cave of Meckel, then of course in 1982, I have then described the resection of the petrous apex to enter into the cave of Meckel. You can see here, when you remove this petrous apex, then you have a space, and that is, you see the trigeminal. Now I show you another interesting case. That is the tumor and the petrous apex. You see, I have opened here the cave of Meckel as I opened the internal auditory canal for acoustic neurinomas. And if the tumor extended in the middle fossa, even I don't recommend to you go subtemporal, remove this tumor. Go to CP angle and then make a resection here, resection of the dura, and then finally you can bring it down, remove it without touching the temporal lobe, creating epilepsy or bleeding or something else. Here you can see after complete removal in these cases. I show you one example of the very interesting also case. This is my today, I would say, optimal approach for such a meningioma that extend into the middle fossa cave of Meckel and CP angle. Look at this extension. And in these cases, I use now simple retrosigmoid approach. You can see the tumor here again, and how I do only small retrosigmoid approach in this area, and then open the dura close to the transverse and sigmoid sinus here. And once I have opened, then I try to open the arachnoid membrane and then enter to the tumor again. I'm not going to separate the nerves, and so the nerve is here, but I go inside of the tumor first to make a enucleation here. And that is the second part of the tumor in CP angle here. Now you can see that here we achieve this. That is after enucleation, you can do that. After this has been enucleated, not before. And now we start again to enucleate this part before we go behind the tumor. And finally, you can see here that the tumor is completely removed in CP angle and always respecting the arachnoid membrane. And we come down to the petrous bone. Here. And then we remove the dura over the petrous bone. and that is the trigeminal nerve. And then we try to use the diametral and open as much as necessary. The word necessary, I never talk about 3 or quadric angle opening, and so you never know how much you have to open. And therefore and therefore it is not necessary to give any advice how many millimeters you should open. You open as much as you necessary as see it is necessary, and then slowly you will then extend your approaches. In this case, you will see in a minute that I had to remove a little bit more here because it was, and then after removing this part, and this was of course very interesting that that we are very careful, of course, of the all cranial nerve. But interesting part is you see how much tumor is in the middle fossa, which I am removing from this approach. And finally, I needed to a little bit extend the approach, and now I have to use the endoscope because a part of the tumor is not visible in the internal auditory canal, and so that I have to go and use the endoscope. And here, yeah, now the endoscope is going to show me that some part of tumor. That is the beauty of endoscope. But if you use from beginning, that is a stupid. When you have the microscope, you have to see the number. Why I have to use the endoscope and limit a little bit my activities, you know, and because I can go with the microscope much faster, and by endoscope I have to clean then the photos and so on, so that here you can see that this is the beauty of endoscope for radical removal of this tumor, which is a very good example for you as arachnoid member. And you see for you to use how to use the endoscope in these cases. And here then I feel always the hole with the fattening sponges, but I close the dura with the fat tissue and fibrin glue to avoid CSF when there is some I would say open area of the muscle, and then we can avoid that. Here you see postoperative MRI with a complete removal of the tumor in the middle and posterior fossa. That is what I would recommend to you for it. But this is another very interesting case of the arachnoid tumor cyst, I would say, arachnoid cyst, with enormous extension to the suprasellar area, posterior fossa to the both side. Also here, I use only the retrosigmoid approach. I go in this case very quickly. I believe that in arachnoid cyst, it's very important to remove the entire capsule if possible. And you see the wonderful view. That is the oculomotor nerve, and you can see the basilar artery and all the perforators here. And this is the pituitary gland. You can see here, that is oculomotor nerve of the other side. And now you see the pituitary stalk infundibulum here. And we can see then here wonderful the floor of the third ventricle. That is here we come to hypothalamus, and we can see wonderful view to the floor of the third ventricle here. That is the way that from frontolateral approach we come through the lamina terminalis and to remove the tumor, which is then extended supracellary. And here you see posterior communicating artery here, and then go to the vascular artery, and so that here wonderful anatomical here. How many I must say I was surprised how many perforators are going from the basilar artery, in this case, to the brainstem. This is the another part of the cyst, that is the abducens nerve, as you see here. And finally, this has to be also completely removed, so that again, you will have, after complete removal, you have a wonderful then view again to the entire anatomy of the infundibulum again, and this is the dorsum cellae, and that is the glandular, um, um, that is the pituitary gland, and that is the infundibulum. You can see wonderful. This is the optic chiasma and so. Anyway, this is also a wonderful case for learning the anatomy of this very delicate area. Okay. For cavernous sinus, my advice to all my colleagues is not to be aggressive. If you have such a tumor like this, remove the tumor. If cavernous sinus is infiltrated, the patient has no problem. Don't create ocular muscle problem. You can follow, and if necessary, you can then use a gamma knife for these cases. I have here this, you can see this lady had over many years had this little tumor in cavernous sinus, didn't kill him. I have this boy, 30 years I am following this now, is without any problem of this part with a huge meningioma. So my personal advice in such cases is, first, if the optic nerve is involved, you have to do the frontolateral, of course, decompress the optic nerve. There is no doubt. But if not, you go to the CP angle and remove the tumor in this area. First, decompress the brainstem, and then you can go to the frontolateral approach and remove this part which is outside of the cavernous sinus here. And you see, this was the preoperative, that was the postoperative. There was a little bit tumor around the carotid arteries, adhesion to that. In this case, I am 100. Normally, I am a radical surgeon for every tumor, but in such a case, I am a little bit conservative, and I say, this is the patient of the surgery. For jugular foramen tumors, in the past, particularly for the dumbbell-shaped tumor, I use this approach, retrocervical and cervical, transcervical, transpetrosal approach, and remove that. You see, we have been very, very successful with this technique. But I have learned, after we have learned the endoscope, to use the endoscope, I have learned that by jugular foramen tumors coming from here, extending the CP angle, we should use also here normal retrosequent approach, go here, remove the tumor here, as you see here, and then after removal of the part in CP angle and expose here the caudal cranial nerve outside of the jugular foramen, and then use the endoscopy 30 degree and look inside of here. You can remove the tuberculum jugulare by diamond drill, and then you can remove with the endoscope the last pieces of the in the foramen jugulare. And here also another example, as you see here, of the, yes, and in 2013, I have described all this technique after evaluation of 6,000 personal cases, which I have operated in that time. And in this book is 1,000 pages, which together with my pupil, Gerganov, I have published. I tried to really to bring also some examples of such a, I would say, difficult, or I would say the rare cases that they need another type of surgery, but they are really exceptional cases. My summary today for the skull-base surgery, after having more than half a surgery experiences, is my conclusion is only a few simple approaches to the skull base are really necessary to achieve excellent results in benign tumors. The approach itself should not create any morbidity. The major limitation of a skull-based surgery are the behavior of pathological entities, as I showed you in Cavernous sinus, that you should not be aggressive, and the individual surgeon experiences. If a surgeon had no experience in acoustic neurinoma, I think he cannot go and make in every case a total resection. Of course, I can accept, I cannot leave the operating theater when I don't remove completely, because I have this experience to do it and preserve the facial nerve. But then you have to stop when you are not absolutely sure or not harm the patient. I accept that, but not destroy the patient. Last but not least, the natural history of the pathology should not be better than the skull-based surgery. I think with this word, I would say, I would like to finish and add something, that the expectation today of the patient are no, in skull-based surgery, no morbidity, no mortality. And the life quality of the patient is the number one for anything what you are going to do for the patient in skull-based surgery. I thank you very much, and I hope that I was good in my time.
Thank you, dear Professor, for this excellent presentation and these concepts that we will appreciate it in our knowledge, and for sure it will give us all a huge experience that make our decisions for our patients different in the future. Now we open the questions for panelists. We can take just 2 questions.
Okay.
Is there any questions from panelists?
Yeah, can I just chip in with a question, Professor Sami? That was one of the wonderful lectures I have ever heard. And you told correctly that just frontolateral approach and retrosigmoid approach, we can deal with 99% of the benign tumors in the skull base. My question to you, sir, just tell me what are your tricks for preserving the 6th nerve in petroclival meningioma, because this nerve is pushed medially. And how do you, what is your trick for preserving 6th nerve?
Thank you very much for this question. You see, when I give such a talk, I need probably 10 hours or more than that to explain all the details for all these things. For example, abducens. I needed to talk about each nerve at least 10 minutes, 15 minutes. But your question is perfect because I have the chance now to explain. If you look to all papers, all people have described the so-called subtemporal approach to the posterior fossa, and you see the highest number of the abducens paralysis happened by this approach. And some people were proud that they have done many of the construction of many abducens paralysis. I said, this is not proudness, but how to preserve it.
The ICP really rising. But I'm sure this indication of ICP monitoring.
I want to explain to you. What is your question? May I go on or I should have stopped? You know?
I think there was some crosstalk from some other session, sir. Please continue.
I saw.
Please continue. Yeah.
I was a little bit irritated. Anyway, why the retrosigmoid approach is a guarantee to preserve the abducens nerve? Because when you come to the CP angle, the abducens nerve is compressed from tumor to the skull base, mostly, and sometimes surrounded, even all infiltrated. You know, I say all options.
Yeah.
If it is not infiltrated, if you come and you enucleate, you have the capsule. The best way is you see at brainstem the exit zone of the abducens.
Yeah.
Is that true or not?
Yes, sir. Correct.
Okay. If
Absolutely.
you see that, that is your guideline then. Then you know I follow that. I go slowly to draw lower canal.
And I'm going to talk about the historical review of.
Somebody talk on between.
Somebody else is there and he has not muted. We are very sorry for that. Sir, you can continue. Please, we are enjoying.
And then it is the same like cavernous sinus. If in dural canal the nerve is infiltrated, please leave it, the part. Don't remove that and transect the things. This is a small area, but mostly you can remove the entire tumor as with preservation of the abducens nerve. I am so happy for your question because this is one of the major problems that people have around the world. But I am always, when I am doing the surgery, the sixth nerve is for me one of the most important nerve, which I have beside of facial nerve to look for and to look after. Yeah.
Thank you, Prof. Thank you very much.
Thank you.
Professor Sami, I want to just, can you, I'm not sure if, can you hear me,
Yes,
Professor
very
Sami?
well, very well.
Okay. So I just want to say hello to you.
Oh, my
and just to say, just to say that I love to hear you always, and I hope you were with me, and I would have loved to hug you. And my dear Professor Sami, you are the mentor, you are my boss, and you are like my older brother. Thank you very much for your lifetime training, lifetime teaching. And I must tell you, if you have one real student in the world of neurosurgery, that one real student who follows your tricks and follows your style and follows your techniques without actually working with you any time in my life is the one who is talking to you, Professor Sami.
But you know, my dear Atul, because it is an open meeting, I want to tell everybody I love him. I love him from bottom of my heart. He is a very honest person, an absolutely excellent neurosurgeon. And of course, he knows I am very open to him. Whenever I was not agreeing with him was something, I told him, is that correct or not, my dear Atul?
Absolutely.
Therefore, I am happy that you are participating in this meeting. I love you so much, Atul. I am missing you so much because of these pandemics, and I hope in very close future we can take each other and
Thank you, Professor.
Thank you, thank you.
Thank you, Sir. Last question from Professor Ahmed Fouad. Please unmute yourself and ask your question.
Hello. Salam alaikum. Professor Majid Sami. I'm Dr. Fawad Pirzad from Afghanistan. Hello and greeting for Atul Girl. You remember we met in Mumbai in 2019.
Yes.
Yeah, it was great. Thank you for your nice lecture.
Thank you. Your voice.
Is there a question to ask?
No, just say hello and thanks.
Thank you.
Okay.
Thank you very much.
Thank you. Salam alaikum. Okay.
Take care of yourself in this difficult time. You know.
Okay. Thank you. Salam alaikum.
Thank you, Professor Sami. It was a great honor for all of us to have this excellent lecture. And I'd like, if you have more time, to shift to lunch to more discussion about this lecture. Thank you, Professor Sami. We will put the link of lunch in chat box. Now we will move to next lecture. Professor Abida Shah, please start sharing your screen. Thank you, dear Professor.
Thank you very much. Thank you.
Hello, everybody. Sami, can you see my screen?
It's okay.
Yes. So after this great, fascinating talk by Professor Sami, I'm going to begin with the basics of skull-base surgery. And just like Professor Goel said, he's a student of Professor Sami. I am a complete student of Professor Goel. So my talk is dedicated completely to his concepts. So I'm going to discuss today the microsurgical anatomy of the subarachnoid cisterns and how we use them during surgery. So this image that you see here is an old image of a cistern in Turkey, the basilica. What does a cistern mean? A cistern is a waterproof container that collects all the water. So they built these underground water systems in olden days to help the growth of the town and to provide water. So just like there is a water system underground, our brain has its own water system at the base of the skull. And this article by Professor Goel and Professor Kothari on the qualities of the CSF and how the CSF protects the brain. Basically, water is life. And if you understand this, you will understand the function of the brain. To understand where this water lies and the water works at the base of the brain, we will discuss the subarachnoid cisterns. To understand the subarachnoid cisterns, you have to understand three main fissures of the brain: the Sylvian fissure, the interhemispheric fissure, and this third fissure, that is the transverse fissure of Behcet. All the subarachnoid cisterns can be introduced along all these fissures. So this is the lateral view of the skull base of the brain as it lies on the skull base, and this is the Sylvian fissure. So they are at the base of the Sylvian fissure. Continuing into it is the carotid cistern, and more anteriorly the chiasmatic cistern and the laminar terminalis cistern, as we will see. And this is the anterior and posterior part of the Sylvian cistern. If you go interhemispheric, there is the interhemispheric cistern and the pericallosal cistern. And the third transverse fissure that we don't often know is the transverse fissure of Behcet that runs around the thalamus. And it actually covers the cistern of the velum interpositum and goes along the base of the skull to include all the lateral mesencephalic cisterns. It runs parallel to the choroid fissure. So if you see this is the fornix, this is the thalamus. It completely runs parallel to the choroid fissure and is a horseshoe-shaped fissure along which all the cisterns are arranged. So this is the choroid fissure. And if you see this, the choroid fissure runs like this, and the fissure, the transverse fissure of Behcet runs and goes inside under the tentorium to continue with the basal cisterns. So this is another image, and this is how it looks. See, this is the transverse fissure of Behcet along where all the subarachnoid cisterns run. So this is the velum interpositum cistern, the quadrigeminal cistern, the ambient cistern, and the crural cistern. So understanding these three fissures gives you an understanding of the subarachnoid cisterns. So this is a very, there is an image from Roton where he has listed all the supratentorial arachnoid cisterns. And you see here, this is the pericallosal cistern, the lamina terminalis cistern, the chiasmatic, carotid cistern, interpeduncular, crural, and ambient cisterns. We are going to see each one of these in details. If you look at it from the top, this is the chiasmatic cistern, laterally is the carotid, more posteriorly is the interpeduncular cistern, coming here will be the crural cistern, laterally will be the Sylvian cistern. And it is quite interesting to note that all these cisterns communicate with each other, and they form a confluence of cisterns in this region. So we start with the Sylvian cistern. The Sylvian cistern can be divided into an anterior part and a posterior part. The posterior part opens into the cerebral surface. It lies between the two opercula and on the surface of the insula. It has a lateral and a medial part. The lateral part consists of the lateral Sylvian veins. The medial part consists of the M2 branches of the MCA. Behind the Sylvian veins, just beneath it, are the M3 branches as they turn over the insular surface. In the depth is the anterior part of the Sylvian cistern, where the middle cerebral artery arises from the ICA and runs up to the Lyman insulae and becomes the M2. So this is the region of the Sylvian cistern. The anterior part, this is the posterior part of the Sylvian cistern. Just opening beneath it is the carotid cistern, as you can see here, this orange circle. And in it, you have the ICA, the bifurcation of the ICA into the anterior cerebral artery and the middle cerebral artery. It also includes the origin of the posterior communicating artery and the anterior choroidal artery. Bordered here, it is bordered medially by the optic nerve and the optic chiasm. So how do these cisterns influence our surgery? So, and basically subarachnoid cisterns are important in understanding of aneurysm surgery and in understanding of tumors like meningioma, extraaxial tumors, and epidermoid tumors, and many other tumors. We are just going to see a few examples here. So this is the lateral part of the Sylvian fissure, and this is a giant MCA aneurysm. You can see that the Sylvian fissure has been opened up completely. These are the branches of the MCA where the MCA bifurcates. You will see the bifurcation soon. That is the anterior part of the Sylvian cistern where the middle cerebral artery is just entering. So this is the bifurcation where it's becoming M2. So this is the anterior part of the Sylvian cistern. This is the posterior part. And this is the huge giant MCA aneurysm. And this is the dissection that is being carried out. The MCA is being compressed, and to see that the aneurysm is becoming less in turgor. Now a temporary clip is being applied. And you can see that the aneurysm loses its turgor and tenseness and then becomes amenable for clipping. So this is the initial clip that was placed. But because the aneurysm was still filling, the clip was reapplied. It was removed and a curved clip was then applied, as you will see soon. This is the perforator branching of MCA, which is being preserved. And this is the clip that is being applied. The aneurysm is then, the temporary clip is removed. Now you can see that both the branches of the MCA at the bifurcation are filling, and then the aneurysm is decompressed and confirmed that the clipping has occurred successfully. So going further, this is another video which shows the anatomy of the posterior part of the Sylvian cistern. And this is a bypass that is being performed by Professor Goel. So this is the anterior part of the Sylvian fissure which has been opened. And now you can see these vessels, the M3 branches in the lateral part of the posterior part of the Sylvian cistern. This is the graft being prepared. And these are the initial sutures that are being taken. This is the radial artery graft. This is the heel stitch. And this is the anterior wall that is being completed. And now going on to the posterior wall, you can see that the anterior wall has been sutured quite beautifully. You will see in a minute. And that is the lumen of the vessel. And now the posterior wall is being sutured. And this is the complete suture. And you can see after releasing the clip, the good flow through the bypass vessel. There you can see blood that is coming out with a very good flow. And then the neck anastomosis is being carried out. And this is the vessel after completion of the neck and the intracranial anastomosis, and that is filling beautifully. This is just another short video to show the carotid cistern. So this is a paraclinoid aneurysm. This is the anterior region of the anterior clinoid process. And this is in the region of the carotid cistern arising from the ICA. So the ACP is going to be drilled now. And the ACP is completely drilled and then removed. It's being scooped out. And this is the neck of the aneurysm. It's a giant aneurysm. You can see this is the optic nerve. So this whole region, the whole aneurysm is actually occupying the carotid cistern and compressing the optic nerve. You can see how pushed it is. And after the aneurysm is clipped, you will see how the optic nerve is released. So this is the neck of the aneurysm that is being dissected. And a clip is being applied at the neck of the aneurysm. And then the aneurysm is maneuvered and punctured to confirm that the clipping is appropriate. There the aneurysm wall is now punctured, and now you see how the optic nerve is relieved from the pressure from the aneurysm and is now lying completely free in this region. This is the optic nerve, and this is the entire aneurysm that has been clipped. Going further, so we've seen the sylvian and the carotid cisterns. Coming more medially, so this is the region of the carotid cistern, this blue one that you can see. This is the ICA, this is the MCA, and the origin of the anterior cerebral artery. The next cistern that comes is the chiasmatic cistern, and it is bordered by the optic nerves, and posteriorly it is bordered by the diencephalic leaf of the liliquist membrane. Here in this region, you can see the pituitary stalk, and the chiasmatic cistern is separated from the carotid cistern by a medial carotid membrane, but there are multiple perforations through which branches of the ICA enter into the chiasmatic cistern in this region. So during surgery, there will be an arachnoid membrane here, which you will have to go through to enter the chiasmatic cistern. Just above the chiasmatic cistern lies the lamina terminalis cistern. And you see this region. It is the floor of the cistern is formed by the optic chiasma and the lamina terminalis. And the roof is formed by the gyrus rectus and the paraterminal gyri. And the contents of this cistern are the A1 branches of the anterior cerebral artery, the ACOM, and the A2 as they enter and go upwards to enter into the pericallosal cistern. So the most common pathology that we encounter where the chiasmatic cistern comes in the picture is this, a tuberculum sellae meningioma. And I will just show you a short video. So this is the subfrontal approach that Professor Goel uses that we have learned from him. And I think Professor Sami also has been advocating this approach. And this is the subfrontal approach. You can see that the retractor is being inserted, and this is the opening of the sylvian fissure, which leads to the release of the CSF. And this causes a relaxation of the brain and thus allowing a better entry into the tumor. So here you can see the sylvian fissure is being completely released, and the carotid cistern is also being opened. So tumor surgery, arachnoid aneurysm surgery is all a game of the cisterns. If you understand the anatomy of the cisterns, you know which one you have to open, which one you will be entering, which vessels and which nerves are there, which you have to preserve, because cisterns basically contain the vessels and the nerves. So this is the meningioma, and it is being disconnected at the base. I'll not go again. Here you can see the optic nerve and how the tumor is completely involving the optic nerve. Here you can see the ICA and the carotid cistern being opened. I'll just go to the end of this. And here you can see that the tumor is being separated from the optic nerve. This again is being performed by Professor Goel. So the tumor is being dissected completely, and you will come and see the chiasmatic cistern in this region. Now you will see the pituitary stalk. This is the optic chiasm. This is the optic nerve on the opposite side. This is the arachnoid membrane. You can see this. This is the diencephalic leaf of this liliquist membrane. This is the pituitary stalk. And as you enter posteriorly, you will be able to enter the interpeduncular cistern by opening the mesencephalic leaf of the liliquist membrane. So this is the anatomy of the chiasmatic cistern, as can be beautifully appreciated in this video. So here you can see the third nerve coming out of the interpeduncular fossa. So This is our papers on skull base meningiomas and how the cisterns have influenced the surgery. Going further, so coming to the lamina terminalis cistern, as I showed you earlier, the constituents are the A1 of both sides, the ACOM and the pericallosal arteries, A2 as they enter the pericallosal cistern. Also, the recurrent artery of Hübner starts in this cistern and exits. This is another video of an ACOM aneurysm. I will just show you the end because otherwise we will run out of time. You can see this is the lamina terminalis cistern and all the perforators in this region as they are being dissected. This is the aneurysm here. And this cistern has a lot of important vessels with a lot of perforators on the posterior and the medial walls of the vessels. And here the aneurysm has been clipped. And we'll go further. Now coming to the other cisterns, this is the olfactory cistern and this is the lamina terminalis cistern. So if you see the relation, you see how these cisterns open into each other. So this olfactory cistern is related to the carotid cistern here, which opens into the sylvian cistern. This is the lamina terminalis cistern, which goes anteriorly, superiorly, and enters the pericallosal cistern. And how the carotid cistern communicates with the interpeduncular cistern in this region. This is the whole circle of Willis. And this area is called the confluence of cisterns, as I will show you. And this is a huge olfactory groove meningioma, again removed by the subfrontal approach, understanding the anatomy of the cisterns and its relations. This is just an anterior view showing how the cisterns communicate with each other around the chiasm and form and confluence. This is further dissection in the region of the lamina terminalis cistern to show the various branches of the ACA, the orbitofrontal artery, the frontopolar artery, as they come out of the lamina terminalis cistern. Coming to the pericallosal cistern, it begins in this region. It is divided into three parts: an inferior part, an anterior part, and a superior part. The inferior part lies below the rostrum. The superior part lies at the genu. The anterior part lies at the genu, and the superior part lies on the body and the splenium. This has the A3, A4, and A5 parts of the pericallosal artery. The anterior one has the A2, A3 part, and the inferior part has the origin of the A2s. So this is an interhemispheric approach being used to approach a pericallosal aneurysm. So we have seen most of the aneurysm in the supratentorial space. We have just to see the basal cisterns and the posterior fossa cisterns now. So this important anatomy that you have to understand is that of the liliquist membrane. The liliquist membrane has actually got two leaves. So you see this yellow circle here and this orange circle here. The yellow one is the diencephalic leaf and the orange one is the mesencephalic leaf. The diencephalic leaf runs from both of them originate at the dorsum sellae. The diencephalic leaf goes up to the mammillary body and the mesencephalic leaf goes up to the midbrain, junction of the midbrain and the pons. The mesencephalic leaf has a perforation where the basilar artery enters through it. The diencephalic leaf generally does not have any perforations, and it actually is a tough membrane that separates the chiasmatic cistern from the interpeduncular cistern. So if you can understand, all the cisterns meet laterally at the confluence, whereas in the midline, the chiasmatic cistern is separated from the interpeduncular cistern by this diencephalic leaf. So this is just to understand, show you the anatomy. This is how the leaves come to the mammillary body and to the junction of the midbrain. And this is the region of the interpeduncular cistern. And here you can see these membranes. This is how the arachnoid. Arachnoid actually is a web-like structure. And this image clearly depicts the web-like structure of the arachnoid. This is actually the diencephalic leaf of the liliquist membrane. Here also you can see more better. And this is the interpeduncular cistern, which has the origin of the basilar artery and the posterior cerebral artery, the P1 portion, and where the PCOM joins. After that, it is P2 as it enters the crural cistern. So this area is actually the confluence of cisterns. So the basilar artery gives multiple perforators from its back wall as it enters into the brainstem. This is an image that shows the mesencephalic leaf. So diencephalic leaf I showed you earlier. So this is the mesencephalic leaf of the liliquist membrane. And once you go through that, you will enter the interpeduncular fossa. This is the oculomotor nerve, and this is the basilar artery. Coming to the lateral mesencephalic cistern, this is the crural cistern. This is the ambient cistern. The crural lies between the cerebral peduncle and the uncus. The ambient cistern lies between the posterior part of the cerebral peduncle and the posterior part of the uncus and parahippocampus. It ends into the quadrigeminal cistern. and its constituents. So this is the image showing the depth of the cisterns, and the constituents of these cisterns are the P2 of the crural cistern and the posterior part of P2B in the ambient cistern. And it gives rise to various perforating branches. So the middle posterior choroidal originates from P2 here and goes all the way posteriorly to enter the quadrigeminal cistern. These are branches that enter into the temporal lobe and the posterior part of the atrium, the lateral posterior choroidal arteries. And this is an operative view showing the communication of the chiasmatic and the interpeduncular cistern. This is a view from a subtemporal approach showing the crural and the ambient cistern. This is the part where just after the PCOM, where it is in the crural cistern of the posterior cerebral artery, and this is where it is in the ambient cistern. And the other constituent of the ambient cistern is the trochlear nerve as it goes on to move to the tentorial edge. So again, this is an epidermoid that is present in the crural cistern, and this was approached by a supracerebellar transtentorial approach as has been advocated by Professor Goel. This is again another video. I don't think I will have time to show the whole thing. Just I will show you some bits. So this is the tent being opened and the epidermoid that you see in this region. And the epidermoid is being resected, and clearly you will enter the ambient cistern. Here it is being separated from the various vessels. So this is an approach to the crural and the ambient cistern from the supracerebellar window and opening the tentorium. This was published by us in 2011. Then there is the oculomotor cistern. So as the oculomotor nerve enters into the cavernous sinus, it carries with it a dural cave. This was also described by Professor Goel. And around the dural cave, there is also an arachnoid membrane which enters the oculomotor system, which enters the roof of the cavernous sinus. And that arachnoid membrane covering the oculomotor nerve is the oculomotor cistern. And as I told you, you see this whole region, how the subarachnoid cisterns all meet to form a confluence of cisterns, the chiasmatic, the carotid, the interpeduncular, the crural, and the ambient. And here is the lamina terminalis cistern. Going to the posterior fossa cisterns, the first one here is the velum interpositum cistern, which lies in the roof of the third ventricle between the fornix and the layers of the tila choroida. It opens into the quadrigeminal cistern, as you can see here. These are the leaves that form the roof of the quadrigeminal cistern, and this is the quadrigeminal cistern. As you can see it more clearly here. So the posterior wall is formed by the superior and inferior colliculi, and this is the pineal body. Here, this region, this entire region forms the quadrigeminal cistern in the region of the supracerebellar space. This is a pineal epidermoid that I had operated. And I will just show you the end of the video to see the anatomy. Here, this is the quadrigeminal cistern. And
1 moment. 1 minute, Abby.
Okay. And this is the end of the video showing the beautiful anatomy of the quadrigeminal cistern. So just quickly, I will show you the anatomy of the posterior fossa cisterns. This is how the cisterns influenced epidermoid surgery. Posterior fossa cisterns are, this is already, we have seen the interpeduncular cistern. This is the prepontine cistern, the premedullary cistern. Going further, this is the cerebellopontine angle cistern, as you are all familiar with. So this is the fifth nerve, this is the seventh, eighth. So this region is the entire cerebellopontine angle cistern. And some tumors that lie in this cistern are endodermal cysts that you can see in this image. This is a posterior fossa petroclival meningiomas, which can be approached by depressing the cerebellum and going through a supracerebellar approach and entering into the cerebellopontine angle cistern. This is an intraoperative image showing the cistern. And lastly, the cerebellomedullary cistern that comes in this region, and it is occupied by the glossopharyngeal and the vagus nerves and the parts of the vertebral artery and the pica as it emerges from there. So this is the region of the cerebellomedullary cistern. And this is one of the most important steps that is being performed to release the CSF while performing a surgery in the posterior fossa. And the cisterna magna, the last of all the cisterns, where it lies on the dorsal surface of the medulla and it communicates posteriorly with the posterior spinal space. It has the pica and the brainstem in this region. And how we use the cisterns for surgery is basically for foramen magnum tumors, where understanding the anatomy of the cistern gives you an advantage and makes you use the conventional posterior fossa midline approach for foramen magnum tumors, as again has been advocated by Professor Goel. So that concludes my lecture. Thank you very much.
Thank you, Abby, for this nice lecture. I will, for just sake of time, we can't take any questions. Please go to lunch if there is any question for Abby. Now, next lecture will be Professor Ayub Shiran. Please start sharing your screen. Thank you.
Can you hear me, Same?
Yes, it's okay.
Yes, I am sharing my screen. Thank you, Abida. And I was hearing Professor Sami and Abida talk. It's a brilliant, brilliant talks. So here we'll be dealing with anterolateral approaches. And we'll first show you a little bit of basics of skull base. Why skull base? So that's what we're going to do. So the whole purpose of doing a skull base approach, especially the anterolateral approach, is to get between the folds of the brain. The brain is folded in two planes. That is, one is in the sagittal plane and another is in the axial plane. So to get to the base of the brain, you must do first a sagittal unlocking. So that is something that we do. Usually, that is drilling off the sphenoid ridge, taking off the anterior clinoid process. All this, if you keep doing that, what you're doing is you are unlocking this frontal temporal lobe like that. That is a sagittal unlocking. So this makes it easy to get into the structures at the base. So this is sagittal unlocking. And this, what we do, other than this, extradurally, is the axial unlocking. Axial unlocking is pulling back the temporal lobe, away from the cavernous sinus, and therefore getting space into the interpeduncular cistern of the suprasellar, interpeduncular part of the suprasellar, posterior part of the suprasellar cistern. This was the temporal lobe. You pull this temporal lobe out and you get space into the posterior part of the suprasellar cistern. So this is called axial unlocking. You have sagittal unlocking and you have axial unlocking. These are the two extradural unlocking, while the intradural unlocking is the Sylvian fissure opening. So that I call it the oblique intradural unlocking. So if you have sagittal unlocking, axial unlocking, and you combine it with oblique intradural unlocking, you have a huge, huge corridor. The frontolateral approach, as Professor Sami had said, you have a huge corridor with these approaches. So this is a schematic made by Voralux from Thailand. So we are, when we do the axial unlocking, we try and preserve, we do it pericavernous rather than transcavernous. Transcavernous, we will have to inject fibrin glue and everything, but we go mostly pericavernous. So once we go pericavernous and open the dura, this is what you see. This is the optic nerve, this is the carotid, this is the third nerve, the fourth nerve, and then the V1, V2, V3. So once you uncover the third and the fourth nerve, you can see the membrane of Lilliquer's PCOM, and then you can see the basilar there, superior cerebellar there. So this is the basis of the anterolateral approach. So we will see in dissection as well as in certain cases how this knowledge is going to be used. So you can go into different corridors. You can go into the corridor between the third and the carotid, or the third and the fourth, or the fourth and the V1 to access different segments of the cavernous sinus whenever there is a need. But we were talking till now about transcavernous approaches, using cavernous sinus as a highway and using cavernous sinus as a destination. So both can be done through the anterolateral corridors. Now, we have described the carotid as a series of horizontal and vertical segments. So we have named the vertical segments as odd numbers. So this vertical segment is C3, this vertical segment is C5, and this vertical segment is C7. In other words, the paracellular carotid is C3, paraclavial carotid is C5, and parapharyngeal carotid is C7. So horizontal segments are odd, even numbers. So C6, petrous, and C4, horizontal intracavernous. Okay, so it's very easy to remember. C2 is intradural, then C3, C5, C7. They are vertical segments, paracellular, paraclavial, paracarotid. Parapharyngeal. And horizontal segments which join them, that's a petrous horizontal segment and the horizontal intracavernous segment. So between C4 and C5, you can see the infralateral trunk just over the sixth nerve. And at the junction, you will see the meningohypophyseal trunk. Okay, these are the two trunks that are important. The other important things are the cochlea. The cochlea, the C7 passes anterior to the cochlea. The GSPN passes parallel to the petrous carotid. And it becomes the Vidian now. So you have V1, V2, V3 here, and you have the pectoralingual ligament medial to that. You have 3 and 4th going into the superior orbital fissure, and you have the second nerve there. So different triangles between different cranial nerves, you can access different segments of the carotid. So for example, so we are going to show that in the dissection now. So that is the orbit, that is the orbitomeningeal band, that is the temporal lobe, that's a frontal lobe. So we are under very high zoom. The orbitomeningeal band connects the frontal and temporal lobe to the orbit. So to disconnect or to start your axial unlocking, we must cut the orbitomeningeal band. And if you cut the orbitomeningeal band, you will be able to do the axial unlocking and also unlock a small structure which is very useful, that's a clinoid. Okay, so you're going to cut. First, this is the superior orbital fissure. The temporal lobe has been pulled away from the cavernous sinus, and the true cavernous membrane is preserved so that there is not much of a bleeding when you do that. You're cutting the orbitomeningeal band now. And once you cut the orbitomeningeal band, that is a clinoid taking place. That's the clinoid taking shape. Now you don't have to drill the clinoid like you're drilling a tooth or something. You have an excellent lateral view after doing this approach, after doing axial unlocking. You have excellent view of the clinoid. You will see that now. And that is a clinoid. Now you can remove the clinoid after separating it from the cavernous sinus roof. That's a third nerve there. The fourth nerve will come and cross the third nerve. So after separating it, you can remove the clinoid. So you are removing the clinoid, and that's a cavernous sinus roof. And the carotid artery, the carotid oculomotor membrane, which covers the carotid artery. And that is the second nerve. And this is your optic strut. So this is your optic nerve. This is your carotid clinoid triangle. That is your third nerve, fourth nerve. And so generally we don't remove it with this. We drill it out. And so you can see the V1, the fourth nerve, and we will go to the triangle between the fourth nerve and the V1. You will see the C5 carotid, and the C5 carotid is there. That's the paraclival carotid, and you can see the sixth nerve there. This is the sixth nerve. Okay, this is just 2 days before we were in this region. So that is the sixth nerve. This is the sixth nerve. So you can see the V1, and this is the window between the fourth nerve and the V1, and that is the sixth nerve. Okay, I am just mobilizing the sixth nerve into. It's parallel to the vertical segment of the carotid. This is the C4 segment will be here, the horizontal segment. So the meningohypophyseal trunk is going to be here, and the infralateral trunk is going to be coming above the sixth nerve, like that. Okay. Now we come back. This is the clinoid triangle. This is the Parkinson's triangle, and that's optic nerve. The third nerve, fourth nerve overtakes the third nerve at the superior orbital fissure. We have the V1, and now you're going behind the V3. So this is the Gasserian ganglion. This is the V3, and we are going behind the V3, and you have drilled. This is the Kawase triangle, which is drilled, and you can identify the carotid there. Once that's a carotid canal, I am putting my dissector, dissecting the carotid a little bit medially, and you can start, after this, you can start drilling the Kawase triangle. So you can drill the Kawase triangle. Once you get the carotid, you know where your lateral limit is. It's very easy. So your medial limit is, of course, you should not hurt the cochlea. Your medial limit your lateral limit is the carotid. So you can drill anteriorly. You can make I've seen a lot of people making very small Kawase triangles. That is not very useful. But if you have a Kawase which is quite large, I know that maybe if you are good in one approach, you really don't need many approaches, as Professor Sami said. But you need to be good in one approach. It is very important. And of course, one of the things that you have to realize is, as young neurosurgeons, we have to have so many failures to succeed. So many failures. This is the secret. More than any approach, one of the things that you have to understand is when you are going beyond what normal people are doing, people are bound. They are bound to look at you and to mock you and to say things that are not very pleasant about your approaches, and they will not accept you because you cease to become one of their own pack, and the pack is usually defined with mediocrity. So it is, at that time, if you lose your heart, and then whatever approach you are going to do, whatever tumors you're going to take out after 2 or 3 failures, if you decide that this is the end, then you're not going anywhere. So if you ask Professor Sami or Professor Goel, or even in my short career, if you ask me the number of successes, I'll first tell you the number of failures we've had. Okay, the number of heartbreaks and the number of problems we have faced when you are going with an approach which is a little above, or which is a little more than what others will do in that particular stage. Okay, so the failures, slowly the numbers of the failures come down, and I hope at least in my next 10 years, my number of failures come down as much as Professor Goel or Professor Sami. And this is something that I can look forward to, because even these giants, their their failure rates come down because they at the end of a few failures and few lessons, these people are giants because they learn and they move on from others' lessons. This is what we try to do. We try to emulate. So we have now, while we were talking, we have now that's a carotid, that is the Kawase triangle, that is the posterior fossa dura outlined. Okay, and then we are going to open up. So that is the pons posterior to the fifth nerve. Pons posterior to the fifth nerve, up to the eighth nerve. You'll see the eighth nerve very soon. So that is the fifth nerve. This is anterior to the fifth nerve. Okay, and this is the superior orbital fissure. Going to the superior orbital fissure. This is the clinoid triangle. This is the vertical carotid. The horizontal carotid you saw here. So, and you can see the entire panorama. Second nerve, third nerve, fifth nerve, and eighth nerve. Okay, that is the seventh nerve there. That is the seventh nerve. That is the fifth nerve there. Okay, the seventh nerve. And now we are showing you exactly the same anatomy. That is the optic nerve. That is the carotid. And we are opening the membrane of Lilliquist there. Okay, opening the membrane of Lilliquist. And that is the basilar. That is the superior cerebellar. And that is the P1. There is an aneurysm there. Backward pointing basilar. Okay, so we are going to deal with it. We are slowly, no proximal control, slowly going to dissect it away from the P1. Okay, dissect it away from the P1. There were times when we used to drill the posterior clinoid, get proximal control, but these days with regulation of BP, these are all ruptured aneurysms. These are unruptured. These are not unruptured aneurysms. So with regulation of BP and prudent use of cardiac arrest, we're using adenosine. There's no need for temporary clip these days. Okay, earlier we used to have posterior clinoid drilling and temporary clip placed on the basilar. These days I don't need it because I can always ask my anesthetist to give me 1 minute arrest. If using adenosine is a very, very useful technique. Okay, so now I've got enough space between the P1 and the basilar tip aneurysm. So it's a posteriorly pointing aneurysm. Got to be very, very careful about the perforators. So you dissect that space and take your time. There's no hurry. There's no train that you are going to miss if you are a bit slow. In fact, you're going to miss the train if you are a bit fast. That's the thing about aneurysm surgery. So you dissect very slowly, and then slowly you put a clip, and that's it. So then you examine everything. The clip is put, P1 is there. Okay, so the basilar tip is there. The basilar trunk is there, superior cerebellar artery aneurysm, superior cerebellar is there. There's another one, same approach, and this is fusiform basilar aneurysm. It's a very big basilar aneurysm. That's the third nerve, so you can see the aneurysm there. It had ruptured, so you can see that the PCOM comes. There is literally no P1, that is P2. So you can see the this is the P1. Okay, the same thing that you are seeing here. You will see now that is this is the aneurysm. So you will now see the same thing in the same anatomy. You will see. So that's the third nerve. That is the aneurysm. I am going to bipolar it a little bit. Okay, bipolar it a little bit so that it shrinks and I can put a clip on this. That is the P1. And that is a basilar trunk. This is another video of a cavernous sinus dissection. So this is pericavernous dissection, as we told. If we are doing for just temporal lobe unlocking, we don't need to inject fibrin glue and everything. So you just need to do a pericavernous dissection. For example, for cisternostomy, when I was doing it, there was no need for there was no need for any fibrin glue injection. So we are going to do a so this is temporal lobe. I'm disconnecting it off from the cavernous sinus, taking off the clinoid process. And once I take off the clinoid process, you can see the optic nerve and you can see the cavernous sinus here. The cavernous sinus is clearly defined here. And so that's the entire cavernous, that everything is cavernous sinus. I'm peeling off the temporal lobe, peeling off the temporal lobe. So that's the cavernous sinus going into the superior orbital fissure. That's the cavernous sinus. So this is without tumor. So this is for temporal unlocking so that I can get a very good access into the posterior fossa structures like an aneurysm or any other tumor in that region. So this is intracavernous surgery. So you can see the cavernous sinus, we are going in between the fourth and the V1. So this, when you go between the fourth and V1, this is the C4 segment and the C5 segment. So that is what you're going to see. So this is the fourth nerve, this is the V1 segment, and that is the vertical segment of the carotid, the meningohypophyseal trunk dividing into two. So that is we are clipping off a large meningohypophyseal trunk here. So that is the V1, the fourth nerve is here. So I'm clipping off the meningohypophyseal, okay, which was supplying a dural AV fistula at the superior petrosal sinus region. So I am first clipping off those meningohypophyseal trunk intracavernous so that you can see the posterior margin of the vertical carotid and these two arteries, it's clipped off now. Now, one thing about additional thing
2 minutes time.
Okay, I will finish. So this is the PCP dura. It is being exposed between the optic nerve and the carotid and these two perforators. So we can go ahead and drill the PCP dura. And this is something that we did a few days back. It's an intracavernous component of a large pituitary tumor. We take that out and then we go, next week we go from the endonasal route to take out the rest of the tumor. So this is the cavernous sinus being unroofed. This is the cavernous sinus full of tumor actually. So we unroof the cavernous sinus and then go between the third carotid and the third nerve, and so that is the third nerve. So the third nerve is completely open from intradural to extradural, everything. And this patient does not have any eye movement deficits. Okay, so this is something that everybody says, oh, you open the cavernous sinus, you will have, but you do it under the highest zoom possible, and you try to be gentle with these nerves, then you are not going to have the eye movement deficits. Okay, so this is opened out and completely emptied out. So it's under extremely high zoom. This is the entire thing is the third nerve, and the third nerve window between the third and the fourth nerve is also opened. Okay, the third nerve is completely opened out, and now we are opening the third nerve from intradural to extradural compartment completely, and they're taking out that tumor in the lateral. So this is between the third nerve and the fourth nerve. So that is between the carotid, that is between the carotid and the third nerve. So this is between the carotid, the third nerve and the fourth nerve. This is the fourth nerve. You can see the fourth nerve there, preserved by that membrane. Okay, so that membrane has to be kept, and then you open, and then you can go between the fourth nerve and the V1. So I guess I'm running out of time. So you can see the horizontal carotid below the third nerve. You can see that is a horizontal carotid. Tumor is being taken off the horizontal carotid, and after that you can see the C4 C5 junction is down there. So you have taken out all the tumor from the lateral segment, which is difficult for me to get via the endoscopic route, and then after that I will go and take out the endoscopically the rest of the tumor. Thank you very much. I hope I have finished in time. So any comments or questions? Welcome.
Thank you, dear Bo Ayib. We will allow just one question from panelists. Okay, if there is no questions, please shift to lounge to meet Professor Ayib. And if you have private questions, we will shift now to next speaker, Professor Baskaya, who will give us his lecture about transpetrosal approaches for skull-based lesions. Please, Professor, start sharing your screen. Thank you.
Good morning, good afternoon, good evening. Same, thank you very much for invitation and having me and organizing this committee. And thanks to all the distinguished panelists and the participants and in the weekend joining this and making time. I was going to talk in general the all transpetrosal approaches, but then listening the Professor Cherian's talk, I think I should skip the anterior transpetrosal approaches and focus more on the posterior transpetrosal approaches. So I'm consultant. This is our Lovely City Medicine. We welcome everybody. And in general, transpetrosal approaches are anterior. We devise anterior transpetrosal, posterior, and combine. And there are so many combinations of these approaches, modifications. So I'm just going to focus on the simple ones and simple classification. How do we select these approaches? In what cases we do? We like to devise clivus in quarters. So upper quarter, second quarter, third quarter, and the lower quarter. And then the lesions fall into the transpetrosal approaches, usually located anywhere between upper first quarter to the third first quarter. And the cranial nerves make these quarters, actually. If the lesion is located in the upper 1/4, combination of any combination of cranio-orbital approaches with the transsylvian middle fossa subtemporal approaches or transcavernous approaches, as Professor Cherian demonstrated, anterior transpetrosal approaches, or combination of these. Second quarter, usually again the anterior petrosectomy or posterior transpetrosal approaches combined with the middle fossa or retrosigmoid, and we are not going to focus on this in my talk today. As well as normal anatomy, you need to be aware of the pathological anatomy, disturbed anatomy by the pathology. That's also important in decision making. Please consider that, because anatomy changes by the pathology. Again, Professor Cherian elegantly explained, I saw his drilling the Kawase, so I'm not gonna spend more time. Just few words about Kawase or anterior transpetrosal approach is very limited if you use only pure Kawase, and then the different from pure middle fossa to Kawase or extended middle fossa, you have to be a little more generous with your incision and exposure. And pure Kawase rarely we do in my practice, but usually I combine with the transcavernous approach and then adding the drilling of the anterior petrous bone. So this is the craniotomy you need for if you are doing just middle fossa approach. This is good approach for small intracanalicular acoustic tumors or tumors of the facial nerve, hemangiomas or schwannomas of the facial nerve in the canal or in genital region. If you extend this approach to the Kawase combined with, you have to do a larger craniotomy, frontotemporal, and combine with the transcavernous approach. Proper dural elevation is the key. and locating the anatomical landmarks is very important, and anatomical landmarks in this location varies from case to case, so be aware of it. And at the end, you need to get this kind of exposure, exposed to all three divisions of the trigeminal nerve, GSPN, geniculate ganglion, arcuate eminence, cochlea. So you have a wide exposure, and you can drill the Kawase. Kawase quadrangle or triangle or petrous apex is just located between cochlea, GSPN, and the Gasserin ganglion or V3, and then medially the superior petrosal sinus. When you are drilling, you need to be aware of the variations of the petrosal ICA. Sometimes this is not covered by the bone, so and then it is just located medial, almost, it's kind of parallel to the GSPN petrous ICA, and you can use that for different purposes if you need to. When you cut the superior petrosal sinus, again, you need to be aware of the venous variations. And I'm gonna skip all these and just show one case to utilize the combined middle fossa, extended middle fossa approach. This is a 58-year-old woman presented with this lesion, is consistent with the appearance, is consistent with the chondrosarcoma. So this is a perfect case for extended middle fossa approach, transcavernous, and extending to the petrous apex. Position is spine and the large frontotemporal incision and nice sizable craniotomy. And again, the same principles demonstrated earlier, cutting the meningorbital band, using this dissection plane and exposing all these cranial nerves from oculomotor to the V3, Gasserin ganglion, taking the clinoid process and gradually moving and more medially towards the Gasserin ganglion. Here is the middle meningeal artery is tethering us. We're gonna coagulate and divide that, and then be aware of these anatomical structures and the anatomy. You have to spend some time in the lab to understand this, and then extending more, getting the arcuate eminence, getting the GSPN, stimulating the geniculate ganglion is a good confirmation of the where you have the geniculate ganglion and the GSPN. High stimulation of the facial nerve, like a 0.2 to 0.3 milliampere, and we go more medially, keep dissecting, and then eventually working under the V3 trigeminal impression and extending this and being parallel to the nerves and localizing the carotid artery and working between nerves, getting this soft, nice to remove tumor. Chondrosarcomas are you get the pleasure of removing, and then drilling the petrous apex or Kawase triangle, and getting the part going more towards the clivus. So this is, we are moving under the trigeminal nerve, and the petrous carotid is right here, working under this structure towards the clivus all the way to the hypoglossal canal. So not only removing the soft part of the tumor in this chondrosarcomas, is also important to remove the disease bone with the bone CUSA, bone ultrasonic aspirators, or drilling, because sometimes there are nests of the tumor within the bone. You don't realize that. So, and this is the roughening up with the drill, diamond drill. It hemostasis the bone, and same time gets rid of all that small invisible remnants in the bone. And then finally the closure, and we put endoscope as well, get the endoscopic view if you are missing anything, so we can remove the small remnants and then put the fat and fascia to close. You see the petrous carotid was right there and then close. And this is completely extradural approach. And you don't need to do any intradural work. Patients feel much better after extradural approaches. This is pathology was grade 2 chondrosarcoma, and patient did very well. A similar patient, more extensive chondrosarcoma, can be done same way. This video nicely edited by my former fellow, so who's also from Egypt. So it is as same way, same things, identifying and getting the tumors. This is a part of the tumor intradural, so we'll get intradural part after cutting the superior petrosal sinus. So I'm gonna skip these parts, and you can get these results. And this is our cases, how to utilize the extended middle fossa approach, combining transcavernous and again trigeminal schwannomas are the perfect case for these. This is an elderly patient with the very symptomatic from this trigeminal schwannoma. Perfect cases for extended middle fossa approaches, and I'm gonna skip that too. So very versatile approach, and I know Professor Cherian and maybe previous speakers mentioned that, you know, you get the at least one approach. And on the contrary, my recommendation, be versatile with all these approaches and choose your own approach for each case. Be good in one, but be aware and versatile with the others. So posterior transpetrosal approach, the whole idea of what retrosigmoid cannot provide, getting more ventral to the brainstem, okay? The goal, more bone you drill, more ventral you get towards the brainstem. That's the whole idea. And most of the lesions we use for posterior transpetrosal approaches are the approaches, the lesions that located in the petroclival junction. So I know there are many variations, many different combinations. To simplify these, you need to understand these are all presigmoid approaches, okay? They are not retrosigmoid approaches. So you may drill the bone in retrosigmoid area to mobilize the sigmoid sinus, but this is nothing to do with the retrosigmoid approach. These are purely presigmoid approach. In retrolabyrinthine approaches, you remove the bone, mastoid bone between sigmoid sinus and the semicircular canals anteriorly, and you expose the Troutman's triangle and the superior petrosal sinus, jugular bulb, and little bit the middle fossa plate. And if you drill more bone and take the whole labyrinth, is translabyrinthine approach. The risk of doing this is hearing loss if patient doesn't have the hearing loss already. And this is perfect case, perfect approach for the patients who have no serviceable hearing. Transcochlear approach, you go furthermore anterior, expose the petrous carotid, take the whole mastoid and expose the facial nerve, and you are taking the bone, periosteum, over the facial nerve, which kind of devascularize in order to mobilize the facial nerve. So transpose the facial nerve. There fallopian bridge technique, you can leave the bone, but I'm not going to talk about that right now. But the price is patients invariably wake up with the facial nerve palsy. They improve best to the grade 3. So this is good approach if patients already lost facial function. Okay, and then you combine these with any approach. You need it. Okay, you can combine with the far lateral, you can combine with retrosigmoid, you can combine with the middle fossa subtemporal, whichever needed for that particular case. Okay, so now I'm going to talk about the combined posterior transpetrosal approach. Retrolabyrinthine, you kept the labyrinth intact, and you are combining with the middle fossa, cutting the superior petrosal sinus and the tentorium. This is a good approach for middle quarter and the third quarter of the clival lesions, middle fossa, cerebral pontine angle. It gives you more lateral, anterolateral exposure to the of the brainstem, but it is very limited approach. So translab, you drill more, it gives you a more anterior approach. Like we said before, price is the hearing loss if patient has a good hearing. Transcochlear, you mobilize facial nerve. Price is the losing the facial function if patient has a good function, at least temporarily, but gives you the best anterior exposure, much wider exposure, but is quite morbid approach. And position for these approaches, we like to do in spine position, maybe a little bit shoulder bump, large C-shaped incision, retroauricular, and elevating the temporalis muscle and paravertebral muscles, exposing the anterior bony landmarks, and then not relying on the asterion is an important thing, and doing the simple mastoidectomy, starting with the simple mastoidectomy first, finding the mastoid antrum. That will help you to locate the lateral semicircular canal. Lateral semicircular canal will help you to locate the facial nerve. And then this is the final product, a little bit middle fossa plate exposed, little bit retrosigmoid dura exposed, sigmoid sinus jugular bulb, superior petrosal sinus, Strassmann triangle, and all presigmoid dura posterior to the posterior semicircular canal and superior semicircular canal here. And these are the pure, so it's, you see, is a quite small approach, a limited approach. If you combine with the middle fossa, it can be more versatile. Translab approach, again, we mentioned this, as if you are using pure translabyrinthine approach, small C-shaped incision is enough, and the muscle elevation is similar. And this is the pure translab approach before you take the labyrinth and after you take the labyrinth. It's completely, almost completely epidural approach. Even if you open the dura, you don't see the cerebellum that often. What are the advantages of translab? Early identification and decompression of the internal acoustic canal, direct route to the cerebral pontine angle. Like I said, almost purely epidural approach, and no retraction needed on the cerebellum dura. Although you open and resect the presigmoid dura, you really don't see the cerebellum that much. And in my experience, is much less postoperative headaches comparing to the retrosigmoid approach. And these are the disadvantages if it is located, tumors located too anteriorly, too inferiorly, and if having the high jugular bulb can be the limiting factors. And if your patient has the chronic otitis media or mastoiditis, this approach is contraindicated. And this is the, again, pure translab approach versus combined with the middle fossa. Transcochlear approach, again, is more morbid approach, and gives you a much wider anterior exposure, ventral exposure. In all these approaches, transcochlear, translab, and the retrolab, when you combine with the middle fossa, you have to cut the superior petrosal sinus. And important things is knowing where the vein of labbe draining. So you cut anterior to the vein of labbe, superior petrosal sinus, then the tentorium. As you get deeper, you go more anterior to avoid the fourth nerve injury. So I'm going to show you that in a case. So I'm going to skip, and vein of labbe is important in these approaches, knowing the venous anatomy beforehand. And vein of labbe can drain to the transverse sinus junction, sigmoid sinus junction, transverse sigmoid sinus junction, tentorium, or very rarely they can drain, as we demonstrated in this our cadaveric dissection, into the superior petrosal sinus. So, and then you cannot cut the superior petrosal sinus. So pure translab is perfect for the spatially previously radiated or operated recurrent or residual acoustic neuromas like this. This is a young person at this surgery and in a place that considers the meccas of the acoustic neuromas. This patient had a subtotal resection and then observation. And the patient had a good hearing before surgery, lost the hearing after the surgery, and then tumors start growing, and the patient developed a severe resistant to medications, the trigeminal neuralgia. So you can go still retrosigmoid, but you'll be dealing with the previous scar from the previous surgery, and patient has no hearing anymore. And this is a perfect case, as you see, trigeminal nerve impinged by the tumor here. And we can go pure translab approach, okay? So see, and we drill the hole. This is this pedi is on the sigmoid sinus, jugular bulb is here, middle fossa plate, and superior petrosal sinus right here. And open the dura and resect the dura, but I'm not gonna see any cerebellum. So you see the previous scar from the previous surgery we have to go through. Not that much though. I am doing all working from the extradural part, initial tumor debulking. I'm going to skip identifying the facial nerve in the canal and amputating and cutting the superior petrosal, superior vestibular nerve. Okay, and only sharp or semi-sharp dissection around the facial nerve. Okay, I know people do different things, but avoid blunt dissection. And this is the facial nerve dissection in the canal, and these are very sharp instruments. And then the main purpose here is to remove the tumor, but debulk, decompress the facial nerve. You remember that patient is very symptomatic from the facial, trigeminal nerve, I'm sorry. So again, sharp dissection, and it's dissecting through the facial nerve wasn't that challenging, but the trigeminal nerve was quite compressed and a tumor was quite stuck to the trigeminal nerve. So now we are getting there slowly, and again, for time purposes, I'm gonna speed up. When we speed up these videos, the audience doesn't get the true feeling of it, but I'm sorry, there's limited time. And this is the part now, debulking. Acoustic neuromas is the thing, is you constantly debulk, constantly dissect, and that's the trigeminal nerve. See. And these are extremely sharp dissectors, so don't use too much blunt dissection. And your suction hand is your friend, okay? This is a suction hand. You can adjust your suction with your thumb. Don't rely on the other people's adjusting your suction, okay? I can suction the facial nerve or the trigeminal nerve without causing any avulsions of the capillaries or injury. So, okay, this is the final thing and final product. And same, larger tumor, first time surgery, no good hearing, young woman, same thing, pure translab approach, okay? And you can get excellent results. Grade 2 immediate post-op and grade 1 facial function with the gross total resection of the tumor. And these are the cases I use combination of the retrolabyrinthine and subtemporal middle fossa approach. Young man, very presented with the double vision and this large petroclival meningioma, perfect case for retrolab because patient's hearing was okay, was fine. And so you don't want to sacrifice the hearing, and you got near total resection, small residual, and maybe somewhere here. And then combine translabyrinthine with the subtemporal middle fossa approach. These are the cases patient has no serviceable hearing, then you can combine middle fossa with the posterior transpetrosal translabyrinthine approach. This is a challenging case. Again, very symptomatic. You see this is the sigmoid sinus. So I cut the dura in the middle fossa floor, and I am ligating the superior petrosal sinus. I used to do this with loops. I do now with the microscope. It's much better illumination and identification of the structure. So you cut through anteriorly. Don't go this way, and then watch for the fourth nerve. As you see here, I just show you the fourth nerve there. You cut towards anterior, and the trochlear nerve, fourth nerve is right there. And then expose everything. And then this video hopefully will be published soon. And then lower end of the tumor, you see, is very vascular tumor, origin of the pica, and you mobilize the tumor and see this is a 7 and 8 nerve complex, and the 7th nerve is going to be more anterior, right? So you can, once you open the internal acoustic canal dura, you can mobilize these nerves, and you can do more mobilization, and you can apply more traction. See, this is the dura of the IAC I just removed. And again, remember that this patient has no serviceable hearing, so we took the hearing already with the approach. Okay, vertebral artery.
2 minutes, dear friend.
I'm almost done. Yes.
2 minutes. Okay.
Yes, I'm almost done. So again, drilling more, establishing the hemostasis with the drill, CUSA, diamond drill, identifying the cranial nerve 6, and going, keep removing. Okay, and then the sharp dissection around the vascular structures. And the fat and the fascia. Okay, this patient woke up with the grade 3 facial, and over a week time progressed to grade 6 and improved to grade 3, back to grade 3, doing very well. Same surgery, translab, no hearing, transpetrosal approach. This is an unfortunate case, operated in somewhere else. Retrosigmoid approach, they remove this much and they get all kind of cranial nerve deficits, and facial nerve didn't improve. So we went for the transcochlear approach and left the small remnant. And good case, transcochlear is when you have the bad facial function already. So these are the approaches I try to summarize in a short period of time: retrolab, translab, transcochlear, how you combine with these. Again, there are many ways of doing these approaches. And retrosigmoid is the workhorse of the skull-based neurosurgery. Okay, so first learn the simple ones, and then when you need it, use the more complex ones. But before you do anything, you go to the lab. Okay, you study the lab, and you read, you watch these masters surgeries, and you see, you practice in the lab. Then you go to the operating room and perform. Okay, without that, unfortunately, you cannot be versatile with these approaches, whatever approach you do. Thank you. Hope I didn't take too much time. I'm happy to take any questions if there is any.
Thank you, Sil, for this great lecture. We will take just one question from panelists. Okay, if there is no more question, we will shift to next speaker, Professor Wang. Thank you, Sil, for your lecture. Professor Wang, can you please start sharing your screen?
Yes. Can you hear me?
Yeah, but it's okay.
Okay, thank you. Okay, this is Wei-Xin Wang from Taiwan. Today is really my honor to join this skull-based congress. Today, I would like to share one of my dissection work. Actually, this project is done in Pittsburgh, and my mentor is Dr. Fernando Mirandas. And my talk today will be foramen lacerum, surgical anatomy and relevance for endoscopy endonasal approach. So the first question is, where is the foramen lacerum? Actually, the foramen lacerum is not a true foramen as the foramen ovale or a foramen rotundum. Actually, this is composed by the three bone. It is a gap formed by the.
Here's the host aquí.
Excuse me. Oh. Is that okay?
Please move so on, unmute yourself.
Oh, okay, sorry. And this is the bone is the kyphoid part of the occipital bone, and the next is the pectoral part of the temporal bone. Actually, the foramen lacerum is a gap formed by these three bone, and in between the bone, we will find some useful surgical landmark. This is the fissure between in between the bone. The first is the petroclival fissure, and the next is a petrosphenoid fissure, and the last one, this is the pterygosphenoid fissure. These three fissures actually will go together and to point to the foramen lacerum as well. And the pterygosphenoid fissure, actually, this is the name by us. I will talk later to describe it in more detail. And when we look at from this transcranial view, and because our topic today is application in the endonasal endoscopy approach. So for this approach, endonasal approach, actually we go from the medial to lateral. So if we want to expand this the access to the laterally, actually we was limited by the nature boundary, the ICA and the cranial nerve here. So for the foramen lacerum, I think that is very important, more important surgical, the surgical area we have to figure out more detail than the transcranial approach. And this is a view look from the ventral side. If we want to go for lateral, and the foramen lacerum will be in this corner. And so I will say the foramen lacerum is a key structure at the crossroad between the sagittal and coronal plane for the endonasal approach if you want to go expand more laterally. So we know the natural boundary is the ICA, and the ICA related to the foramen lacerum will be the key concept of this project. Actually, this is already published. So I will describe more detail about this surgical landmark surrounding the foramen lacerum. The first is the median nerve. We know the median nerve is a very useful anatomy structure for us. It will lead us to the lacerum ICA. But we already know this median nerve will lead us to the lacerum ICA. But in the deep depth, the surrounding structure, actually, we did not know very well. So we divided into the 4 quadrant. We use the deep part of the median canal as a center. And then we can find many useful landmarks. We will describe later. And the pterygosphenoid fissure, we say that this fissure actually is a very small one. Where is this fissure? Actually is located between the pterygoid process and the flow of the sphenoid sinus. So we look at this feature. Its application is if you follow, we found this feature, and then we can found this trajectory here, and then we have the median nerve here. So this two line you can lead you more focus on the lacerum ICA. And then next is the pterygoid tubercle. The tubercle here, actually, when we drill the sphenoid flow and when we go very deep, is located medial to the median canal. And in the dip, when you getting close to the lacerum, you will have the very thin bone chip here. And if you remove this bone chip, and you will lead you to the connective tissue of the lacerum here. So this is a surgical, actually the surgical technique or the step-by-step dissection to describe this medial, inferior medial part of the inferior medial part quadrant here. We drill the sphenoid flow, and then we will find this pterygoid sphenoid fissure, and then we will have this pterygoid tubercle here. So actually, this pterygoid tubercle is the safe entry zone for us if we want to do the nasopharyngectomy, if we want to dissect or to mobilize the excision tube, or to go from the inferior to the pectoral part. That will be the safe entry zone there. The next I will talk about is the lingual process. The lingual process actually is a ridge of bone along the lateral margin of the carotid groove. Actually, this lingual process is to separate the Microsurgical and the lacerum ICA here. So the important of this lingual process is if we want to do go to the Microsurgical to such as trigeminal schwannoma, and you want to do by endonasal approach. Probably you have to identify this bone chip and remove it, and then you will have the more space in this corner here. And after the lingual process, actually this is a petrolingual ligament. The petrolingual ligament actually is not easy for endonasal approach to remove, and just the thin tissue there. So this is about a step-by-step dissection to how we remove the lingual process by endonasal approach. The first, you have to drill to expose this bone here, and then we will probably to drill more in the base, and then you can elevate this bone from superior to inferior, and then you will expose the Microsurgical dura here and the carotid artery, the dura here, and then this is the thick tissue. Actually, this is the ligament behind. It's not possible for us to remove it. And the next is the foramen ovale. There's a relationship with the foramen lacerum. Because we know the median nerve is here, and we know probably the foramen ovale is more laterally to it. But how you to identify precisely when you do the dissect during the surgery? And then we identify this bone here. Like the maxillary strut, we named this a mandibular strut. Actually, it's just lateral to the depth of the median canal, and you will have the bone chip, very solid bone here, and it's not possible for you to remove it. And just laterally, you will find the foramen ovale. So that this is a landmark for us to identify the foramen ovale by endonasal approach. So this is a mandibular strut. So you can see how deep it is. It's impossible for us to remove this bony strut by endonasal approach. But you can identify it and let you localize the foramen ovale. The visualis vein probably just the venous drainage to drain to connect it to the pterygoid plexus with the cavernous sinus. It located just anterior to the pterygoid mandibular strut here. So sometimes we dissect or remove the tumor here, we will meet some severe venous drain, venous oozing. You just to calculate or to use the hemostasis agent to pack in. You will stop the bleeding here. The lacerum, ICA, and the pectoralis apex. If you want to expose the pectoralis apex, you probably have to mobilize a little bit the ICA. But it's not easy for us to do that. So the remove the lingual process probably can give us a little bit space for us to mobilize the ICA laterally to expose the pectoralis apex here. So that we do some measurement or to do the some observation about the this structure. You can I have no time to explain all, and probably you can, if you have interest, you can read the paper. And so the next, probably I just use a showcase to show you how I use this surgical landmark to do to expose, especially for the pectoralis apex here, the lesion here. The first case is a nasopharyngeal carcinoma case. This is a recurrent one, and so this video just show you how we use to identify the Vidian canal and to drill the Vidian nerve. And then, because this is not a very pneumatized sphenoid sinus, you can identify a carotid very easy. But we drill the sphenoid sinus flow, you will expose the pterygoid fissure here, pterygoid sphenoid fissure here. So you're just using this line to localize the lacerum ICA, and then we can have the self-mobilize the ICA and to remove the pectoralis lesion there. So this is how we use the pterygoid sphenoid fissure combined with the Vidian nerve to localize lacerum ICA. The next case is a trigeminal schwannoma. The patient presents with facial numbness and pain. And for the small lesion like this, of course, the transcranial approach is, of course, is a useful one. But for endonasal approach, for the more from endonasal approach, probably is proper as well. So we do this case by endonasal approach. The first is a partial transpterygoid approach, and to identify the Vidian nerve and to localize the Vidian nerve. And because this lesion is more superiorly, it is not necessary to drill more lacerum structure here. But the key point here is to identify the lingual process and to remove it. And then we can expose the Meckel's cave completely, and the relationship with the paracaval carotid artery here is very clear. So we just cut the dura parietal to the V2, and then we just go into the Meckel's cave here. So if we do not remove the lingual process here, probably we will have no space to mobilize and to do any dissection or here. So we can see here is the tumor. The tumor is not big, and we can do a little bit dissection and then to get it out. So the for trigeminal schwannoma, if you want to do transmecos cave like this, and the key point of the remove the lingual process is necessary here. And this is a post-op. And the next case is about the pectoralis appendicitis, and is this an inflammatory disease? The patient suffer from the left arteria and the retroorbital pain because the patient suffer from the acute diplopia. So the mass lesion is getting bigger. So that we decide in beginning, the patient she is treated with the antibiotics only, but for more than 2 months. But the symptoms getting worse, so we decide to to do the surgery for her. So it's already going to the sphenoid sinus, and this is the left side sphenoid sinus here, and you can see already the tumor, the lesion already can be seen. So again, we localize here. This is the pterygosphenoid fissure, and like this is the dissection, and here is a median nerve, and then we can identify the lacerum ICA early on, and then we drill. Here is because we want to full mobilize the paracarpal ICA, so that we we remove the lingual process, the lateral to the paracarpal ICA, just to make this ICA without the bony cover, and then we can have a little bit access to mobilize it. And so you can see here, we remove the lingual process very carefully. And then here, right now, the ICA is already no bony cover on it. And so we can start to remove the lesion. And here, because this is inflammatory disease, it's not like the tumor one. So that we just try to debug it and this is a 45-degree scope view, and under navigation you can see probably the most of the lesion already removed and well decompressed, and so this is application we use here. So the patient, the baptism palsy, recover 1 month after the surgery, and shorten the antibiotic treatment course. And this is a post-op the image. We just covered the middle turbinate graft to protect the ICA we expose, and it grows very well. And then the last case is about the cavernous sinus pituitary adenoma. Of course, actually this is not going to the foramen lacerum, but the tumor involved to the lateral recess of the sphenoid sinus and surrounding the paracarpal ICA as well. So to identify the structure to remove the tumor safely is very important. And I demonstrate this case. I just is how amazing. When I do the surgery, I found it almost like the view I did in the lab. And you can see here the partial transterior approach, the median nerve, and lead you to the lacerum ICA. And here is a visalis vein. We can see very clear. And the lateral recess, the tumor already been removed very clearly, and then go into the cavernous sinus. And so if we cannot identify the structure near to the ICA, and that will be the big problem for us. And this is to remove the lateral compartment of the IC, the cavernous sinus, and to expose the lateral cavernous sinus. And this is a inferior compartment of cavernous sinus, and there's no vessel or just the sympathetic process here, because we already know where is the lacerum ICA, the turning point, and we can expect the depth of the paracarpal ICA, and as well as the vertical segment of the cavernous sinus ICA. And the next, we go to the superior compartment or medial compartment, and then we cut the ligament and to completely expose the superior compartment. Here is a oculomotor triangle there. Here's a posterior compartment, and below it will be the sixth nerve here. So we just follow this compartment, the idea, and because we can localize the ICA very early on, and to predict the whole its trajectory. So the tumor resection is not difficult. So my conclusion is foramen lacerum is a complex structure in the skull-base surgery, and we provide the pterygo-sphenoid fissure, pterygo-tubercle lacerum, and lacerum ICA or the lingual process mandibular strut. This surgical landmark to help in dissect during surrounding the foramen lacerum by endonasal approach. So I think this surgical landmark is very useful, and I every time I go to this corner, I will identify all this structure. And thank you for your listening. Thank you.
Thank you so well for this nice lecture. We would allow just one question from panelists. Okay, if there is no questions, we will shift to next speaker. I'd like to announce that every speaker here can take the other room to more question and discussion. The other Zoom room launch link is available in chat. Professor Baskaya, just join the launch now, and you can take more discussions here. Next speaker will be Professor Shimanyir, and we will talk to us about endoscopic cadaver dissection of sphenoid, sinus, cella, and supracellular lesion. Professor Yib, please share your screen.
Hello, can you hear me?
Yes, it's okay. Just start with screen share.
Good morning, good afternoon, good evening, everybody. Thank you very much to your kind invitation. I am Jiman Yip, coming from Kaohsiung Victorian General Hospital, Taiwan. It is my honor to...
We are just see your video, but we can't see your lecture. It's okay now. It's okay now.
Okay now. So it is my honor and my pleasure to participate in this international congress and to share my cadaver dissection with you. My presentation is endoscopic cadaver dissection of sphenoid sinus, cella, and supracellular region. This is the right side nostril, and here is the inferior turbinate on the lateral side, nasal septum on the medial side. And then I proceed the endoscope, and we can see this structure, choana. Choana is a constant landmark to approach sphenoid sinus, especially for the beginner. And here is the opening of eustachian tube. Middle turbinate, I use the shaft of the instrument to mobilize the middle turbinate, not the tip, to minimize the mucosa injury. Like that movement. Then I use the scissor to reset the right side middle turbinate. In this limited space, it is better to handle the scissor in an orbit flexion. And the tips to reset the right middle turbinate is cut and then push down. But be careful not cut the attachment too high, otherwise CSF leakage will be resolved after surgery. Just push, cut, and then push. And here is the sphenoid ostium. From this opening, I can enter the sphenoid sinus here. And now I am trying to dissect the nasal mucosa. And here is the sphenoid rostrum. It is a good guidance for the midnight location. The rostrum. Then after I enter the sphenoid sinus, we can see there septation. And I use this long drill and high-speed drill to remove the septation, and the posterior is more air cell, like that. Now I was drilling the posterior isthmoid air cell. Here is very close to the lamina papyracea, the medial orbital wall. Now I am drilling the septation inside the sphenoid sinus. Here is the chiral recess, and here is the pituitary fossa. Chiral recess is a constant landmark to identify pituitary fossa. Here is the lateral recess of sphenoid sinus. I still keep on drilling the septation. Now I was drilling the pituitary fossa in an upright direction because carotid artery is on the both sides. So up and down direction drilling is much safer. I drill the bone until the bone becomes very thin. Then I use the Carrison punch to dissect and pick up the bone, not just bite, because sometimes it may injure the dura or carotid artery. Now I proceed to drill the tuberculum sella. Tuberculum sella is a bone that was quite thick, and I drill in a C-shaped direction on both ends, this side and this side. When the bone becomes very thin, then I fracture it and then dissect and reflect the bone from the underlying dura and remove these pieces of bone in one pieces. Like that. And we can see this the indentation of dura at the level of tuberculum sella. Here is the right side optic nerve, carotid artery on the right side. And this area is the lateral optical carotid recess. This spaceman is not well pneumatized, so it's not very prominent to be seen. And here is the medial OCR, medial optical carotid recess. And lateral OCR is corresponding to the location of optic stroke. And I was trying to remove this optic shock. So we can see there's some soft tissue attached to the optic shock here. Now I am proceed to do the transpenum approach. This is the posterior ethmoidal artery, which is the anterior border of transpenum approach. When we doing this approach, there is a lot of bone filling and bone work to be done. Here is the opener, and here is the lamina papyracea. And in this is the area of the bone that had to be drilled in doing the transpenum approach. And the shape is like a trapezoid shape. And the technique of bone removal is just drilling the bone to be very thin and then dissect it from the dura and we fed the bone flap from anterior side to the posterior because of the slope of the anterior cranial base. So I have to take my time to drill the bone. So when the bone became very thin, I can just dissect it from the dura and we fed it from anterior to posterior direction and remove it. But if the bone is sick, still is sick, such as in this situation, don't fracture the bone, but keep on drilling. Otherwise, dural tear can be happen. So there is a lot of bone drilling required. Of course, in the life surgery, a lot of irrigation is very important and necessary. Now, a wide sphenoidotomy was done. And here is the opened carotid artery, lateral OCR, medial OCR, and this is the distal vein, distal dural vein, and this is the paracrinoid carotid artery. And pituitary gland is here, and there are two layers of dura covering the pituitary gland. And probably around here, these two layers separate And in between them is the cavernous sinus. And the outer layer of dura became the anterior wall of cavernous sinus. This is the indentation that caused by the tuberculum sella. And here is the optimal, and so here is the limbus sphenoidale. And here is the chiasmatic sulcus. Mobilize the pituitary gland, the dorsum sella can be exposed. And this is the parakyphal carotid artery, but not yet fully exposed. Dorsum sella. And there's still some remnants of the optic structure left here. Now I move the endoscope a little bit backward and find here is the opening of Radian canal. Here is the opening of the Radian canal. Inside the canal is the Radian nerve, which is a landmark leading us to the lacerum segment of carotid artery, which have been well described by previous speaker, Dr. Wong. So this is the lateral recess of sphenoid sinus is fully exposed here. Parakyphal carotid. And if the parakyphal artery can be more mobilized to the lateral side, then the pitch's apex is can be approached in this direction. And now I am showing the location of posterior canoid process. This is the pennum. The bone of the pennum had already been drilled. And this is the limbus sphenoidale. And here is the chiasmatic sulcus, which is an important landmark in endonasal approach. Because if we open the dura above the limbus sphenoidale, then we can enter the suprachiasmatic space. And we can, from this space, I can approach the frontal lobe. And if we open the dura below the limbus sphenoidalis, then we can approach the system below the optic chiasm, the infrachiasmatic space. Now, I am open the dura in a longitudinal fashion. So the infrachiasmatic space is exposed. Here is the optic chiasm. And when we open the dura around this region, we should take care, or we should be very careful to the payoff of ophthalmic artery. because ophthalmic artery is around here. It supplies the optic nerve. Now I try to show the structure in the intrachiasmatic space. Here we can see the the pituitary stalk, and this is the superior hypophyseal artery on both sides, and it supplies the pituitary gland and the inferior surface of optic chiasm. Here is the distal dura vein, and this is a supracarotid segment of carotid.
Four minutes.
Okay. The outer layer of the outer layer of the dura has been opened. So this is the inner layer of dura covering the pituitary gland, and here is the inferior hypophyseal artery, and here is the cavernous sinus. I try to open the inner layer of the dura and to find out the interface between the gland and the inner layer. So there's an interface between gland and the dura. And because this specimen is not, the brain condition of the previous brain is not so good, so I use another specimen to show the structure in the suprachiasmatic space. I open the interhemisphere fissure, and then be careful the frontal orbital artery, and then dissect, and then we can see the anterior cerebral artery complex. And actually, in clinical practice, from this approach, we can assess the ventricular system. This is a patient having a giant pituitary adenoma. I operate on him, and after tumor resection, this is the final view. The chloroplexus ventricular system is nicely shown. So endoscope is one of the tools available to modern scalp-based surgeon, and modern scalp-based surgeons should be trained in both open and endoscopic techniques, so that the best surgical option can be offered to the patient for any given pathology. Study the anatomy and practice the surgical skill in the lab. Thank you for your attention.
Thank you, Professor Job, for this great lecture. We can allow just for one question from panelists. Okay, if there is any question, we can shift to lounge room to start this discussion and more questions about this lecture. Thank you, Professor. And now we will shift to next speaker, Professor Binzu. Professor Binzu, please start your screen share. Thank you.
Okay, thank you, Chairman. This is Bin Xu from Shanghai Huashan Hospital. So today my topic is cerebral revascularization in recurrent nasopharyngeal carcinoma. The risk of the recurrent nasopharyngeal carcinoma is very high. So if the ICA was invaded by the recurrent nasopharyngeal carcinoma, on the 3-year survival rate without treatment only 65.1%. This is in the without ICA invasion. If the ICA was invaded by and without any treatment, the 3-year survival rate is only 15.7%. But if we treated with revascularization combined with the ICA embolization, then totally removed the carcinoma. So the 3-year survival rate increased to 100%. So this is our preliminary result. So you can see in this recurrent nasopharyngeal carcinoma, the patient is very dangerous for the ICA bleeding. If it happened, the patient can die in minutes. Sometimes even in intraoperatively, the ENT doctors remove the tumor. They can hurt the ICA wall. So you can see this is a pseudoaneurysm originated from the ICA wall. So the indications for ECIC bypass, including the blood flow replacement, usually we use the complex aneurysms, but now we also use the square-based malignant tumor involving the wall of the ICA, such as nasopharyngeal carcinoma. And the second type is a blood flow augmentation, including moya-moya vasculopathy or occlusion of ICA or MCA. So you can see how much blood flow can a high flow bypass supply. This is a ECA saphenous vein to MCA bypass. You can see it can replace the blood flow from the whole ICA for the dominant side, not only the same hemisphere, but also the frontal lobe to the contralateral. This is my personal experience in bypass. Now it's close to 9,000. The treatment of a square-based tumor invading carotid artery, we can use the direct repair if the vessel wall was bleeding intraoperatively. So we can use a covered stent to repair the vessel wall immediately. But for the malignant tumors, we want to totally remove the tumor, including the invaded vessel wall of the ICA. So we, at first, we need to do the blood flow replacement. High flow normally means ECA saphenous vein to M2 bypass. Medium flow, ECA radial artery to M2 or M3 bypass. Low flow normally means STA, single or multiple branches to M3 or M4. This kind of cerebral revascularization should combine the direct occlusion. So some collateral blood flow from the ACAM or PCAM is enough. If the BOT intensive taste, which means that we decrease the blood pressure 30%. If the patient still can tolerate this BOT enhanced taste, we can direct occlusion the ICA. without any bypass. And the assist method, including the progressive occlusion of ICA. This kind of method can promote blood flow of bypass and can be combined with different bypass methods. This is a direct repairing of the ICA vessel wall. You can see intraoperatively, the ENT doctors hurt the ICA vessel wall. So this is you can see the vessel, the pseudoaneurysm was bumping, and they compressed to hemostasis. Then send the patient to us. Then we use a covered stent, and then fixed the problem immediately. This is after the covered stent. You can see the vessel wall was repaired immediately. But for the malignant tumor, this is not enough, because if you only stop the bleeding, you still left the malignant tissue in the local lesion. So we need to remove it totally. So this kind of treatment need cerebral revascularization before the removal of the carcinoma. The donor vessels, including radial artery, saphenous vein, STA, sometimes we use occipital artery. The ICA invaded by the malignant tumor before the bypass, we should estimate the natural collateral blood flow, guarantee the enough blood flow replacement. So this is a different strategy. At first, we use the ICA balloon occlusion test for 30 minutes. If the patient there's no neurological deficit, we use the enhanced BOT, which means the blood pressure decreased 30%. If the patient still tolerates very well, this kind of ICA can be occluded immediately. If the patient cannot tolerate the enhanced BOT, we still need the STA-MCA double bypass combined ICA immediately occlusion. If the ICA balloon occlusion of the ICA couldn't tolerate the, which means the BOT positive, we should make the plan for the bypass. If the ICA not only feeded the whole hemisphere, but also the contralateral ACA territory, we should use the saphenous vein or sometimes ECA radial artery to MCA combined STA to MCA double bypass. If the patient the related ICA only feeded the same side MCA combined ACA territory, we normally use the radial artery. If the ICA only feeded the MCA territory, for the male patient, STA normally larger than 1.2 millimeter. Double bypass is enough for replace the MCA territory. But if the patient is a female, STA normally is around 1 millimeter. So we still need a radial artery for transplantation. After the bypass and the ICA, we also can combine the progressively occlusion in 7 days. Actually, in the this is a special in the malignant tumor that both side ICA was totally invaded by the malignant tumor. So I called this maximum flow bypass. So both ICA blood flow should be replaced. So this is a preoperative both side of BOT. You can see the balloon occluded the both side, and the collateral from contralateral is quite good. So our surgical plan is the ECA saphenous vein to M2 stoma. This is a stomas. This is the ECA to saphenous vein. This is the M2 to saphenous vein. And for this patient, I also combined the STA MCA double bypass. So you can see the saphenous vein is quite patent after bypass, and this is a bypass immediately after the surgery. So I occluded the both side ICA. You can see the blood flow was enough to feed the both sides of the hemisphere. This is a right hemisphere, also got some collateral flow from posterior circulation. So this is the second type is a high flow bypass. We should replace the blood flow of one side of ACA combined MCA territory. Normally use the saphenous vein to MCA. This is enough. So in this case, you can see the saphenous vein can totally replace the ACA and the MCA territory. The third type is a medium flow bypass. We can replace the blood flow of the one side MCA territory. For this kind of patient, normally for the male patient, we use double STA. For female patient, we use radial artery to MCA. So this is a stomas. You can see the graft artery totally replace the MCA territory. This is a surgical video. You can see I occluded the M2 segment with two curved temporal clips, then cut one piece of the vessel wall. Use the 9-0 proline suture. The second stage is to the here of the donor artery. If there's some tension between the donor and the recipient artery, I use a surgical knot. So in a few minutes, you can finish the stoma. Then remove the temporal clips. The first is a distal part. Then the proximal one. Then make the stoma of the ECA to radial artery. The anastomo is the same. This vessel wall is quite thick, so it's easy to anastomose. So then remove the distal temporal clip, then the proximal one. This is the ICG after the bypass. You can see this is the ECA radial artery. Then we performed the angiogram immediately, then sacrifice the ICA immediately. So the final type is a low flow bypass. Normally we use STA as a donor artery. So this is a double bypass of STA. You can see for the male patient, normally the double branch of STA can feed into the MCA territory. This is after the double bypass. You can see the blood flow was quite abundant and reflux to M2 segment, then redistribute along the MCA network. Sometimes we can use progressive occlusion of ICA in 7 days. It can be combined with different bypass methods, increasing blood flow of donor artery and promote the anterior and the posterior communicating artery and the pure matter compensation. So this is, as this patient, you can see the before the progressive occlusion, the collateral is quite poor. But after 7 days, the collateral increased. The right side, you can see the bypass immediately after the surgery was not enough to feed it the both side. But in 7 days, the blood flow increased a lot and can feed it the both side very successfully. So this is the original progressive occlusion clip. This is a new design by myself. This is a occlusive, progressive occlusion clip. This is an illustrative case. You can see before the bypass, the collateral from ACAM and the PCAM was very few. This is a bypass. You can see the blood flow was quite good. And this is intraoperative. We hook on the clip, then narrowing about 70% intraoperatively. Then we will get totally occlusive in 7 days, every 5% per day. So this is a left ICA was gradually occluded and completely occluded 1 week later. So then you can see the double bypass was all patent and the blood flow was increased a lot. Not only the blood bypass blood flow, but also the natural collateral from ACAM and the PCAM was increased. So now the bypass for nasopharyngeal carcinoma, totally we have around 19 cases, all successfully replaced the blood flow of ICA invaded by tumor. The ENT doctors completely removed the tumor soon afterward. The 3 years survival rate now is 100%. This is a take-home message methods, the cerebral revascularization combined with direct occlusion of or progressive occlusion of ICA, tailored bypass for ICA invaded by malignant tumor. And the preoperative cerebral revascularization combined ICA embolization have a better prognosis. Thank you. That's all for my report.
Thank you, dear friend, for this great lecture. Any questions from panelists? Okay, for more discussion, we will shift to lodge. And now we will shift to next speaker, Professor Su, which we will be talk about preoperative strategies, angiography, and new intervention application in skull-based tumor surgery. Please, Professor Su, share your screen.
Hello, I'm Dr. Su. Can you hear the sounds?
It's okay. You can start.
Okay, and do you see the screen? Okay, can you see the screens? Sorry.
It's okay, you can start.
Okay, thank you, Chairman. Dear ladies and gentlemen, I'm Dr. Yichang Su from Taipei Medical University. And thanks for inviting me to join this wonderful conference. And I'm a vascular neurosurgeon and interventional neuroradiologist in my hospital. So today I'm going to talk about the strategy of the preoperative angiography that I use for my skull-based surgeon colleagues. And this strategy will mainly depend on some important anatomical variations that are relevant to the skull-based approaches. Okay, so let's start from two clinical scenarios. In this first case, the patient had a cavernous sinus meningioma at the left side. So which treatment or surgical approach will you choose based on this MR images? If I give you these angiographic pictures, will you change your treatment plans? And let's look at the second case. The patient had a petroclival meningioma at the right side with this venogram. Which surgical approach will you choose? How about the same tumor, but with a completely different venograms? So in order to make an optimal treatment plan, a detailed evaluation of the vascular anatomy is extremely important in skull-based surgery. Non-invasive images such as CT or MR are very helpful, but sometimes catheter angiography are still necessary. And this slide summarizes all the important vascular information that we should gather from all the vascular images we can get. And this evaluation is not limited to the vessels around the lesions, but also the vessels related to the surgical approach. So in this talk, we will focus on some examples of arterial or venous evaluation that will affect how we choose a surgical approach. And we will demonstrate how we gather this information from the common vascular images we can get. And we will focus on 3 classical skull-based approaches, including frontotemporal, anterior transpetrosal, and posterior transpetrosal approaches. And the vessels that are relevant to these approaches are middle meningeal artery, superficial middle cerebral vein, and superior petrosal sinus. So let's start from the middle meningeal artery. We all know that it's a key step to divide the branches of middle meningeal artery during certain skull-based approaches. For example, meningeal orbital band detachment is a key step in anterior clinoidectomy, and this step will inevitably divide the meningeal orbital artery, which is the branch of middle meningeal artery. Similarly, in anterior transpetrosal approach, it is also a key step to divide the middle meningeal artery at the level of the foramen spinosum. However, it is possible that the patient's ocular supply or the ophthalmic artery is not coming from the classical ICA, but is coming from the middle meningeal artery, like this angiogram. And also you can see the choroid blush from this ophthalmic artery. So this kind of artery that supplies the eye is called the meningo-ophthalmic artery, the same artery that we will divide when we attempted to detach the meningeal orbital band. The reason for this kind of anatomical variation can be explained by the embryological development of the ophthalmic artery and the middle meningeal artery. As you can see this step-by-step drawing, adult type ophthalmic artery, which supplies both ocular and extraocular structures inside the orbit, is actually the results of the fusion or regression processes between the fetal ophthalmic artery, which is the red lines, and the middle meningeal artery, which is the blue lines. If this development process was different, numerous kinds of anatomical variation occurred. The variation that's relevant to our today's topic is this one. The middle meningeal artery becomes the main artery that supplies the eye. And you will see that in this case, the ophthalmic artery is actually not going through the optic canal. It is going through the superior orbital fissure. If we did not notice this kind of anatomical variation and ligate the middle meningeal artery at either foramen spinosum or the meningeal orbital band, visual loss will be highly possible. And this potential complications has already been published previously. The author in this case reported that the reason for the blindness is because the patient's eye is supplied by the meningeal ophthalmic artery, and this artery is sacrificed during the meningeal orbital band detachment in terional approach. So in our previous angiographic screening, we found that actually this kind of meningeal ophthalmic artery variation is not that infrequent. Therefore, please carefully look at the vascular images you had. If you can identify the ophthalmic artery that passes through the optic canal, then it is safe. But if not, it is better to do an angiography to confirm where the orbit or ocular artery come from. If you can prove that the patient has a meningeal ophthalmic variant, frontotemporal approaches involving anterior clinoidectomy, anterior transpetrosal approach will probably risk the visions. And the next vessel I'm going to discuss is the superficial middle cerebral vein. And this vein is usually traceable in thin-cut contrast CT or MR scans. Embryological speaking, the superficial middle cerebral vein initially courses along the temporal base posteriorly into the tentorium and reaches the transverse sinus. It gradually migrates medially, regress partially, and is finally captured by the cavernous sinus. So the adult type of the superficial middle cerebral vein empty into the sphenoparietal sinus and reach into the cavernous sinus. And this is named as the sphenoparietal type of the superficial middle cerebral vein. If the this vein is not captured by the cavernous sinus, but empty into the pterygoid plexus via the foramen ovale, then it is called the sphenobasal type. If the vein persists as its fetal type, which runs along the temporal base and back into the tentorium or the transverse sinus, it is called the Sphenopetrosal type. So in this case, for example, you'll see that the vein goes all the way to the foramen ovale over here. So it is a sphenobasal type. And in this case, this vein goes along the temporal base to the superior petrosal sinus or the tentorium. So it is called the Sphenopetrosal type. Please look carefully at this drawing published in this journal. The venous segment at the temporal lobe, the temporal base, may be intradural, partially extradural, or completely extradural. Therefore, when surgical approaches involving epidural dissection at the temporal base, it may cause injury of the superficial middle cerebral vein and results in venous infarct. And of course, there's an anatomical variation that the superior middle cerebral vein is poorly developed or drained superiorly into the frontal cortical veins. In these two situations, venous injury is less likely in anterior or posterior petrosectomy. So this article therefore summarized that some superficial middle cerebral vein drainage patterns may be favorable or non-favorable in either anterior or posterior transpetrosal approach. So you can take the reference at this table, and hopefully this table will help surgeons to choose a proper approach. Accurate determination of this drainage pattern is important. In our practice, if the superficial middle cerebral vein is easily traceable in CT scans, we will not perform the catheter angiography. However, if the tumor masks the drainage pattern of this vein, we will usually perform the conventional angiography to determine the exact drainage pattern. The last anatomical variation we are going to talk about is the superior petrosal sinus. And the reason to talk about this vein is because this sinus is usually ligated and divided in either anterior or posterior transpetrosal approach. As you can see, the superior petrosal sinus lies on the top of the petrous bone, and it is the major outflow of the petrous veins, which collects the venous blood flow from parts of the cerebellum and the brainstem. So 3 types of the anatomical variation of this SPS has been proposed. As you can see, most of the patients had a complete superior petrosal sinus or the lateral part of the superior petrosal sinus, but a minority of the people have a smaller, a medial type of the SPS. And this is an example of the lateral type of SPS, which drained posteriorly into the sigmoid sinus. And this is an example of the complete type of SPS. The venous flow predominantly drained posteriorly into the transverse sigmoid junction, but sometimes it drained anteriorly into the cavernous sinus. In the medial type, the SPS drained anteriorly into the cavernous sinus exclusively. And these are the CT scans that performed after an anterior or posterior petrosectomy. As you can see, SPS is actually divided at the different levels in both anterior and posterior transpetrosal approaches. Therefore, we can deduce that in anterior transpetrosal approach, it is safe to ligate the SPS in the lateral type of SPS or the complete type of SPS, because the petrosal vein, however, it will be very dangerous if you divide a medial type of SPS, because the petrosal vein will fail to empty into the cavernous sinus unless it is associated with the rich venous collaterals. On the contrary, in posterior transpetrosal approach, it is less limited by this SPS variation as long as the SPS belongs to the medial type or the SPS was divided anterior to the point where the petrosal vein enters. Therefore, we can summarize again that SPS drainage pattern may be one of the key players in choosing either anterior or posterior transpetrosal approach. However, since it is usually more difficult to identify the SPS in the non-invasive images, in our practice, we would prefer to do conventional angiography, when we choose a skull-based approach that requires SPS division. In conclusion, the middle meningeal artery, superficial middle cerebral vein, and the superior petrosal sinus are all important vascular anatomies that should be carefully analyzed before choosing a proper skull-based approach. These are just some examples. Remember, presence of anatomical variation is a rule rather than an exception. And this rule also applies to the vessel that we tend to neglect, such as middle meningeal artery. So in our daily practice, when we face with a skull-based tumor, we will think of several possible approaches first. Many factors affect our surgical approach of choice. And today I mentioned one of the major determinant factor is the vessels that will be encountered or sacrificed in a certain surgical approach. Therefore, we have to determine what vessels we should look for and understand all the possible anatomical variation related to that vessel. Next, find those vessels and define its pattern by using the non-invasive images we had. If it is undetermined, we will suggest to perform a catheter angiography first. Hopefully, this strategy will help surgeons to choose a proper surgical approach. So thanks for your attention.
Thank you, Professor, for this nice lecture. And is there any questions from panelists? If there is no question, we will shift to our next speaker, Professor Atul Goel. And all can shift to the other room of Zoom launch for more discussion and questions.
Can you unshare your screen?
Yeah, I'm doing, sorry. Okay, there you go.
No, not yet. Yes.
There you go, Atul. I did that for the king.
Yeah, I can see that. Okay. So good evening from India, from Mumbai, and good morning to my dear John. Good afternoon to Sameh, and I hope and I wish that all of you are happy enjoying this wonderful skull-based feast that Sameh has organized such wonderfully. He's such a great educator. John, you agree? Such a great educator. And
he's an ace. He's an ace.
yeah. So I'm going to take you now to the world of trigeminal neurinomas. Trigeminal neurinomas. So trigeminal neurinomas are relatively rare problem. In neurinomas, they are second only to acoustic neurinomas. Acoustic neurinomas, of course, the most common. And rarely they are associated with neurofibromatosis. So we all know this. So in the year 2003, I published this series with 73 cases. I had analyzed 260 cases, personal cases operated by me from 1988 to 2017, 260 cases. And now in the next further 4 years, at least I have reached more than 300 cases of trigeminal neurinomas, which is without any question the largest personal series in the world. So with that power, I am going to talk to you. So this was my article in 2003, which was, it is quite a well-cited article. And in this article, we introduced several beautiful things about trigeminal neurinoma. First beautiful thing is that we mentioned for the first time in the literature that trigeminal neurinomas arise from the region of Meckel's cave. It does not arise in the root, does not arise in the further roots of the trigeminal. It arises in the region of Meckel's cave. That is one thing in this article. Second thing in this article, which was for the first time we mentioned, these tumors can be removed by an interdural, within the dura. These tumors remain within the dural confines of lateral wall of cavernous sinus. and this dura protects you during surgery. So this information was first time in the literature exploited for trigeminal neurinoma. The other beautiful thing that we mentioned in this article is that surgery, you can aim to preserve the function of trigeminal nerve. That is one thing. Not only preserve, but the aim of surgery is to improve the function of the fifth nerve. So that improvement of the fifth nerve function as a series was first time discussed in this article. So in this article, we mentioned that this middle fossa component of the tumor is interdural. In this article, we had mentioned that the posterior fossa tumor is intradural like acoustic tumor. But further articles of mine discuss that even this part of the tumor can be interdural. So the whole thing can be interdural tumor. And the fifth nerve are displaced by the tumor. So this information was not available 25, 30 years ago, and these tumors were quite complex and not many people operated on these tumors. So as you can see, we observe that most of the tumors arise at the entry of fifth cranial nerve into Meckel's dural cave. So this was one information. Second thing that we mentioned, this is my other article, trigeminal neurinoma with extracranial extension. And here we mentioned that we speculated the origin of even extracranial trigeminal neurinoma in the region of Meckel cave. So even the tumor is extracranial, the origin of the tumor is in the Meckel's cave. And most trigeminal neurinomas, irrespective of the site of spread, have an association with the region of Meckel's cave. So that is these are the things that we discussed for the first time in the literature. The other beautiful thing that I already talked to you about is that you can improve the sensations of the fifth nerve. So this information, this kind of improvement of function was never discussed in the literature as a series. So trigeminal nerve is quite a big nerve. As you can see, this trigeminal nerve has been split. The carotid artery is very closely proximated to the tumor. And these are the third nerves which form, these are the three divisions of the trigeminal nerve. V1 and V2 form the lateral border of the cavernous sinus. Lateral wall of the cavernous sinus. So it is the trigeminal nerve is located in the lateral wall of the cavernous sinus. See this V1 and V2 divisions. V3 is exits before the cavernous sinus. So this is third nerve, fourth nerve, sixth nerve. So trigeminal nerve, these two nerves are located in the lateral wall of the cavernous sinus and they have a very well-defined dura. So that is the basis. So this dura is a strong structure, dura is a firm structure, and dura cannot be penetrated. That is the beauty. The dura, you know, all the nerves and blood vessels which exit from the brain have a dural cover. So this concept that dura is strong and dura will be there, dura is respected by the blood vessels and the nerves, and even the tumor respects the dura. So this is my concept, which I have discussed on several occasions. As you see, these papers are 25, 30 years old papers of mine where we have discussed about how the arteries are displaced by the tumor. This is a very, you know, during those times, this concept was not there in 30 years ago. So on the basis of arterial involvement and displacement, we identified the nature of the tumor, we identified the surgical strategy for the tumor, and we identified preoperatively what is the histological nature of the tumor. So some of these articles on cavernous sinus, I think they had big impact on trigeminal neurinoma surgery. So this is the paper. You see, this kind of arterial encasement will never be seen in trigeminal neurinoma, never. This kind of intracellular, this is pituitary tumor, or this is displacing the carotid artery. This kind of displacement of carotid artery is never seen in trigeminal neurinoma. This kind of trigeminal nerve, this kind of carotid artery encasement is never seen in trigeminal neurinoma. So these are the basis of identifying the trigeminal neurinoma. So trigeminal neurinoma, this is a very classical case of trigeminal neurinoma located in the lateral dural walls of the cavernous sinus. Carotid artery is displaced medially by the tumor. You can work within the tumor and you don't have to identify or define the carotid artery. This dura will protect. So this understanding is a very critical understanding in trigeminal neurinoma. The whole tumor is covered by dura and you have to work interdural within the dural confines. And like for acoustic tumor, you are stressing for facial nerve preservation all the time. In trigeminal neurinoma, you must stress on preservation of trigeminal nerve fibers. And that is the aim. If you damage the trigeminal nerve fibers, then it is a failed operation and a huge complication. Because if V1 is lost, then corneal reflex is gone and the cornea will be damaged eventually. Tumors located entirely in the posterior cranial fossa are relatively rare. Even the tumors which are located in the posterior fossa, trigeminal neurinomas, have an extension towards the Meckel's cave, most of these tumors, or almost all of these tumors. The most common form of trigeminal neurinomas are these kind of dumbbells. As I mentioned earlier in my experience, we thought that this part of the tumor is intradural, but now I am quite convinced that a large number of these tumors, even there is a dural. So you can come in this direction, work within the dural confines, and you can remove this tumor radically, quickly, and effectively. The most important thing to learn about this tumor is how to attack this tumor, how to demolish the tumor, how to break this tumor. There is no need to coagulate these tumors. They are not vascular tumors. They are soft tumors. Sometimes they are like, maybe like nubbins, maybe they're here and there, but essentially they are confined and defined tumors. So these kind of dumbbells are very common in trigeminal neurinomas. More importantly, they come with a very classical type of presentation with numbness over the face, with wasting of muscles of the trigeminal nerves. Motor and sensory involvement are classical. On the basis of the clinical finding, you can say that this is a trigeminal neurinoma, because surgery on meningioma of cavernous sinus is different. Surgery for trigeminal neurinoma is different. The aims and objectives are different. The surgical style is different. So there can be a large middle fossa and larger posterior cranial fossa component. But you see, there is a defined, this is a very defined posterior cranial fossa component, and you can, these are one of the more important skull-based tumors and radical resection. I must tell you that 25, 30 years ago, surgery on trigeminal neurinoma was not frequently done, and people did not understand how to remove trigeminal neurinomas. So this is another large trigeminal neurinoma. So I'm going to show you several images so that you get a feel of these kind of tumors. Less frequently, but not uncommonly, these tumors extend along the divisions of the trigeminal nerve. So this tumor, we had reported extension along the lacrimal nerve. You see, along the V1 division of the trigeminal nerve. But there is a base in the middle fossa. The concept is that these tumors arise in the Meckel cave and then it goes ahead. So they can go along the V1 division of the trigeminal nerve, and essentially the surgery you have to define how to operate on these tumors. This is the tumor along the V2 division. You see these are teeth, and this is along the foramen rotundum, and this is the V2 division of the trigeminal nerve, and they can go along the V2 division. More importantly, you must understand that the sixth nerve is medial, carotid artery is medial. You cannot come from this direction. This direction, if you come, you can hit the carotid artery. This direction you come, you can hit the sixth nerve. Lateral, working within the dura, is the way to operate on these tumors. So these tumors, this is along the foramen rotundum, very huge tumor, as you can see, and this has destroyed the teeth of this gentleman. And these can be this kind of extracranial extension of trigeminal neurinomas, not frequent, but not uncommon. This is along the V3, you see, along the foramen ovale. It is dilated here. There is extension in the middle fossa, and then there is an extension in the infratemporal fossa. So this is a trigeminal neurinoma. You will diagnose this tumor on the basis of symptoms. Numbness is one very big symptom, and wasting of the muscle is another big symptom. So these two symptoms, you can diagnose that this tumor is not some malignancy, or this is the most benign tumor of the body, and you can remove it radically and you can remove it effectively. This is another tumor which you can see there is a bulge over the lateral part of the face. This is in the posterior cranial fossa, this tumor. Then it is in the middle fossa, then the infratemporal fossa, then along the division of the trigeminal nerve. So along in all the 4 compartments, this is of course a rare situation, but this was one of these kinds of tumor. So in my series, many of these tumors, you see type A is only in the middle fossa, type B is only in the posterior fossa, type C is dumbbell shaped, type D is when there is an extracranial extension. So trigeminal neurinomas can be very small, as you can see here, or they can be huge. You see, huge trigeminal neurinoma. As I mentioned, even small trigeminal neurinomas, the symptoms are classical, and even in the large, they are classical, numbness. Many of these tumors are soft and necrotic. You see cystic changes, necrotic changes, going extracranially, going in the infratemporal fossa, along the foramen rotundum, in the infratemporal fossa. These tumors, this division of the trigeminal nerve, this is a benign tumor, large tumor, but benign, and this is a trigeminal neurinoma. This is another huge dumbbell-shaped trigeminal neurinoma you can see, and necrosis is the key feature. This is common in trigeminal neurinoma. Necrotic change, not, you see, they are like neurofibromas and schwannomas, firm, nodular, but necrosis and soft cystic changes are frequently identified in trigeminal neurinomas, like you see in this case. So many of the tumors in my series have been very huge and large. The other very beautiful trigeminal neurinoma, you see there is a cystic change. This is a whitish cyst, and this is like a craniopharyngioma. No other tumor. This is a contrast enhancing firm part, and this is the cystic part. Samay, you can hear me properly? Samay? John?
Yes, we can hear you.
Okay. So there are 2 components. There is the largest cyst here, and this is in the middle fossa. Another beautiful feature that I'm showing you is this is the cyst, and there is a fluid level. There is a fluid in the cyst, and there is a fluid level in the cyst. So this is uncommon, but it is seen in trigeminal neuroma, this kind of fluid level. Now you see carefully this tumor going in the middle fossa, and there are multiple fluid levels in this tumor. You see there is a fluid level here, there is a fluid level here, and there is a wall of the tumor. So this is a trigeminal neurinoma with fluid levels. You carefully see this tumor, and you see there are many fluid levels in this tumor. You see here, here, here. So multiple fluid levels in this tumor. And I have to tell you that tumors with fluid levels like this, it may be due to bleeding within the tumor or due to the consistency of the tumor, the proteinaceous content of the tumor. And whenever you have a fluid level, these tumors are more aggressive in nature, and the recurrence rate is much higher in these kind of tumors. Bilateral tumors, neurofibromatosis is always associated with bilateral trigeminal neurinomas. You see, but which tumor to operate and which tumor not to operate. In neurofibromatosis, you don't have to operate all the tumors, but bilateral is a frequent observation in NF2s. You see another NF2 case, there is an acoustic tumor, huge acoustic tumor, and on this side, and there is a trigeminal neurinoma on the other side, and you see they are almost touching each other. So this is a very beautiful case for your visual delight, and you enjoy seeing this slide. They are almost kissing each other, acoustic and trigeminal. I don't think such a beautiful case has ever been shown in the literature. This is another case of NF2 where there is a trigeminal, there is an acoustic neurinoma, there is a facial nerve neurinoma, there is a sixth nerve neurinoma, there is a fourth nerve neurinoma, and there is a trigeminal neurinoma. So there are multiple neurinomas in this patient, and you can see this kind of in NF2. Now you have to decide which tumor to remove, which not to remove. Of course, this is a very important decision. This is a bilateral NF2 trigeminal neurinoma, and you see there is ossification in the tumor. There is bone formation within the confines of the tumor, and in my series of 300 cases or more, I have identified ossification in trigeminal neurinoma in 4 cases. So ossified trigeminal, this is a beautiful, this is an extremely rare kind of a situation. Now, this is a trigeminal neurinoma, and this is a retroorbital tumor. This is retroorbital tumor is a hemangiopericytoma, and this is a trigeminal neurinoma. So this trigeminal neurinoma associated with another tumor related to the eye. We had thought that both the tumors are same, but this was different and this was different. And we operated, you see, this is a highly vascular tumor, and we removed first this orbital tumor and then this trigeminal neurinoma and this tumor. Both these tumors were removed. And I have a follow-up of this young boy for more than 24 or 25 years, and he's completely asymptomatic. Of course, he does not have vision in the affected eye. Many of these trigeminal neurinomas are in middle age group people. You see many of these in my in middle age group. Very rarely we reported in infant, you see 18-year-old child with tumor and presenting with proptosis. This was I reported several years ago, 25 or 26 years ago. So the more important thing is how to diagnose these tumors. They have characteristic clinical features. Symptoms of trigeminal nerve involvement like numbness in the distribution is very important and characteristic, and wasting of the temporalis muscle and masseter muscle is very characteristic. Wasting. So if you have these 2 features, it is a trigeminal neurinoma, and accordingly you have to operate. So motor and V1 is quite commonly involved. V2, V3 and motor is quite commonly involved. And there are various kinds of symptoms. Most important is almost 100% numbness, almost 100% wasting. And you will see one very important symptom that we reported, pathological laughter. You see, in this kind of large dumbbell-shaped tumor, we reported 4 cases where the patient presented with the primary symptom of pathological laughter. They have characteristic radiological features like petrous apex is eroded, carotid arteries always displaced medially. They are confined to the dural spaces as I have mentioned to you. In my own series, we had made errors in diagnosis, like we thought this was a trigeminal neurinoma, but this was a tuberculoma. We thought that this was a trigeminal neurinoma, but this was an aspergilloma. We thought that this was a vascular trigeminal neurinoma, but this was a hemangiopericytoma. So trigeminal neurinomas will never be vascular like this. So if you have a vascular thing like this, it is either a meningioma or some other kind of tumor. In 1991, 30 years ago, I had thought that this was a trigeminal neurinoma, and we had attacked this like a trigeminal, but this was a heavily vascular tumor, and this was a cavernous hemangioma of the cavernous sinus. You see the carotid arteries encased by the tumor. Such encasement will never be there in trigeminal neurinomas. So trigeminal nerve is a beautiful nerve located in the middle fossa floor and surrounded by a very firm and sturdy dura. And that makes it relevant. This dural relationship makes the surgery, and you have to design your surgery according to what you understand about the dura. So surgery on trigeminal neurinomas in 1992, so 30 years ago, my own understanding and understanding of the world at that time was these tumors should be removed in 2 stages. It was Malice who said for the first time that these tumors can be removed in 1 stage by a middle fossa approach. But in 1992, my personal feeling was that these should be removed in 2 stages. First, the larger tumor should be removed, and then the smaller tumor should be removed. So here you see, first I had removed the cavernous portion of the tumor, and then I removed the middle fossa tumor. So this was a 2-stage surgery in 1992, 30 years ago. In 1992, similar trigeminal neurinoma, I first operated by posterior fossa route, and I removed the posterior fossa component of the tumor, and then I removed the middle fossa component of the tumor. So this is a 2-stage surgery, which I was also doing personally, and the whole world was doing at that time. So then we design our own strategy that surgery for the middle fossa component, you have to play with the dura, and surgery for the posterior fossa component, you have to play with the dura and sometimes with the arachnoid. So this is trigeminal nerve. There is CSF around the Meckel's cave. This is the tumor. This is interdural, and many of the times this portion is also interdural. And this was extradural approach to cavernous sinus tumors that we described for the first time in the literature in 1997. Tumors for cavernous hemangiomas and for trigeminal neurinomas. Of course, then Vinko Dolan had described vascular lesions, and also for trigeminal neurinomas. But for intracavernous sinus, so we understood how the dural relationship of these tumors are. And this was my book, which was published in 1996, where we have discussed all these kind of things. So one sentence which I like to talk for last 35 years, that Alum al-Dimag from Arabic legacy, that meninges are the mother of the brain. This sentence is my very popular and very, I like this sentence because the tumors respect the dura. Now in 1995, I described this approach, infratemporal fossa interdural approach. You see, in 1995, what we did was we did not do any craniotomy. We just removed the zygomatic arch. You see the hands of the surgeon just widen the foramen ovale and remove this tumor. So this approach we described, infratemporal interdural approach, in 1995 for the first time in the literature. A tumor, which cavernous sinus tumor, which were considered to be very difficult tumors at that time, and even now, was removed without craniotomy. So this was a beautiful evolution of surgery of these tumors. So in my paper in 1995, I had shown some pictures. So this was the tumor, small tumor, which was removed by widening of the foramen ovale without craniotomy. Now you see, beautiful, in 95 article, I had shown the tumor which is going in the posterior fossa. I had done without craniotomy, just open the dura, work interdural, and follow within the Meckel's cave into the posterior fossa. And this is my craniotomy, just widening of the foramen ovale without doing any temporal craniotomy. So I think in the growth or development of trigeminal neurinoma surgery, this was one very important article. This was also in the same paper of mine in 1995, which the tumor we had removed without any craniotomy by infratemporal interdural approach. Of course, now I don't do that approach because now I like to come subtemporal, open the dura, work within the dura, demolish the tumor, work, respect the dura, don't coagulate unnecessarily, and most of these tumors can be removed in 20-25 minutes or half an hour, not more than. If I remove a trigeminal neurinoma in more than 1 hour, it will be a very difficult trigeminal neurinoma. I don't do that. So this is acoustic tumor. It arises from the internal auditory meatus. Like trigeminal neurinoma arises from the Meckel's cave. And then this tumor grows. So I am still studying the dural anatomy of this tumor. I will like to discuss this dural anatomy later. Now this is another C2 ganglion. This is C1 arch atlas, C2. This is C2 ganglion. This is similar to trigeminal nerve. This is the largest ganglion of the spine. Gastrin ganglion is the largest ganglion of the brain. Here the tumor, when the tumor C2 neurinoma arises, it arises outside the dura and behind the bones, behind the joint. And there is a well-defined dural cover of these tumors. So I had published this series. Let me, I'll show you that. Like trigeminal neurinoma arises from the Gastrin ganglion. It is in relationship to cavernous sinus. It is in relationship to the carotid artery. C2 neurinoma arises here. It is in relation to vertebral artery. It is related to the venous plexus here. Now you see this drawing in this is trigeminal neurinoma. This is C2 neurinoma. This part we had discussed that this is interdural, and this part we had mentioned intradural in my article. So this part is, now we are quite convinced that this part is also intradural. The whole tumor is intradural. You don't have to do laminectomy. You open the dura here. You don't have to expose and control the vertebral artery. You work within the dura and work within the dura, and the whole tumor can be removed in very quick time. So this whole tumor is interdural, working within the dura, working within the dura. You can remove this tumor in 10 minutes or 15 minutes, like trigeminal neurinomas. So bilateral C2 neurinomas, like bilateral trigeminal neurinomas. So this is how I have developed. In 2008, I had studied 60 cases of C2 neurinomas, where I had said that this part of the tumor is intradural. And in 2018, I studied another 50 cases of C2 neurinoma, where I said that this part is also interdural within the dura. So the whole tumor is interdural. You work within the dura and you remove this tumor. So this was my understanding. So this is C2 neurinoma, very similar to trigeminal neurinoma. Another tumor which I discussed is oculomotor nerve neurinoma. You see, this is a large oculomotor nerve neurinoma presenting with oculomotor signs. And we discussed for the first time in the literature that this entire tumor is interdural in location. You work within the tumor, don't try to remove dura, and you can save the third nerve. You see, interdural oculomotor neurinoma. So our philosophy is that these tumors arise in the oculomotor cistern, and the dura covers these tumors. So this is interdural tumor. You work within the dura, and you can save the third nerve function, which has never been reported in the literature. So third nerve neurinoma arises in the oculomotor cistern. And you see there is a beautiful dural cover that you have to protect during the surgery. Demolish the tumor, learn the art of breaking the tumor without coagulation, and you can save the third nerve fibers. Sixth nerve neurinoma is within the cavernous sinus, and when carotid artery is encased, it is sixth nerve neurinoma. Now you see beautiful, I am showing you seven nerves. Seven nerve arises in the region of geniculate ganglion, and the whole tumor is interdural in location. You come from lateral, you demolish the tumor within the dura. Do not try to remove this dura. Try to work safely around the facial nerve, and you can probably save or improve the facial nerve function. I'm not saying I have improved the facial nerve function, but the thing is, you can make the surgery very simple. These are soft and necrotic tumors, and you can do a very rapid fire job. This is seven nerve neurinoma. Work within the dura and don't try to remove this dura, and that forms the basis of my surgery. This is another seven nerve neurinoma that we have removed. This is immediate postoperative period scan. Same strategy. You see, interdural for lower cranial nerve schwannoma. Lower cranial nerve schwannomas arise in the region of the petrous bone, and then the whole thing, even the posterior fossa component of the tumor, this whole thing is covered by the dura. So take a transverse incision, work within the dura, and that is the way you can improve the function of the lower cranial nerves. And there is no question in my mind that you can do a radical job but preserving the dura. And if you demolish the dura, you will take the lower cranial nerve. So these things are discussed in my articles on the subject. Now coming back on trigeminal neurinoma, in 1996, I published this article where we said that you can do a basal temporal craniotomy, removal of the root of zygoma, roof of condyle, roof of external ear canal, partial mastoidectomy. This is the approach I discussed in 1996. I do not use this, but this was at that time. Dr. Sameh, you stop me whenever you want to stop me, okay?
Just 5 minutes, see.
5 minutes.
5
Okay,
minutes.
so let me go rapidly now. So this is the approach I had described, basal extension for middle fossa approach. This was the incision, which was quite a new incision. Temporalis muscle was rotated anteriorly, and then this bone work was done, mastoidectomy was included, and this was a beautiful exposure, and then work interdural, and this was the exposure. So basal so this is the craniotomy, this is the root. This was a very big craniotomy at that time. I don't do such big thing now. So this is the root, and this is the condyle and mastoidectomy. I don't do all these things now. So this currently I use just this exposure, splitting of the temporalis muscle, do a smallish craniotomy here. In tumors which are located anteriorly in the middle fossa, I take the craniotomy little anterior. So this is my work. So this is the tumor, and you see, I don't want to show the videos because this, you have to learn the art of demolishing this tumor, work within the dura, and you can remove these tumors beautifully and effectively. You see, now I will show you several preoperative. You see, they are eroded. There's never a need to drill the petrous bone. There's never a need to drill the anterior clinoid process. Just come from here or middle fossa, take lateral position, cut the dura like this transversely, and then work within the tumor, and you can do a beautiful resection. This is preoperative, postoperatively. Tumors which are located middle fossa, I come little bit anteriorly and then retract the dura and then work within the dura. So this is another tumor, preoperative, postoperative. I don't want to show you the video, unfortunately. This is the tumor, and you see this tumor has already eroded the anterior clinoid process and the petrous bone. There is no need to drill these things. This is preoperative and postoperative. You see the beautiful tumor resection. This is a smallish tumor, which is of course a relatively simple tumor. This is a huge tumor where you can work within the dura, and remove this tumor very beautifully. So tumors which are going in the posterior fossa, you can make a tentorial dural flap and work either through the Meckel's cave or make an incision and then work within the dura. So this is the tumor. You see, this is a gem of a tumor for a skull-based surgeon. And I have already told you that learn the art of breaking the tumor, learn the art of demolishing the tumor without extensive coagulation. You should save the fifth nerve fibers. If you don't save the fifth nerve fibers, it is a complication of surgery. You see this huge tumor. This is another big tumor. You see how the petrous bone and anterior clinoid are eroded by the tumor. This is another tumor. You just enjoy these tumors and see the world of trigeminal neurinomas. And this is a multi-cystic tumors. As I mentioned to you, there is a possibility of recurrence of these tumors. Even when there is a nubbin, this nubbin is not intracavernous. This is between the dura. You work within the dura and make a beautiful total resection of these tumors. You see, eroded. There is no need to drill the petrous bone. Work within the dura, respect the membranes, and you can do a terrific and beautiful job even for these massive tumors. And when there is necrosis, when there is cyst, there is a possibility of this immediate postoperative total resection of these tumors. You see, what is more important is preservation of the trigeminal nerve. Believe me, you have to preserve the trigeminal nerve. And if you know how to break this tumor, you can rather easily preserve the trigeminal function. I am saying not preserve. You should improve, like acoustic tumor. You should all the time worry about the trigeminal nerve. And you see many of these tumors look very similar. Erosion of the petrous apex. And these are the tumors which have been beautifully resected, as you can see. So this is another tumor. This is a smallish tumor. This is a biggish tumor. This is a little bit okay kind of tumor. This is a large tumor. And you see, you have to see how these tumors, another big, huge tumor, work within the dura, respect the dura, no matter how big this tumor becomes, it is dura respecting tumor, and you have to remove this tumor accordingly. So this is another huge trigeminal neurinoma, which has been removed, which has been demolished by a beautiful surgery. This is another tumor. Now, you know, more recently for these large tumors, I come even supracerebellar approach I am doing. I will show you some of these cases. Cystic tumors, you have to remove, you see, completely respect the dura and remove this radically, because recurrence rate, this tumor, the recurrence, this is recurrent same tumor, and then you have to work. Even the recurrence is within the dura. That is a beautiful, I will show you that article. And this is a recurrence of another cystic tumor. And then this is, I reoperated and removed this tumor. So cystic necrotic tumor, some trigeminal neurinomas go in the posterior fossa, and nowadays I do them supracerebellar and retrosigmoid approach, and then follow this tumor in the posterior, in the Meckel's-Cave. So this is that kind of approach. This is another tumor by supracerebellar approach, resect the tumor, go along the Meckel's-Cave and remove this tumor. So you see, this is another tumor strategy which I am using nowadays for tumors which are going very much posterior or very much downwards. This is in the cavernous sinus. This is another similar approach I used. You see how this tumor I have removed from the supracerebellar approach. This is another tumor by supracerebellar approach. This is another tumor by supracerebellar trigeminal approach. This is another one by the same, which I am recently liking it very much. This is also supracerebellar and removal of even the cavernous sinus portion of the tumor. So extracranial tumors which extend, you can do by, you know, reverse skull base. Even the extracranial part is within the dura. That is beautiful understanding. This dura is present even in the extracranial part of the tumor. I wanted to show you, just see, Samay will allow me a few more minutes because he's my good friend, and Samay likes to see these cases. You see how the dura is covering the middle fossa, and also the extracranial part of the tumor, the dura is covering. This is a very old slide of mine. I don't like to show such blood and all those things, but I wanted to show you the dura. You see, this is the middle meningeal artery. Let me show you the dura. You see how this is the, I have drilled this part, and the dura is covering even the extracranial part of the tumor. And then you have to take an incision. You see this, how the dura is covering the extracranial part of the tumor. Then you take the incision and work within the dura. So this was my paper. And here also you see it displaces the artery, and the tumor which is going in the orbit, you can work within the dura. And that is very important. Reverse transcranial approach. Transcranial for this, not from the nose and not from the ears and not from the mouth, but transcranial. Make a smallish exposure. You see this post-operative work within, have a beautiful control, respect the dura, and you can remove these tumors beautifully. You see this tumor, and there is a complete resection. This tumor, how it is covering the dura, and you see this, how it is going in the infratemporal fossa, 3-compartmental tumor, beautiful. Just a minute, my friend. You see, this is another tumor. You see, this is my smallish craniotomy here, and then I work extracranial and remove this tumor. This is another tumor in the going in the extracranial infratemporal fossa, removed by a smallish reverse Now, this tumor I showed you here in the 4 compartments, and I removed this tumor. Here is the video, but somebody is saying no time. This is another tumor. And you see these tumors have been removed very effectively and beautifully by a reverse transcranial approach. Now I want to show you apoplectic. When the tumor recurs, even the recurrence is in the dura. You see, this is a recurrent tumor within the dura. And you see how I have resected this tumor within the dura. This is a tumor, and I have resected within the dura. This is a recurrence also in the form of apoplexy. So I don't want to continue further. Chordomas are different, and trigeminal neurinomas are different. So thank you, my dear Samay. I hope I took you to another world of trigeminal neurinomas. I hope you have enjoyed this world of trigeminal neurinomas. This is a beautiful tumor for a skull-based surgeon. And, you know, I just love these tumors. So thank you, Samay, for giving me this opportunity. And my best wishes to you. You are indeed contributing a lot like John is doing. John Bennett has taken neurosurgery in all the corners of the world, and you are his good friend and my good friend. Thank you very much.
Thanks a lot, dear brother, for this excellent presentation. Thanks again for your support for EWNC Academy. You have supported it a lot. We can make it without you, sir. Thank you, sir. Unfortunately, we can't take any questions. We can take it in the lunch to start the other lecture by Professor Yon Kai Shen. Thank you. Professor Shen, please start sharing your screen.
Hello, can you see my screen and hear me?
Yes, sir. Yes, it's okay. And you sound
okay.
Clear.
Hello, everyone. Now. Hello, everyone. I'm Yun Kai Zhan from Memorial Hospital in Taipei, Taiwan. It's my great honor to be invited to present in this skull-based congress. My ENT colleagues are Dr. Yin Biao Wang and Dr. Jiaxin Lin. Today, I'm going to present a case with trigeminal schwannoma involving middle cranial fossa and the infratemporal fossa. For my self-introduction, I finished my neurosurgical residency in Memorial Hospital in Taipei, Taiwan. I completed my skull-based training in University of Pittsburgh Medical Center, including observership and research fellowship. Today, I divided my presentation into 2 parts. The first one is about the patient and the surgery. The second part is about the literature review. About the patient and the surgery, this is a 58-year-old female. She had the past surgical history of breast benign tumor. She denied systemic disease. This time, she suffered from left ear fullness and the nasal itching sensation. Thus, she went to a local clinic for help, and in the local clinic, left oral tumor was noted. And then she was transferred to our hospital ENT clinic for further help. In our ENT outpatient department, the brain CT scan was arranged, and it revealed there is a space-occupied region in left side, the middle cranial fossa, and the infratemporal fossa. The tumor extends through the left side foramen ovale and expand it to much bigger than normal. Then we arrange the brain MRI for further evaluation. In T1 wet image, the tumor is relatively low intensity. In T2 wet image, it was high intensity. After gadolinium enhancement, we can see it was the well-enhanced tumor with some heterogeneous content. And by the coronal view, we can see the tumor was in the middle cranial fossa and the infratemporal fossa. And here is the left side, the foramen ovale, and it was much bigger than normal. And this is the sagittal view of it. Because the radiologist told us that the malignancy cannot be completely ruled out, So we arrange tumor biopsy first. We use the intraoral approach to remove for the tumor biopsy. This is the picture in the operation. We open the left side parapharyngeal space for tumor biopsy, and the pathology report was schwannoma with ancient change. Because the schwannoma is relatively benign lesion, so it is necessary for us to remove the tumor as much as possible. After discussion with the patient and her family, we arranged the second operation. The second operation have two parts. The first part is open approach, and we did the left total parotidectomy and remove the tumor in the deep parotid space. This is the pictures in the open approach. The blue rubber band loops the left side facial nerve, and here is the tumor. And after we remove the tumor, the cavity shows no significant residual tumor. Then the second part of our second operation is endoscopic endonasal left transpterygoid approach with left and anterior transmedia approach. We goes into left side nostril first and identify crystallized modalis and the sphenoparietal foramen. Then we coagulate sphenoparietal artery. After coagulation, we cut it, and then we can open the left side, the pterygoparietal fossa. Here we can see the periosteum of the left side pterygoparietal fossa. Then we came out and then make an incision just above left side canine. We goes all the way down to the bone, and then we did the subperiosteal layer dissection, and to find the canine fossa, and made a puncture to make a hole at the anterior wall of mesoid sinus. After that, we can introduce some instrument through the mesoid sinus to the pterygoparietal fossa. Because we need to introduce several instruments several times during the whole surgery, so we use a big Foley catheter to protect the soft tissue around the hole. Then we try to remove the periosteum at the left side, the pterygoparietal fossa, and also we remove the soft tissue within it. After we remove the soft tissue and the periosteum, we can find the internal mesoid artery. Then we coagulate it and cut it. After we cut it, we can go further to find the lateral pterygoid plate, and goes upward to find the infraorbital fissure. And also we can identify the infraorbital nerve. Then we go further to find the tumor and the anterior division of B3. Because the bone will obstruct our surgical corridor, so we remove the lateral pterygoid plate to facilitate the tumor removal. Then we can expose the tumor capsule better. Then we coagulate the tumor capsule, and then we open it. After we open the tumor capsule, we can try to do the internal decompression. The tumor was soft and the color was yellow. First, we try to remove the tumor in the infratemporal fossa. So we try to dissect the plane between the tumor capsule and the soft tissue around it. Then we go upward, try to larger the foramen ovale and identify the foramen rotundum. Then we remove the bone between the rotundum and the ovale and try to remove the tumor in the left middle cranial fossa. So during the dissection, we can see here is the middle fossa dura. And then we dissect the tumor from the middle fossa dura. After that, we can remove the tumor in the middle fossa. After middle fossa tumor removed, we can see here is the middle fossa dura, and this is the lateral wall of left side cavernous sinus. Then we go back to the infratemporal fossa to remove the residual part. And this is the final view after tumor removal. And then we came back and remove the Foley catheter and suture the wound. On the next day after the surgery, we can see the anterior wall of the mesenteric sinus. The soft tissue and the skin was not quite swelling. After the surgery, she felt the left cheek and the mandibular area numbness, pain, and paresthesia. But the symptoms improved gradually. 8 months post-operatively, she just felt mild left face numbness and itching. This is the post-operative image 3 months after the surgery. This is T1 wet image. And this is T1 coronal view. This is the T2 and the T2 coronal and the sagittal. After gadolinium enhancement, we can see there was no obvious residual tumor in the middle cranial fossa and the infratemporal fossa. By the coronal view and the sagittal view, we can see that no significant residual tumor. About the literature review, first we try to analyze which surgical approach will be better for the lesion at this location. For tumor in upper parapharyngeal space, there are several possible surgical approaches to remove the lesion at this location. In our first surgery, we used transoral approach for the tumor biopsy in the left side the parapharyngeal space. For tumor in middle cranial fossa, and there are several possible surgical approaches to remove the tumor at the medial aspect of middle cranial fossa, such as pterional craniotomy, FTOZ, subtemporal approach, lateral orbitotomy, and EEA and anterior transmesseal approach. This is a project that we did when we were in Pittsburgh, and we try to analyze to approach the lateral Merkel's cave by several different approaches, such as lateral orbitotomy and the transmesseal approach. And then we try to analyze the area of exposure between the V1 and the V2 as known as anterior medial triangle and the anterior lateral triangle, which means the area between V2 and the V3. We have the result like this. Lateral orbitotomy can provide us wider area of exposure in anterior medial triangle. And because of the trajectory of this approach, it can provide us an anterior to posterior surgical corridor. So if the tumor extends to the posterior fossa, it is possible to remove the tumor in the posterior fossa as well. By transmesseal approach, it can provide us a wider area of exposure in anterior lateral triangle, which means the area between V2 and the V3, and because of the surgical corridor, and if the tumor involves the pterygopartite fossa or infratemporal fossa, transmesseal approach can give us a better attack angle to remove the tumor at this region. This is the picture of our project. So if the tumor extends to the posterior fossa, lateral orbitotomy or transorbital can help us to remove the tumor at this region. But if the tumor extends to infratemporal fossa or pterygopartite fossa, transmesseal approach will be a better choice. How about endonasal endoscopic approach? If we want to go to the middle fossa through endoscopic endonasal approach, we need to go from medial to lateral. And then if we want to remove the tumor at the lateral wall of cavernous sinus or Merkel's cave, we need to curve back to the medial aspect after we go into the middle fossa. So at this region, where we can go is between the superior orbital fissure and the foramen rotundum, but the mesenteric strut will obstruct us to go medially. But by anterior transmesseal approach, because the surgical corridor and the trajectory is more parallel to the Merkel's cave and the lateral of cavernous sinus, so it can help us to be easier to remove the tumor at this region. In the article in Operative Neurosurgery 2017, they also told us that by EA transmessenger approach, it will be limited by the message strut to approach the Merkel's cave. Let's talk about anterior transmessenger approach, as known as canine fossa trepanation or modified Cutaway lock approach. In the Journal of Neurosurgery 2019, Pittsburgh team told us that there was a trans-Alice Sphenoid approach, which means by anterior transmessenger approach, we can go through pterygoparietal fossa and the infratemporal fossa to approach the lesion at greater wing of sphenoid. They divided the approach for 4 stages. The first stage is to enter into the mesoid sinus. The second stage is to expose the greater wing of sphenoid bone. The third stage is to expose the middle fossa. The fourth stage is to expose the Merkel's cave and the lateral wall of cavernous sinus. Let's talk about the first stage. This is the anterior view of sphenoid bone. So here is left side the pterygoid process. In the medial pterygoid wedge, we can see the median canal here. And the foramen lateral and the superior to the median canal is foramen rotundum. And the bone lateral to the lateral pterygoid plate is infratemporal crest. And the bone anterior to the sphenoid bone is the palatine bone. And between the orbital process and the sphenoid process of palatine bone is the sphenopalatine foramen. And the median canal is just behind it. And the space between the palatine bone and the pterygoid process is, we call it pterygopalatine fossa. And the space lateral to the lateral pterygoid plate and the medial to the infratemporal crest, we call it infratemporal fossa. And the maxilla bone is anterior to the sphenoid bone and the palatine bone. When we put the 2 maxilla bones together, the central hole of it is the piriform aperture. And the foramen below the orbit is infraorbital foramen. And here is the canine. If we look at the skull from the left inferior location of it, we can see here is the left side the zygomatic arch. And this is the lateral pterygoid plate. And here is the left side the mesoid bone. So the space between the lateral pterygoid plate and the maxilla is, we call it pterygomesoid fissure. And the space medial to the pterygomesoid fissure is the pterygopalatine fossa. And the space lateral to pterygomesoid fissure is infratemporal fossa. So about the canine fossa. The canine fossa means the area above the root of canine tooth and below the infraorbital foramen and the medial to the zygomatic buttress. So here is the canine fossa. When we want to approach the canine fossa, usually we make an incision just above the canine and cut the mucosa and then dissect down to the bone. Then we perform some periosteal dissection all the way up to see the infraorbital foramen and the infraorbital nerve. There are some nerves medial and inferior to the infraorbital foramen. This is the anterior superior alveolar nerve. And the ideal location for canine fossa trepanation is the area lateral and inferior to the anterior superior alveolar nerve. And we also call it sublabial enterostomy. Dr. P.J. Warmer in Australia proposed the modified technique of canine fossa puncture in several articles. And then Dr. P.J. Warmer also invented a canine fossa trepanation kit to perform the canine fossa trepanation. They also described the ideal point for canine fossa trepanation. They define it by 2 lines. The vertical line is the mid-pupil line, which will cross the infraorbital foramen. And the horizontal line is the lowest point of the piriform aperture. In this space, okay, thank you. This is the vertical line, and this is the horizontal line, and here is the ideal point for the canine fossa trepanation. And the canine fossa trepanation kit can help us to avoid the anterior superior alveolar nerve and orbit and the tooth the injury. When we goes into the mesoid sinus, we can go on the second stage. After we remove the posterior wall of mesoid sinus, we can expose the periosteal layer of the pterygopartite fossa. And then we can remove the periosteum of it and the soft tissue in the pterygopartite fossa. Then we can expose the vascular structure within it, including the branches of internal mesoid artery, and also the neural structure such as the mesoid nerve and infraorbital nerve. So this is the lateral pterygoid plate, and it means the pterygomesoid fissures here. So the area medial to it is the pterygopartite fossa, and the area lateral to pterygomesoid fissure is infratemporal fossa. And then we can dissect all the way down and find the mesoid nerve and the infraorbital nerve, and we can dissect the the lateral pterygoid muscle from the lateral pterygoid plate and the temporal base, and down all the way down to the foramen ovale and the mandibular nerve. So about the third stage, we can expose the middle cranial fossa. We can drill the bone at this region to expose V2, V3, and the temporal dura. The boundary of our bone drilling is inferior orbital fissure anteriorly, from rotunda medially, from ovale posteriorly, and the infratemporal crest laterally. So about the fourth stage, we can expose the Merkel's cave and the lateral wall of the cavernous sinus. We can dissect the plane between the preosteal layer and the meningeal layer dura to expose the Merkel's cave. So if the lesion is at the Merkel's cave and the lateral of cavernous sinus, we can do it by this approach. So these four stages can help us to complete the surgery. In conclusion, different approaches can help us for different lesion removal. For lesion in middle cranial fossa and the infratemporal fossa, endoscopic endonasal transpterygoid approach with anterior transmesoid approach is the ideal surgical choice for it. Multidisciplinary team with skull-based surgeons who are familiar with skull-based anatomy is mandatory for the skull-based surgery like this. I'm Yun Kai Zhan from Taiwan. These are all my presentations. Thank you very much.
Thank you. Is there any questions from panelists? Okay, thank you.
Thank you very much.
Thank you.
Thank you.
We will shift to our next speaker, moves to Sebastian Liao. Please share your screen.
Okay. Can you hear my sound?
Yes, excellent sound.
It's okay.
Okay. Okay, good night, dear colleagues. I'm Sebastian Liao from Taiwan, and today my topic is a pretemporal transmechos cave approach for a large petroclival meningioma. And this is my CV, and I had my training in Taipei Veterans General Hospital, Taiwan, and I've been a faculty in the WFNS 2017 as a moderator, and been an assistant in a cadaver dissection course is sponsored by Oscar Lab Academy. And my main publications is about the CTA, using CTA to diagnose the paraclinoid aneurysm. And the second one is today's speech. And it's my honor to have the chance to give a talk. And I have no disclosure. And this paper was published in 2018, and I have to thank my mentor, Sanford Su, and he's also the next speaker, and I learned a lot from him. And first, I showed this image. Everyone sees this tumor and may have his own way to operate this large petroclival meningioma, a 5.5 plus 5 cubic centimeters. And we can see that this tumor extended into the Meckel's cave and encasing the basilar artery and pushing the midbrain, the brainstem severely. Today, Professor Sami has also talked about the retrosigmoid approach, and now today this approach is Transmeckel's cave, and this approach is consisted of two approaches. It's the Lank approach and Kawase approach, and just like previously mentioned, Kawase approach is a limited exposure. It has to be combined with other approach to gain more surgical corridor to treat a large petroclival meningioma. And the concept of this approach is combined the Lank and Kawase approach, and we call it a pretemporal transmeckel's cave transtentorial approach. And it is paramount this approach to open the Meckel's cave and incise the tentorial incisura to create a paramount view to the suprasellar and interpetuncular and posterior fossa spaces. And it is important to remove the ACP and petrous apex and connect the two dots together. It means that we incise the tentorial incisura and open the Meckel's cave, so we can remove the tumor from the anterolateral approach from middle fossa to posterior fossa. And this is our surgical incision. It is a traditional terional approach, and with additional zygomatic fracture, we create a trapezoid shape of a fracture bone of the zygoma, and we reflect it downwards to create more space. And after an interfacial dissection, we pull the temporalis muscle laterally to create more space. And now I show a video to demonstrate this approach.
Additional bone drilling was carried out down.
Can you hear this video, the sound?
Flatten the sphenoid wing and expose the periorbital.
Yes, we can.
Okay.
Cut the meningio-orbital fold. Open the superior orbital fissure. Peel the lateral wall of the cavernous sinus. Inject tissue glue between V1 and V2 for hemostasis. Coagulate and cut the middle meningeal artery. Expose V3 and GSPN. Perform the anterior petrosectomy. Check the location for petrous ICA. Remove ACP extradurally. Drill the optic strut and remove ACP. Finish the extradural bony work. This is the surgical view of Transmeckel's cave transtentorial approach in this case. We cut the dura from ACP tip to petrous apex. A T-shaped durotomy.
we performed a transmacroscopic transtentorial approach. Dura propria was peeled to the edge of incisura. The dura was cut along the green dots. Use CUSA to debulk the tumor. Cut the falciform ligament and distal dura ring for ICA mobilization. Dissect the superior surface of the tumor away from the third ventricular floor. Expose the ACA and MCA. Continue debulking. Dissect tumor from the space created by anterior petrosectomy. Remove the tumor invading Meckel's cave. Cut the tumor base. Dissect the tumor from the brainstem. Dissect around the tumor. And finally, remove it.
You can see that from this video, we can achieve a complete total resection of the tumor, and it is not necessary to use a retraction. And from in this paper, we conclude that the VGH experiences from 2014 to 2017, there are 18 patients, and the mean size, we only include large petroclival meningiomas. The dimension, whether it's width, length, or height, are all above 3 centimeters. And the mean tumor size preoperative was all over 4 centimeters. And the results was the preoperative was about 4.3 centimeter, and the post-op is less than 1 centimeter. So gross total resection in 7 patients, near total resection more than 95% in 7, and subtotal resection in 4. And about the complications, there's no post-op hemiplegia, no surgical mortality, but there's some facial nerve palsy noted in this approach, because we mobilize the oculomotor nerve. So all of the patients had transient facial nerve palsy, oculomotor palsy, resolved in 3 months, and 3 had 4 partial palsy and 6 transient palsy in 2 patients. And we have 3 patients with hydrocephalus and 1 have CSF otorrhea who required a second repair surgery for the CSF leak. And the conclusion is that pretemporal transmucous cave approach, in this approach, we combine the Lenk and Kawase approach, and it is important to incise the tentorial, to cut it open and to release the whole space from the middle fossa to posterior fossa, which led us to have a panoramic view from the suprasellar, interpeduncular, prepontine, and upper half of the clival regions without overtraction. But this approach also has some limitations. As to the posterior fossa, the CN 7 and 8 are the lateral and lower limits, and the Dorillo canal is the medial limitation of this approach. And this is my talk. Thank you.
Thank you, Dr. Sebastian, for your nice lecture. Is there any question from panelists? Thank you. We will shift to our next speaker, my dear friend, Professor Sanford Hisso. I'd like to thank him also for his great effort and help for me to put this Congress together. Thank you, Professor.
Thank you, Dr. Same. Could you hear me and see my screen?
It's okay.
Yes, it's my honor to join Dr. Same's well-organized skull-based Congress, and very pleasure to meet all the masters in the world. Today, I would like to talk about how to safely open the cavernous sinus, and I will show some videos about the symptomatic intracavernous aneurysm as illustrated cases. And I'm from Taipei Veteran General Hospital, and actually I have done fellowship at UMass Little Rock since 2007 and to 2009. And it's my fortune to have 3 great mentors, Professor Yasagil and Professor Mapti and Professor Ali Krisht. I learned a lot of concept and techniques of microsurgery and approaches to the skull base, especially in the cavernous sinus. Also, I learned a lot from a lot of friends, Professor Yoha, Professor De Oliveira, and Professor Zelenk. And as I mentioned, as my colleagues, Dr. Wang, and we did a lot of studies in the lab about the anatomy of the cavernous sinus. But actually, the anatomy is not just the terms to memorize, but you have to know how to utilize this anatomy to your surgical routine. So you see the beautiful pictures as a lot of friends and speakers are showing, but it is real that you can really approach this so-called no man's area like a cavernous sinus, as you have done in the lab. Actually, because of the advance of the microsurgical techniques and the knowledge about the anatomy, actually we can do surgery in and around the cavernous sinus as you have done in the lab. And like Dr. Liao mentioned, I always using the pretemporal approach to the cavernous sinus, as I learned from my mentor, Dr. Krisht. And it's a little bit different from the Trigeminal approach. You just lower the temporal muscle down to the zygomatic notch because you need more space in front of the temporal region. And sometimes you need to cut the zygoma and to facilitate widely exposure to the lateral wall of the cavernous sinus. And I always mention that because we have the double layers of dura overlying the lateral wall of the cavernous sinus, the temporal dura actually is attached to the wall, the lateral wall of the cavernous sinus by two strips. One of them is the meningio-orbital artery within the dura folds, just beside of the superior orbital fissure. So you need to coagulate and cut this dura fold to expose the superior orbital fissure as the first step to expose the cavernous sinus. And you can always find the dura groove, the beginning of the double layers of dura just beneath the superior orbital fissure. And I'm always using the sharp dissection to keep the plane between these two layers of duras. And then I are using the blunt dissection to push the dura backward, like you're peeling the banana, and just to expose the first two branches, the trigeminal V1 and V2, and you can also see the trochlear nerve and until the tip of the anterior clinoid. If you need to widely open the cavernous sinus, you have to turn your microscope to the second strip of the dura. The second strip is actually the middle meningeal artery. You need to coagulate and divide this artery to expose the V3, and you can see the foramen overlay, and you can dissect the dura backwards further, and to expose the GSPN and the anterior petrous region, so-called Kawase triangle. So in this way, you can totally expose the lateral wall of cavernous sinus. So you can see the anterior clinoid, the trochlear nerve, and all three branches of trigeminal, Gastrin ganglion, GSPN, and the anterior petrous region. Since you already make the space outside the dura, and if you turn the dura flap like usual as we did in the Trigeminal approach, then you will lose the space of the exposure. So it's reasonable that you cut the dura along the cilium fissure down to the base and extend the incision bilaterally. One is towards the optic nerve, one is toward the tenderine caesura, like this way. So I simply introduce how to the basic techniques, how to expose the cavernous sinus lateral wall. But as you have known, the cavernous sinus is a complex anatomic structure, including the dura, skull-base bone, venous channels, and neurovascular structures. But you have to keep in mind that all these structures, you have to keep some landmarks as a navigation during the surgery. For example, the dura, you have to familiar with the structure of the inner ring, outer ring, tentorium. And for the bone structures, you have to know how to deal with the anterior clinoids, or sometimes you need to remove the anterior petrous bone, like you did the Kawase approach. And thus, of course, you have to know every neurovascular structure penetrating the dura into the cavernous sinus. If you are familiar with these landmarks of anatomy and you have based on the basic techniques to open the cavernous sinus, then you can do the level 1, and later I will show what is the level 1 techniques for cavernous sinus surgery. You can do the level 1 approach to the cavernous sinus. You know how to peel off the dura off the lateral cavernous sinus wall, and you know how to remove the anterior clinoid, and you know how to remove the dura rings. And based on your experience, you can do more advanced approach to cavernous sinus, like you can add, like a building blocks, you can add another blocks, like you can do the transmicroscope approach, transmicroscope, tentorium, like Dr. Liao showing the approach to petroclival meningioma. So with different approach to cavernous sinus, you can deal with a lot of the pathologies in or around the cavernous sinus. For example, you can deal with the trigeminal tumor like Professor Goel shown, and a lot of pathology, not especially the vascularization like a pecan, paraclinoid, basilar apex aneurysms, and some other difficult cases like a petroclival meningioma or chordoma. So based on my experience, I classify the learning curve in cavernous sinus surgery into four levels. As the beginners, you have to know how to deal with the tubular cancella or sphenoid meningioma, especially you have to done the Simpson Graham resection, or you have to know how to do with the ophthalmic pecan aneurysm. And with the time, you gather your experience, improving your techniques, then you can do the more complex like a trigeminal schwannoma or petroclival meningioma. In level 1, there are some key steps in each level of cavernous sinus surgery. For example, in level 1, like I said, you have to know how to peel off the dura. You have to know how to do the endocrinolodectomy and deal with the ring structures surrounding all these neurovascular structures. And when you are upgrade to level 4, you have to know and to deal with each of the neurovascular structure in and within the cavernous sinus and every corner of the cavernous sinus. So from level 1 to level 4, you can deal more and more area in and around the cavernous sinus. But in my lecture, I have to convey the most important message to the audience. That whenever you have done the different pathology in the cavernous sinus, you have to know that all these important neurovascular structure that when they penetrate in the dura into the cavernous sinus, there are always the ring-like structures surrounding these structures, which anchored this structure to the dura. So how to lessen the injury to all these nerves or widen the windows between these nerve and the vessels to facilitate the tumor removal or facilitate the inspection to the aneurysm, is that you have to free all these neurovascular structure from the dura, from all these ring-like structures. So you need to cut this ring structure surrounding this neurovascular structure so that you can free them from the anchoring points, and you can widen the windows, and you can lessen the traction-related injury to all these important structures. So in the past decades, I just showed some videos to tell you how I starting from the level 1 to the level 2 or level 3, and this is my learning curve. So this is the case I would like to show. The patient presented with the right itosis and actually is the intracavernous aneurysm, and the projection of the aneurysm is toward the oculomotor nerve. And so I removed the ACP and I cut the dura down to the base. So now you can see this is outer ring surrounding the carotid. This is a carotid. And I need to open the inner ring, so-called the inner membrane surrounding the oculomotor nerve to open the superior wall of the cavernous sinus and the clinal portion of the carotid. So you can see this is the clinal portion of the carotid, and you can also see the part of the aneurysm, and this is the distal neck of the aneurysm. So I have to deal with the outer ring. Actually, the outer ring and inner membrane, they are fused together in the dorsal aspect of the carotid, close to the oculomotor nerve. So you need to clean the outer ring very well, and you have to cut the inner membrane along with the oculomotor nerve. And actually, the clinal portion of the carotid is within the the membrane, the thin membrane continuous with the inner membrane, like this carotid is like a sleeve surrounding the carotid and is part of the cavernous sinus. So you can see some blood oozing from the superior wall of cavernous sinus. And sometimes you can inject the tissue into this space, into the superior wall of the cavernous sinus. And I try to dissect more of the inner membrane of the carotids and some part of the donor aneurysm, because I need to localize the proximal neck of the aneurysm. In this case, I prepare the proximal control in the neck region, because at that time, as a beginner, I don't know how to do the proximal control within the cavernous sinus. So I prepare the neck for proximal control. And I dissect the ring, the dura of the dome or the aneurysm to facilitate to mobilize the aneurysm. And as you can see, I inject the tissue into the superior wall of the cavernous sinus to minimize the bleeding, the oozing, to make a surgical field more cleaner. So I keep on dissecting the dome or the aneurysm of the medial wall of the cavernous sinus. Now I almost have the whole neck of the aneurysm, so I can put the pilot clip to catch the aneurysm. Since I control the aneurysm, so I can keep on dissection of the aneurysm of the medial wall of the cavernous sinus. I can have a very good inspection of the aneurysm, and I can push the aneurysm out of the superior wall of the cavernous sinus so I can see the proximal neck very well. Then I can put a final clip to totally obliterate the aneurysm. So in this case, this is the post-op photos. In this case, actually the patient came back to my clinic 6 months later, and actually the patient had a transient oculomotor palsy, worse than the presentation. But after 6 months, I referred the patient for acupuncture, and the symptoms totally recovered. And in this case, I learned how to open the superior wall of the cavernous sinus by I remove the endoclinoid, I remove the outer ring and inner membrane, and actually I free part of the anterior part of the oculomotor nerve, and to expose the whole neck of the aneurysm. So this is my the level 1 experience. But since I gathered my experience and improving my techniques, now I can deal with such more complex aneurysm than the first case. The patient also presented with ptosis. In this case, also I removed the ACP and widely exposed the lateral wall of the canum sinus. But in this case, I didn't cut the dura at the beginning. In this case, I opened the Parkinson triangle to get the proximal control. As you can see, I removed the outer ring of the carotids, exposed the distal neck of the aneurysm, and I opened the Parkinson triangle so I can get the proximal control. Then I can put a pilot clip and to inspect the proximal neck, and I try to coagulate the aneurysm to shrink the aneurysm, but it ruptured. But since I already had the proximal control, so I can control the situation. And then I put several clips over the aneurysm. Now I can open the dura and remove the ring overlying the carotids, so I can adjust my clips to totally obliterate the aneurysm. In this case, different from the first one, I know how to found the proximal control because I know how to open the proximal triangle to localize the intracavernous carotids proximal to the aneurysm. But in this case, I dare not to open the dura at the beginning because at that time I have not much of the confidence because I'm afraid if I made the premature rupture of the aneurysm, you may cause massive bleeding into the dura. So in this case, I keep the dura intact and I deal with the aneurysm totally outside the dura. And if I secure the situation, then I open the dura. But in this case, I learned how to open the lateral wall of the cavernous sinus. And this is the post-op photo. And actually the patient totally, after 6 months in the clinics, the symptoms of the ptosis is totally resolved. So in this case, I learned a lot how to open the lateral wall of the cavernous sinus by exposing the lateral wall of the cavernous sinus and opening the Parkinson triangle. So I can get access into the lateral wall of the cavernous sinus. And the third case is more complex than the first and the second one. So as usual, I thinning the lateral wall of orbit and expose the superior orbital fissure, found the meningorbital dura band and coagulates and cuts. And I can find the dura groove just beneath the superior orbital fissure using the sharp dissection. And keep the plane between the double layers of dura. So you can expose the anterior third or the cavernous sinus. Since you're already within the right plane of the double layers dura, you can using the blunt dissection to expose the V1 intraocular nerve. And you can see the bulging here is actually the aneurysm. You can see the V1 intraocular is overlying the dome of aneurysm. And I push the dura backwards until the tip of the ACP, and I remove in the ACP. I can see this is the optic canal. I skeletonize in the optic canal. You can see this is optic canal. So usually, if you detach the ACP from the spinal wing and optic canal, it is fragile. It easily can be taken off by the rongeur since the optic tract is fragile. So you can see this is carotid. And in this case, I open the dura because I want to see all the nerves penetrating in the dura. I have confidence in this case because I'm ready. So I remove the ring, outer ring, to expose the clinal portion of the carotid. I remove the inner membrane. Then you can see this is the aneurysm. I can expose the distal neck or the aneurysm. So I dissect the ring of the carotids and the dome or the aneurysm. You see, this is the distal neck of the aneurysm. Then I try to free the oculomotor nerve. You can see this is the oculomotor nerve within the dura. I cut a dura ring overlying the oculomotor nerve. And actually, this is the oculomotor triangle is in the posterior wall of the cavernous sinus. I remove all these dura ring structures surrounding the oculomotor nerve, try to free the oculomotor nerve totally from the wall of the cavernous sinus so that I can mobilize this nerve to widen the exposure to the aneurysm. Now I open the window between the Parkinson triangle, the V1 and the tracheal nerve. I open the Parkinson triangle. I localize the intracavernous carotid, and actually the 6 nerves underlying the V1. So now I have the proximal control. And also I open the space between the tracheal nerve and the oculomotor nerve because I need to mobilize the tracheal nerve so that I can see the whole neck of the aneurysm, because the aneurysm is just underlying the oculomotor, tracheal nerve, and V1. So I free, remember the tracheal is crossing over the oculomotor nerve. So I free, as you can see, since I free the oculomotor nerve, so I can dissect the oculomotor nerve off the dome of the aneurysm. This is oculomotor nerve, and this is dome of the aneurysm. So I can free, I need totally free the oculomotor from the SC zone to the supraorbital fissure. So it like the string of the guitar and is totally loosening. So I can mobilize the oculomotor nerve to widen the space. And now I can put a pilot clip to catch the aneurysm. And I can mobilize the tracheal nerve since I already freed the tracheal nerve. So I can dissect the dome of the aneurysm off the lateral wall of the cavernous sinus. And be careful of the 6th nerve underlying the V1. So now I can see the proximal neck of the aneurysm and also the proximal neck of the carotid. You can see I totally expose the aneurysm, so I can adjust my clip to totally obliterate the aneurysm. So in this case, as you can see, I almost exposed the whole segment of the carotid within the cavernous sinus. Since I already free all the nerve structures from the anchoring points to the cavernous sinus, so you can mobilize all these nerves that without overt traction over these nerves. So I widening all the windows between these nerves so I can see the whole segment of carotid and the whole configuration of the aneurysm. So in this case, based on the previous experience, I open the superior wall of the cavernous sinus, followed by the lateral wall of the cavernous sinus. Then I open the posterior wall of the cavernous sinus to free the oculomotor nerve, tracheal nerve at the beginning of the SC zone. So this is post-op photo. And also the patient came back to the clinic 6 months later. 你往前看，眼睛往上看，往右边，往左边，往下面。So the patient, the ptosis of the symptoms are totally recovered within 6 months. And this is another case. Again, I cut the dural fold at the beginning and thinning the lateral wall orbit, exposing the cerebral orbital fissure, and using sharp dissection to find the plane between 2 layers of dura and push the dura to expose the lateral wall of cavernous sinus. And you can see the bulging over the tracheal nerve and V1 overlying the aneurysm is a bulging here. And remove the anterior clinoid, thinning the optic canal, removing the ACP so that I can expose the superior wall of the cavernous sinus. In this case, I need to remove the optic strut because the aneurysm is more superiorly close to the cerebral orbital fissure, I need to remove the optic strut to facilitate the carotid mobilization. I open the cerebral wall, inject the TCO, and I open the dura. I open the phospholimon, and along with the outer ring overlying the carotid artery. And I totally open the cerebral wall by dividing the inner membrane along the oculomotor nerve. And also I open the Parkinson triangle just for the proximal control. Then I dissect the oculomotor nerve of the aneurysm dome using the similar techniques as the third case. I remove all these ring structures overlying the oculomotor nerve to mobilize the oculomotor nerve to widen the space of the cerebral wall and widen the space between the trochlear and oculomotor nerve to localize, to have a good inspection into the aneurysm. So you can see the bulging down beneath the oculomotor and trochlear nerve. So I need to free the oculomotor nerve and trochlear nerve so that I can dissect the nerve of the dome or the aneurysm. I keep dissection and made all these nerves slack. So now I have the proximal and distal control. Now I localize the distal neck of the aneurysm. I put the proximal control, distal control, and dissect the aneurysm and put a pilot clip and adjust the clip. Free the dome of the nerve, then I can adjust the clip. So this is a post-op angiography. And also the patient is doing very well after 6 months in the clinics. So in conclusions, anyone that would want to do the cavernous sinus surgery, as a lot of the speakers mentioned, we have start in the microsurgical lab. This is the beginning of your learning curve. Then we have to do the step-by-step following the learning curve. Don't jump to the level far beyond your experience and techniques, and otherwise you are causing a catastrophe to your patients. You just keep your level 1 and you are familiar with any kind of surgery within your level, then you will go further to the level 2, then to level 3 or level 4. And the most key steps in the cavernous surgery is free all the relevant neurovascular structure from where they are anchored to the dura rings. This is so-called unlocking the cavernous sinus, so that you can widen the windows between all these nerves, and you can mobilize these nerves without overt traction. And this is sums of the cavernous sinus surgery. And based on our results and experience, and we would like to thank Iskala Academy that they put our cavernous sinus course as the global courses. So Dr. Wei-Xin Wang and I, we just done the first course this year, and welcome all. If you are interested in the cavernous sinus surgery, in our course, we would show how to step by step by learning curve from level 1 to level 4, from the microsurgical lab to the daily routine surgeries. And thank you very much. And I would like to thank Dr. Samuel again to put me in this great congress, and hope in the future we can meet you all in-person meeting. Thank you very much.
Thanks a lot, dear brother, for your excellent lecture and your support. Is there any questions from panelists? Okay, thank you again, Professor Heso.
Dear Dr.
Now
Su,
we will shift.
dear Dr. Su,
Okay.
may I
Yeah.
comment? I'm Dr. Vikas from Bangalore, India.
Yes.
You have a fan. I've been spellbound seeing your videos. You are not only a fantastic surgeon, but a fantastic teacher. You know, within 15 minutes, I think you've changed my perspectives on the cavernous sinus and what is possible within the cavernous sinus. Thank you. It's been really enlightening. I've tried cavernous sinus, but you know, I look like a toddler in front of what work you've already shown. You know, I only disagree with your levels. Level 1 is way beyond most of our abilities, and level 5 is for gods. So you're a god. Congratulations. Thank you. And as I told you, I am a fan of yours. First time I'm seeing you, first time I'm hearing a presentation, a fan.
Thank you very much.
So much. Thank you.
And thank you. Thank you, Dr. Same. Thank you, everyone. Thank you.
Thank you, Professor Su. We will shift now to next speaker, Professor Mao Shi Wang. Please share your screen.
Good afternoon, dear colleagues. I'm Dr. Wang from Taipei Veterans General Hospital. Today, I'm talking the topic about translabracing approach and the retrolabracing approach for large cerebral proton angle tumors. This is my background of laparoscopic surgery training. I spent a year in Stanford with Dr. Robert Jackler and 3 months in Italy with Professor Maria Sana. I have nothing to disclose. As we know, surgical approaches for cerebral proton angle tumor, they are translabracing approach and the retrosigmoid or retrolabracing approach and the middle fossa and the transcochlear approaches.
Dr. Wang.
In type of
Dr. Wang.
Yes.
Please make your screen full screen.
Pardon?
Your screen not in view. It's stuck to the first slide.
You need to make the slide bigger. At the bottom, there's some options to make the screen full screen.
Okay.
Do you know where the options are at the bottom of your screen?
Bottom of my screen.
Can you show him, Sam?
Just activate this window, then press F5. F5.
Function 5.
Yep. Button for F5.
Oh,
F5?
F5.
Okay.
Is it okay now?
It's not big. Okay, you can press on the number of the slide.
Yeah.
Press on number of the slide.
Okay, you see the bottom of the screen next to 64? The bottom of the screen. There's a couple of icons there. There's a couple of icons there. You click one of those at the bottom next to 64.
Okay.
Yeah.
这样有了吗?
You got that?
这样有了吗？
So you see the icons next to the 64 at the bottom? Do you see that? You're saying, Sam,
PowerPoint
F5 does
It's-
it also?
It's okay.
这样有了吗？嗯，
Okay, well, he
Hey.
can continue like this, Sam. What do you think?
对对对，投影片播放，点了，哎，这样有了吗？我点了啊。我点那个64% 右下角的左边呐、我点了啊。
Okay, Professor Wang, we will shift to next speaker until you make it well. Okay?
Okay. Okay, sorry.
Never mind. Okay, we will shift to next speaker. Next speaker will be Professor Shin Hao Lee, and he will talk about endoscopic supraorbital keyhole approach for surgery corridor expansion. Please share your screen.
Okay, so can you see my screen?
Yes, it's okay. You can go now.
Okay. Ladies and gentlemen, thanks for the invitation of the chief of this wonderful congress. I'm the Chen Hao Li from the Far Eastern Memorial Hospital, Taiwan. And the topic I want to talk today is the endoscopic supraorbital keyhole approach for surgical corridor expansion. And this is the first scenario. This is a 40-year-old man with sudden onset of severe headache. And he came to our emergency department, and a non-contrast CAT scan showed a typical diffuse SH and mild hydrocephalus. The CTA study showed acon aneurysm, which pointing inferior anteriorly. And the hypoplasia of right side A1 segment is also noted. So we perform a supraorbital keyhole surgery from the right side for the aneurysm clipping. And this is a picture after we do neurotomy. And we open the optic-carotid cistern for releasing of the CSF and extend the opening of the cistern from the chiasmatic cistern to the left side optic nerve, and open the right side rectal gyrus and interhemispheric fissure to exposure the aneurysm. This is the aneurysm, and here is the acon. And this is the right side A2 segment. This is the left side A2 segment. Actually, this aneurysm is arising from the bifurcation of the left A1 to parietal A2 segment, and the acon is not involved by the aneurysm. So after the dissection of the aneurysm, we apply the clip, and after ICG study, we puncture the aneurysm and coagulate the aneurysm. So this is the end of the surgery. We can perform the aneurysm clipping via a small craniotomy with only about 2 centimeters. And we also remove the orbital ring for the looking from down to up for the aneurysm, better aneurysm visualization. And this is the post-op CAT scan. This is our craniotomy, and we can put a clip for the aneurysm clipping. There is no obvious residual and no new infection or hemorrhage after the operation, and the patient recover well. So how about the keyhole surgery? Donald Wilson is one of the first neurosurgeons who used the term of keyhole surgery. And he said that the ideal exposure is one which is large enough to do the job well, while preserving the integrity of as much normal tissue as possible. We make no fetish of keyhole surgery. So due to improvement of the surgical technique and the technology, we used to decrease our craniotomy size from the traditional terminal approach, subfrontal approach, to the supraorbital, orbital-zygomatic approach, or even mini-terminal or endoscopic approach recently. And how about the supraorbital keyhole craniotomy? It is a kind of anterolateral entry of the anterior skull base, and it can expose the ipsilateral frontal lobe, temporal lobe, sylvian fissure, and the cribriform plate, planum, tuberculum sella, paracella, and the medial aspect of contralateral frontal lobe. And the standard supraorbital keyhole is ranged from the supraorbital notch to the superior temporal line, and the distance between these two structures is only about 3.5 centimeters. Besides the standard supraorbital approach, there are also a median variation or lateral variation of the supraorbital approach. But due to the small craniotomy, the problem of the keyhole surgery is the dim light in the depth of the operating field. Like what we do for this patient, there's a dark light and the narrow viewing angles. And the small craniotomy also limits our surgical freedom of instrumentation. And this is a cadaveric study which compare the most popular keyhole, two kinds of keyhole surgery. One is a mini-terminal approach, the other one is supraorbital approach. And we can see that the area of exposure is much better in the mini-terminal craniotomy, and the surgical freedom also better in mini-terminal approach. But however, if we do more bony work, like we use the supraorbital craniotomy accompanied with the orbitotomy or even the sphenoidectomy, we can gain the same degree of freedom comparable with the mini-terminal approach. And besides, we can also extend our supraorbital keyhole approach to the temporal lobe to make the exposure of area of exposure much better than the classic supraorbital keyhole approach. What we have to do is just to add another 1 centimeter distal to our lateral skull skin incision, and we can elevate the skull flap as we do in the traditional terminal approach for the facial nerve preservation, and put a burr hole at the keyhole and expose the frontal and temporal dura and the sylvian fissure. With this approach, we can also do the pretemporal and exposure the lateral wall of cavernous sinus. And after durotomy, we can open the sylvian fissure widely and gain the space as much as terminal approach. So this is the cadaveric study which compare between the standard supraorbital eyebrow approach and the extended supraorbital eyebrow approach. We can see that the vertical angle of attack, it means the perpendicular plane of the sylvian fissure. The significant increasement of the attack angle in the extended supraorbital eyebrow approach in both ACOM, ICA, and MCA. And the area of exposure also increased about 6% on ipsilateral region, midline region, and about 30% in contralateral region. As compared with the mini-terminal approach mentioned before, the area of exposure is comparable with the extended supraorbital keyhole approach. But with this approach, we can avoid the complication of the mini-terminal approach, such as the pain when chewing or the temporal hollowing. How about the endoscope? Because the endoscope is the trend of current surgery field, not only in neurosurgery, but also in general surgery and the other kind of surgery. Then Professor Pernesky introduced the endoscopy assisted microscope. And if the endoscope provide our close-up and wide field and angle view, which can make us better visualization of the blind spot for the remnant tumor examination. Besides, we can also use the close-up view to evaluate the tumor interface between the brain and cranial nerve and the blood vessel. If there is severe adhesion between the tumor and the cranial nerve, we may leave a small piece of tumor to avoid avulsion of the cranial nerve to achieve the maximal safety resection. This is another scenario, and this is a 47-year-old woman with acute vision loss within 1 to 2 weeks. When she came to our department, the only light perception is noted, and the image study show a large cystic lesion over the sella, suprasellar, and prepontine system, and the left side cavernous sinus involvement. We do the extended supraorbital keyhole approach via the left side, and this is we use the microscope for the tumor excision, and the endoscopic assist is used for at the end of surgery to check if there is any neurovascular structure damage or the residual tumor. And we can see that here is the pons and the basal trunk with the dragonfly picture, and there's a bilateral oculomotor nerve, and there's a abducens nerve bilaterally. And here is the inferior aspect of the optic chiasm and the left side internal carotid artery. So this is the P cone, and this is the A1 segment, and this is the pituitary stalk. And this is the origin of the tumor. And the pathology is a brusky cleft cyst with cranial pharyngioma change. And this is the post-op image, and there is no adjacent neural structure damage after the surgery. But although the endoscopy assisted microsurgery is well known and popular in the neurosurgery, the evidence of the endoscopy assisted microsurgery is still limited. So this is the recent updated meta-analysis for the endoscopy assisted supraorbital keyhole approach for anterior skull-based tumor. It compared the endoscopy endonasal approach and the endoscopy assisted supraorbital keyhole approach and the microscopic transcranial approach of the olfactory groove meningiomas and the Trigeminal meningioma. As the gross total resection seems better in microscopic transcranial approach and less in the endonasal endoscopic group, but the visual improvement is better in endoscopic group. However, the CSF is still higher in the endoscopic group compared with the supraorbital keyhole and the transcranial approach, microscopic transcranial approach. And the intraoperative arterial injury and the 30 days mortality is all low in 3 groups. So according to this meta-analysis, it shows that the endonasal endoscopic group has the highest rate of visual improvement, but has higher post-op CSF leak. And the microscopic transcranial group has slightly higher instance of gross total tumor resection. And the endoscopic supraorbital keyhole group shows intermediate results. But due to the heterogeneity of the study, there is still inconclusive for the benefit of the endoscopic assisted keyhole surgery. So how about the full endoscope, since we can use the endoscopy assisted? So why can we use the full endoscope? And this is a 65-year-old woman with a hand fullness and transient blurred vision. She visited our neurology OPD, and brain MRI was checked for the consideration of possible intracranial lesion according to a neurological examination. And the results showed olfactory groove meningioma with the crista Getty and posterior wall of frontal sinus involvement. And according to the coronal view, we can see that he has a large right frontal sinus with extension of his right orbital roof. And the tumor has a lateral extension up to the orbital roof. So, and the relative flattening of the left side orbital roof. So we use the left side supraorbital keyhole for this patient because she still have the smell function, still have the olfactory function. And this is the operative video. And we relieve the CSF via the left side sylvian fissure first for relaxation of the brain. Then we expose the tumor. This is the tumor margin. And we dissect the olfactory nerve left side. Then the course of the olfactory nerve was dissected from the olfactory bulb to the more proximal side for relaxation of the frontal lobe. And devascularization of the tumor was performed. And this is the crista galli. This is the crista galli, and here is the posterior wall of the frontal sinus. So after detach the tumor from the crista galli, we remove the dura cover the crista galli until the end of the fox. And the crista galli was removed with the punch and drill bits. And this is the last piece of the crista galli. The tumor involved these areas is also removed. This is the removed tumor. And we open the dura cover the other side of the crista galli. And do the devascularization and detachment of the tumor from the dura base. And this is the posterior end of the dura attachment. We remove part of the dura that severely attached to the tumor, which may be the origin of the tumor, and keep the vascularization of the tumor away from the dura. This is the right side orbital roof. After complete detach of the tumor, dissection was performed along with the tumor capsule. We can see that the left side of the olfactory nerve is preserved. And this is the involved right side olfactory nerve. And after partial dissection, the tumor was removed piece by piece because the working space is limited. So this is the superior margin of the tumor, and the arachnoid plane is not clear between the tumor with the right frontal lobe. And this is the last piece of the tumor. So this is a picture after tumor removed, and the olfactory nerve was preserved, and the skull-based dura was repaired with the artificial dura graft and fixed with the tissue glue. So this is the end of the surgery. So the post-op CT scan showed that the tumor within the olfactory groove was removed totally, and this is the artificial dura we used to repair the dura defect here. And this is the craniotomy we performed for the tumor excision. So with the supraorbital keyhole approach, we can expose the most area of anterior skull base, but there are still some limited regions, including the anterior olfactory groove, intracellular space, and inferior space right under ipsilateral optic canal, and the interpeduncular and perimesencephalic cistern, anterior third ventricle, and ipsilateral medial fossa and medial temporal lobe. So with the endoscope assist, we can unlock this limited area, and we can expose the mostly of the anterior skull base with this kind of approach. So this is the other article that reported. This is they use the full endoscope for remove the intracellular Ruski cleft cyst. We can see that here is the tumor removed, and you can examine the diaphragm cella and the pituitary gland within the cella. And this is the cadaveric study, which shows that we can use the endoscopy via the supraorbital keyhole approach to open the lamina, use the translaminar approach for anterior third ventricle tumor excision. And furthermore, we can use the supra keyhole approach with extradural dissection and remove the sphenoid ridge to explore the temporal lobe dura and open the temporal dura to move the temporal pole tumor. So
Since we have many kind of the route for anterior skull base, when should we choose the supraorbital route? There is three major factors we should consideration. The first one is the patient-related factor, and we should consider about the presentation of the patient. Like our patient have the olfactory function, so we don't want to use the endoscopy endonasal approach to distract her cribriform plate, which may cause her complete olfactory loss. And the other kind patient-related factor is the patient preference. And as about the tumor, the location, the size, extension, and the character of tumor also make us choose different kind of surgical approach. And the most important is the surgeon's experience and surgeon preference of the surgical approach and our surgical goal. If we want to preserve the vision, preserve the olfactory function, or we want to do a gross total resection or just subtotal resection. It all interferes what we choose to use the supraorbital route or the endonasal route. This is a decision-making algorithm for minimal invasive approach to the anterior skull-based meningioma. And if there is a extension in front of sinus less than 50%, and there is lateral extension beyond the internal carotid and the lateral papyracea, we should use the transcranial approach like terminal, supraorbital, or subtemporal. If there is no lateral extension, we can use the endoscopy endonasal approach. But if we consider about the olfactory preserve, we should use supraorbital approach with endoscopy assistant. If there is no olfactory function and there is no cribriform plate invasion, we can also use the supraorbital approach with endoscopy assistant for the lateral extension tumor. And without the lateral extension or the posterior wall of frontal sinus involvement, we can use the endonasal endoscopy approach. And if there is a cribriform plate invasion, we should use the endonasal endoscopy approach for complete tumor excision, accompanied with the supraorbital approach if there is lateral extension. This is the other article discussing about the approach of the tuberculin sella with the endoscopy endonasal approach or supraorbital approach. And if the majority of the tumor is below the planum and the tuberculin angle is less than 135 degrees, that means there is a large angle of the tuberculin angle, and there is a minimal lateral extension and hyperostosis of the tuberculin. And we saw without medial optic canal inversion, we should choose the endoscopy endonasal. And if there is a tumor many above the planum and there is a flat tuberculin angle and there is a large lateral extension and no medial optic canal invasion, we should use the supraorbital approach. So conclusion, the supraorbital keyhole approach is a safe and effective approach for the anterior skull-based lesion. Additional with the endoscopy, we can have much more better illumination, improve visualization and mobility. And the endoscopy approach can also expand our surgical corridor, not only in the anterior olfactory groove, but also the intracellular inferior aspect of ipsilateral optic nerve, anterior cervical temporal fossa, with promising rates of olfactory preservation, vision improvement, and less CSF leak. However, in such limited craniotomy with endoscopic use, we need experienced trained assistant or co-surgeon to avoid sword fighting situation and to avoid a proximal neurovascular structure injury during the structure with passing the instrument through the operative route. Thanks for your listening.
Thanks a lot, Dr. Shin, for your nice presentation. And now, is there any question from panelists? Okay, now we will shift again to Professor Wang. Please start this screen sharing. Thank you.
Okay, I'm Dr. Wang from Taipei Veterans General Hospital. Sorry for the mistake. And today my talk is transablation approach and the retroablation approach for large CP angle tumors. This is my laparoscopic surgery training background. I spent 1 year in Stanford with Professor Jacqueline and 3 months in Italy with Professor Maria Sana. I have nothing to disclose. As we know, surgical approaches for CP angle tumor, there are translabyrinthine approach, Neurosurgical or Neurosurgical approach, middle fossa and transcochlear. In Taipei Veterans General Hospital, I do surgery with Dr. Sanford Xu with translabyrinthine approach and a Neurosurgical approach. For scalp-based tumor removal, the tumor are located in the centers of the skull. There are vital vessels and cranial nerves, so good surgical exposure is essential. Every millimeter bone removal counts for better surgical exposure. For translabyrinthine approach, the indications are for large acoustic neuroma with or without hearing, or for large meningiomas without use of hearing, and for large tumors such as epidermolysis or other tumors without use of hearing. For retrolabyrinthine approach, the indications are for large meningioma with use of hearing or other large tumors such as low cranial nerves, schwannomas, or epidermolysis with use of hearing. But not for large acoustic neuroma with use of hearing, because for large acoustic neuroma, the hearing preservation rate is really low. For translabyrinthine approach, the advantage are excellent access to the CP angle and the exposure to the facial nerves from brainstem to stylomastoid foramen. The disadvantage is we have to sacrifice hearing. For the surgical procedures, first we have to do a mastoidectomy. This is left ear. We can see lateral canal here, posterior canal here, and the jugular ball. Then we do labyrinthectomy. We can expose all the semicircular canals, and then we do labyrinthectomy. We can see endolymphatic sac here and the endolymphatic duct here. After labyrinthectomy, we remove more bones and we expose the internal osteotic canal. For large, very large tumors, we can do enlarged translabyrinthine approach with transapical extensions for large tumors. We can remove more bone superior to the IAC and then remove more bone inferior to the IAC. For large tumors like this with trigeminal nerve involvement, we can remove more bone superior to the IAC with this superior anterior transapical extension. After tumor removal, we can check the facial nerve. You can see these exposures. We can do more bone removal above to the IAC. And after the tumor removed, we can check the facial nerve integrity. So we can do this total removal of this large tumor. From the 2011 to last month, we did this approach with 76 patients. More than 60% of patients we can achieve very good facial nerve functions. About 9% patients will require gamma knife for further tumor control. Conclusions, translabyrinthine approach for CP angle tumors, we can have better exposures for large tumors. We can have good tumor controls and the facial nerve function preserved. Teamwork is the key for scalp-based surgery. We do this with one ENT doctors and one neurosurgeon. for retrolabyrinthine approach for CPU angle tumors, we have the advantage are that we can have chances of hearing preservation, and we have better exposures than retrostigmoid approach. But this exposure, we have less exposure than translabyrinthine approach. For this kind of meningiomas without ISC involvement, we can do surgeries mastoidectomy, and we have to identify facial nerve, and we can also expose the lymphatic sac and the posterior fossa dura. We do this approach to dissect down to the jugular bulb, and after all the bony work done, we open the dura and do the tumor removal. These are post-operative MRI. We can do total tumor removal with this approach. From 2013 to last month, we did 29 patients with CP angle meningioma. Hearing preservation was achieved in 26 patients, and almost all the patients have very good facial nerve function. The conclusion: retrolabyrinthine and the infralabyrinthine approach can be an alternative for lateral scalp-based lesions. Hearing preservation can be achieved in most patients, and teamwork is the key of scalp-based surgery. As my experience, temporal bone is like 3-level basement. The level 1 basement is mastoidectomy, is for all the middle ear surgeries. Level 2 here is for translabyrinthine approach, and the level 3, the deepest, is we do enlarged translabyrinthine approach with transapical extensions. Thank you very much for your attention.
Thank you, Professor Wang, for this lecture. Is there any questions from panelists? So for more discussion and for any questions, we can shift to the other Zoom room, lounge. And now we will shift to next speaker, Professor Hugo. Please start sharing your screen.
Yes, let me share the screen. Okay, it's this one. And the whole screen, I think is okay. Is it okay now? The whole screen?
Victor, perfect.
Okay, thank you so much. Thank you, Dr. Sameh and Dr. John Bennett, and all of you for this kind invitation to show this job. I have been working for almost 33 years at the Forensic Sciences Institute in Mexico City. So you invited me to talk about how to prepare specimens for studying skull base and some approach. I think that there is no secret to work with this kind of specimens. The only thing is that we should work in a fresh cadavers. So, for example, in these videos, I am showing the injection of some veins. In the left into the brain veins, and in the right into the veins of the spinal cord. The only secret or the only tip that we should know is to have a fresh specimen. So in this Forensic Sciences Institute, we have the opportunity to work in corpse in some persons that have died almost 24 or 36 hours when we can do the study, the research. So that's the reason you can see these videos as I am showing here. So sometimes I prepare these specimens, putting them in a formaldehyde solution, 10% formaldehyde and 90% water. And then after I cannulate these small veins and arteries to put some water, only a simple water. And then I am ready to inject these beautiful arteries and veins. In this video, I want to show you the injection of a posterior inferior cerebellar artery. So it's much better to inject the brain into the skull than to inject outside of the corpse, because you know, if for example in this video it's not possible to go to very small arteries because we have a leakage, for example in here. So if you push the silicone, we are going to have some leakage. So it's much better to inject these specimens inside the skull through the carotid artery or jugular veins in the neck. And if you have the specimen outside, you can also inject specific arteries like you are in here. For example, here we have a posterior inferior cerebellar artery, and this artery is going also to the other cerebellar hemisphere. So in that manner, we can find some specific morphology of the brain arteries. In this, I am doing a dissection of posterior inferior cerebellar artery that is coming from the left side of the vertebral artery. And here I am cutting this anterior spinal artery that are arising from both vertebral arteries. So this is very useful for knowing vascular anatomy of the brain. This is another video in which I am displacing this vertebrovascular complex, and in this way we can follow these beautiful arteries. For example, in here we have only an anterior inferior cerebellar artery, and the posterior inferior cerebellar artery is hypoplastic. Look at this. So this is only a short pica, and the real pica is coming from anterior inferior cerebellar artery. So we can also make some dissection of the white fibers or the tracts of the cerebellum in order to learn the anatomy of these regions. In this video, I want to show you this dissection of vertebral arteries, and the anterior spinal artery. Look at this. This is also very beautiful because with this technique, we can differentiate the arachnoid, some arachnoid, from the very small arteries that are coming, and these arteries are creating in here a network of very rich network of vessels coming from these anterior spinal arteries. The anterior spinal artery in the right side and the left side. This is an injection of another brain. So in this case, I could inject also very, very small arteries. But as I told you, it's much better to inject in the carotid artery in the neck with the brain inside the skull. But if we inject these specimens outside, we could have this leakage. But no problem. Sometimes, if we follow the injection, we can go to a very, very, very small arteries, as you can see in this video. I am continuing the injection, and we can go to a very, very small arteries. For example, in here, these arteries probably are less than 100 micras. And then we are going to have a very beautiful specimens to study arteries of the brain. For example, in here, we have both anterior cerebral arteries, and I can say that in this case, there is only a communication between these two anterior cerebral arteries, but there is no a true anterior communicating artery because they are together. They are very close in here. Then we have the supraclinoid carotid artery in this case, and with a hypoplastic posterior communicating artery, and in this case, the fetal variant of the posterior communicating artery. In this video, I have the anterior communicating artery, A1 in the right side, some branches coming from anterior communicating artery. And this artery is very important because A1 is the favorite site on the side circle of Willis for hypoplasia. A1 hypoplasia has a high rate of association with aneurysm. It is found with 85% of anterior communicating artery aneurysms. It is the only anatomic variant that correlates with the location of cerebral aneurysm. These are the small branches coming from anterior communicating artery. This is another picture. This is another beautiful video to show the branches of the tip of the vascular artery. Look at that. In this case, we didn't find a posterior communicating artery in the right side. In the left, here we have posterior communicating artery. This is very rare, the absence of posterior communicating artery. And these are some perforators arteries going to the mesencephalon, going to the midbrain. Mammillary bodies, and the third cranial nerves in both sides. And this is the posterior perforated substance. So another possibility is to study the superior sagittal sinus in order to know the lacunae formed to both sides of the superior sagittal sinus. So here I am doing this dissection in order to follow these veins that are coming from the lateral surface of the brain through the superior sagittal sinus. Doing this dissection, we can know how is formed this lacuna. And you know that some tumors like meningiomas coming from the superior sagittal sinus sometimes are difficult to dissect in this when they are situated close to the superior sagittal sinus. So this kind of dissection shows us the complex anatomic formation of these veins. Look at this. This is very, very complex. This is a picture showing the complexity of these veins. Another method to understand the brain is the staining of the brain for a macroscopic study. Was Mulligan in 1926 described a method of staining sections of brain hardened in formalin and intended for naked eye examination. So when we do this technique, it's very easy to understand some tracts and some nuclei, because the gray substance is stained with color blue and the white substance is not stained with this method. So for example, here, if I try to looking for the anterior nucleus of thalamus, maybe I can say that is in this region, head of caudate nucleus, the cuneus, and other structures. But what happens if we make this staining? It's easier to locate these structures. For example, in here, we have the anterior nucleus of thalamus, the head of the caudate nucleus, and other anatomic regions like globus nucleus in the cerebellum, and the medial lemniscus with the number 7. And let's go to see another, this is an axial cut to see this kind of preparations. Here we have the genu of corpus callosum, posterior limb internal capsule, the anterior putamen, the head of caudate nucleus. And what happens if we make this this staining. It's easier to understand these tracts. For example, here we have the head of caudate nucleus and the striatum. And another structures, here we have the splenium of corpus callosum, and with the number 2, the claustrum, this very thin column. And another picture to understand this, look, we have a very beautiful cuts, a very beautiful image to understand. For example, here we have the dentate nucleus, some tracts in the pons, and another regions of the brain. This is a parasagittal cut, and look at this. Here we have the genu of internal capsule, anterior limb of internal capsule, 3 head of caudate nucleus, the stratum zonal of thalamus, pulvinar nuclei, calcarine sulcus, dentate nucleus. So let's go to see this in this image. So this is a basic anatomy to understand the brain. So another technique is the white matter dissection with the Klinger technique. And this is also very useful to know because as we know, the white matter of the brain is composed of myelinated nerve axons. And here I put these arcuate fibers, and then it's very easy to follow these axons. These axons, when sharing a common origin and destination from compact structures such as white matter fascicles or tracts, the orientation of axons within the brain can be traced non-invasively through diffusion MRI. But if we have the specimen, we could have and do this kind of exercise to find these axons. This technique provides the possibility to study the anatomy of white matter and connections between different cortical regions. Specific fascicles can be isolated from the whole brain based on the anatomical knowledge that comes from classical anatomical white matter dissections. Here we have a short fasciculus. All of this is white substance. This is really useful to understand anatomy of the brain, as you can see in the next images. For example, in here, these are the short fibers, the U-formed short fibers. Here we have the lateral geniculate nucleus. This one. This is the optic nerve. And these are geniculocalcarine fibers. These are geniculocalcarine fibers from lateral geniculate ganglion to the occipital lobe. And then, for example, in this brain, I could it in several ways in order to find, for example, here we have the caudate, the head and here the thalamus, and here we have the basal nuclei, the pallidum, and also we have here some, when I injected this brain, maybe I put some strength injection and provocate these small ruptures of these lenticulo-striate arteries. So, as you know, in here we have another picture. This is another one to understand not only white matter fibers, but also the arteries. This is another picture, and here I want to show you this video. In this video, I want to show you the middle cerebral artery, the sphenoidal segment with its lenticulo-striate arteries. There is some noise, I think. This is not coming from my video.
Okay, Victor, I'll get on it.
Anterior choroidal artery, external segment. And let's go to this other video to show the recurrent artery of Hübner, and these are lenticulo-striate arteries. The lenticulo-striate arteries coming from first segment of middle cerebral artery. The lateral group. Let me advance the video to show you the recurrent artery of Hübner. We can see also the recurrent artery of Hübner in the right side. And then in the left side. Okay, I think I'm on time, Dr. Sameh. Do I have a time? It's okay.
We can have, yes, 15 minutes.
1 minute more, how many minutes?
10 minutes.
10 minutes, okay. Okay, let me show you then this video to show the arteries coming from the tip of the basilar artery. And then, okay, and then I'm going to show you this beautiful dissection. I dissect the corticospinal tract in order to see this very interesting feature that was described many years ago, but in few times we have the possibility to follow the corticospinal tract. This is the corticospinal tract. Most of its fibers cross to the opposite side, as you can see in here. Most of them cross in the pyramid of the medulla, and some of them continue in the same side. In the literature, we know that these are almost 10% of fibers. and the fibers that cross to the opposite side are 90%. So this, I enjoy too much this video because if you follow these tracks, you could find this is very beautiful for me to see the decussation of corticospinal tract. And it's obvious that if you know anatomy, you are going to have a good results when you treat these giant meningiomas. I operated this patient, and for me it was very, very good to have an hypoplastic lateral sinus. So I decided to enter in this side, and then I could have a complete resection of this giant petroclival tumor. So in order to make that kind of difficult approach and removing of that tumors is very important to work to get some skills to remove those kind of tumors. In here we have an hypoplastic vertebral artery in the right side. In the left side is greater than the other, and here we have the anterior spinal artery and the lower cranial nerves in here. And in the lateral side, here we have the superior cerebellar artery, posterior cerebral artery, and geniculate artery. Here the posterior geniculate artery. It was in Poland when Albert Adamkiewicz studied the arteries of the spinal cord, but he did not study veins because he said that veins in the spinal cord are difficult to classify because they don't have an usual formation, anatomic formation like the arteries. So if we want to make this this kind of injection, we need to remove the complete spinal cord from craniocervical junction until L5, and then to make laminectomies in all the canal rachidium in order to remove this spinal cord. So then after we wash this spinal cord with water, and then I cannulate every vein and artery, and then inject silicone, color blue for veins and in red color for arteries. And then we can dissect these beautiful anatomical regions. This is very easy to do, no secret, very, very easy. The most difficult is to get a fresh specimen. I think is the most difficult. In most of the countries, this is very difficult, but in my country, I have a special permission to work in unidentified cadavers. So what do I do? Spinal cords were extracted via a longitudinal midline posterior incision from the occiput to the sacrum. Anatomic dissection was performed in unidentified cadavers at the Institute of Forensic Sciences in Mexico City. Laminectomies were performed from C1 to L5, and the spinal nerves were cut with care so as not to lesion the dura or also the small vessels. And then I injected this silicone. You can inject silicone or latex. Latex is going is a little more difficult because you have to wait almost 24 hours to make dissection. And if you inject silicone, you could start to study the spinal cord 1 hour after, because it's easier to do that. And then we could have these beautiful pictures. For example, in here we have the Adamkiewicz artery and the trifurcation. This bifurcates into posterior spinal arteries. This is the left and the right side. And the other one is a small artery that is running along to the filum terminalis. And then we have very interesting results. For example, in here we have C1, C2, 3, 4, 5, 6, 7, 8, and then we have the origin very high in these 50 spinal cords, the origin of this Adamkiewicz artery in T3, the thoracic nerve 3, 2, and 1. And this is cervical segment. And this is the other picture to show the thoracic aspect. And in here we have the lowest level from coming from left L2, lumbar 2 nerve. This is left lumbar 2 nerve. And here you can see this Adamkiewicz artery, the lateral aspect, anterior aspect, posterior aspect. And in here, you could see the great posterior radiculomedullary artery. And then we could have these beautiful pictures to understand vascular anatomy of the spinal cord. Let me show you this great posterior radiculomedullary artery. This artery was not understood 50 years ago. Some authors denied the existence of this artery, but now we know that it really exists. Here we have a great posterior radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve and goes to the posterolateral aspect of this spinal cord. Then returns to the posterior aspect between L3 and L4 nerves. Great posterior radiculomedullary artery.
Two minutes, Victor.
Yes, thank you. Here we have the posterior spinal artery that is coming from the Adamkiewicz artery. This is the posterolateral aspect of this spinal cord. Here we have the posterior spinal artery. This artery is going to make a beautiful anastomosis with the great posterior radiculomedullary artery. Okay, thank you so much. Thanks, Dr. Sameh, Dr. John Bennett. It's very important to work in these specimens to get skills for doing complex surgery into the brain, skull base, and also the spinal cord. Thank you so much.
Thanks a lot, dear brother, for your excellent presentation. Is there any questions from panelists?
I have a question.
Okay, go ahead.
Yeah, Professor Perez, very beautiful demonstration of the technique and the anatomy, obviously. I just wanted to know how we have been able to clear the blood from the cadaver, because all your specimens, there's not even a single drop of blood anywhere within even the capillaries. What is the secret of that?
Okay, could you repeat please?
How do you remove blood from even the capillary level blood vessels?
Okay, how to inject the capillary vessels
without blood?
Without blood. Okay. First of all, you need to resect the whole brain and the whole spinal cord with care.
Okay.
With care, not to lesion small capillary vessels. And then after, to inject them also with a soft pressure, not hard pressure. If you do that with force, you are going to rupture these very delicate capillaries. But the other thing is, if you inject the brain inside the skull through the carotid artery, first of all, you need to wash and open both sides, because you are going to inject in one, and then you are going to see the water coming in the opposite side. So in that case, you are very sure that the vessels inside the brain are good. They are not broken. But if you inject in one side and do not have water in the same form in the other side, I'm not very sure that I am going to make a good injection. So this skill you can get these skills through the years working with specimens.
Okay, yeah, that explains, Professor, because we have been trying to do that, but unfortunately, we are not a full-fledged institute in which we get the whole cadaver. So
Yeah.
we have been having difficulty in clearing the blood from the brain. So our quality of we do white fiber, but very difficult to get the silicone injection high quality specimens.
Yeah. Okay. You can change the silicone for latex. Latex is easier. Latex is easier because it's liquid. The only thing is that you have to wait maybe 24 or a little more hours to strengthen the latex.
Okay. Okay. Thank you, Professor. Thank you.
No, thank you.
Thank you, Victor. And now we will shift to next speaker, Professor Ahmed Kanaan. Please, dear brother, start sharing your
Thank you, Dr. Sam Mercy, for this kind invitation, and John, wonderful transmission of this slate of colleagues and friends. Victor, you have a marvelous slides you showed as usual. And may I share my screen?
Yes.
Yes, sir.
All right, so my talk is a trend in skull-based surgery. I call it transformation in skull-based surgery, the merits of simple approach that trumps the complex signature approach. And of course, before we start talking about this one, we should nothing coming from nothing. Evolution skull base in the late 70s, 80s, and early 90s. The name are listed, they have their contribution. We learn a lot, and we adopted many of these approaches. And there was an evolution in the neuroendoscopy as well over the years. To Kassam, and after Kassam, there were several contemporary, they are doing the endoscopy. 2006, I like this slide. I conducted a skull-based meeting, the Asian Oceanian in Dubai in 2006, and I invited 42 skull-based surgeons. You can see all the famous name, Roten, Sami, and I'm seeing my colleague Banish and Nanda, Kawazi, Fed Gentili, just name them. All of them were there in that meeting, and everyone produced the evolution in the skull-based approaches coming from the mid-80s, including the Hakuba approach, who was invited, but he was not there. And we see these approaches focus on the three measures that are the fronto-orbital-zygomatic, FOZ, the pre-sigmoid combined approach, and Kawazi approach, the lens, and the far lateral approach. We adopted this approach, and most people adopted this approach. They have worked closely with ENT colleague at the time with the surgeon of microscopy, and most of them, their ENT colleague, they want to do in-block resection. So they need the maximum exposure on the least retraction. When I reviewed this presentation of the colleague from that time, and over the past 20 years, I divided the neurosurgical approaches or strategies into three. The authoritative approaches that we all learn about it when we are mentored by somebody who would like to have his approach, and we follow his approach. And then we start being on our own, putting our wings, and we try to fly, and we adopted some additional technique from seeing others masters at work. And then eventually some of us became more innovative. That time, I mean, Kassam, with his counterpart, endoscopic surgeon, Caro, they introduced the innovative approaches. So we start from that review. I realized that the major two powerhouse approaches, they are still the Trigeminal approach and the retro-mastoid retro-sigmoid approach. We went into the progression for complexity as it showed here, but now we are turning back and we are going back to the simple approach, as I mentioned, for good reasons. Now, we are doing more a tailored approach, the drill as needed, relieving the CSF and do cisternostomy, it gives you a space, respect the arachnoid during dissection under the microscope, use the tumor cavity empty space after decompression to provide you additional space to maneuver your equipment without the need for taking more bone. And the hybrid use of endoscopy has given us a visual extended arm to see beyond the corner you are working at under the microscope or in naked eye. And complement your treatment with other modalities. There are friends, whether it's an interventional radiologist or oncologist, we have to remember there some of the diseases need the triple treatment from all of us. And at the end, this is the message from the two pioneers, whether it's Professor Majid Sami and Professor Yazarjil, both of them said the most important message that whether you are a microsurgeon or endoscopic surgeon, you have to perfect microsurgical technique and dealing with the tissue. And the other one, functional exposure you are doing should provide good functional outcome. it doesn't help if you do a nice approach and the patient comes out with a major complication. We have few examples of this approach, the trend in less invasive procedure. The best example is the transfemoral surgery that went through 100 years of evolution. And thanks to Griffith, who coined the name of microadenoma for a Cushing disease, that we can cure it if we find the adenoma, and thanks to MRI imaging and sometimes PET scan in these cases. So you can take an elephant from transnasal approach, and now we're seeing big tumor are taking through transnasal surgery. And this has increased the indication for whether it's an extended endoscopic approach or extended assisted transnasal surgery. That's what I like, endoscopic assisted, to use in most of my cases. So a large supracellular with a small intracellular adenoma used to be an indication for craniotomy. Now all these listed, they are indication for endoscopy. And I divide the stage of the need for endoscopy based on that grading. From 1 is nasal, sinus, and 3 is the cellular, and 4 supraparacellular. And that's what I use it for, to do the extended approach. Usually I use the speculum. I am not shy from using that speculum. I never have problem with it. In no time, I am at the face of the sinus. And when I enter the reach the face of the sinus and displace the septum, I put the endoscope from the contralateral side, nostril, and I take the speculum and I do the rest as usual with the drilling and showing this with the endoscopy, the medial wall of the cavernous sinus or the infradiaphragmatic area. So you are still using the endoscope whenever it's needed. Navigation, of course, has a major impact on our management in general. And these are examples. This is an apoplexy that went through a simple unilateral, uninostril approach. And I put the endoscope just to see if I have left any residual. It was a complete resection as it shows in the lower series of the imaging. In giant adenoma, the issue is a little bit different. And I use what I call it the clock technique. I start initiating in an empty space, as I mentioned, by decompressing at 6 o'clock. Then I go from 5 and 7, and I cross both sides up to 12 o'clock, keep the last part up at the roof. This is where the stakes are. This is where the optic nerve and the A1 and this and CSF. This is, I leave it to the end, and I empty the space at the bottom so tumor can come down, whether it's with a Valsalva or then you put the endoscope and take any residual. This is an example of an extremely giant tumor in a young girl with visual problem, and it was a non-functioning adenoma. And this is the post-resection, and we did it by nostril with endoscopic assisted. This is another one with a partially infarction giant adenoma. Remember, this infarction at the top give you a guidance. When you reach from below up to this hemorrhagic tumor, you know you are reaching the top or the dome of this tumor, and this is post-resection, used again endoscopic assisted resection. Endoscopy in microadenoma is of value. I used to say there is no value, but I realize its value when you are searching for a microadenoma, and there are cases of Cushing disease where you have an infracellular tumor that can be highlighted by the endoscope, looking to the medial wall of the cavernous sinus or subdiaphragmatic or behind the pituitary stalk. And this is a case was successfully done by endoscopic surgery. So the indication has increased, and for meningioma, there are a group described by Amir and Al-Mufti, the subdiaphragmatic meningioma. This is why I feel this is an indication for transfemoral surgery. The rest, I am not very convinced yet to do a big craniotomy from below, as I feel I am better off from above from the point of view of repair, removing tumor with margin of dural margin to achieve a better Simpson grading. And this is perhaps a newer generation acquainted with the regular use of endoscopy might like to do tuberculum celli from below, or olfactory groove meningioma. This is a case of a craniopharyngioma. It's a funny shape lesion. We were not sure about the nature of the lesion. I went by nostril, endoscopic assisted, and it was craniopharyngioma that was removed completely from below without any problem. Calcified, heavily calcified craniopharyngioma and multi-compartment craniopharyngioma, I still prefer, or post-radiation treatment craniopharyngioma recurrence, I prefer to go from above. I am safer for many reasons, and I avoid any major vascular injuries. There are a few additional indications. I'll go over them later on and discuss the subject of petroglyval and foramina magnum meningioma. These are cases, they are midline. It was not my intention to take a meningioma from that approach that time, but we went in, it turns to be a meningioma, it offered itself. It was very soft that I could take it with a good decompression and removal, as it shows on the lower series here. The tumor completely removed without any incidence, and patient stayed only 3 days in the hospital. This is a case of chordoma. See where the basal artery is, but the beauty of that case was a purely midline, and you see what's happened to the brainstem, severely compressed. So we went transfemoral and removed this tumor, which was very soft, and this is the post-resection. Whether you go in any approach in chordoma, you still need to give a proton beam, as even a complete resection, your recurrence is pending without the proton beam radiation. Going to anterior fossa, the fronto-orbital-zygomatic become less appealing in general, and it has been modified. The first time was used actually by John Jane was to remove an orbital tumor. He took the orbital rim. Then Hakuba and his ENT counterpart, Hakuba, apropos, he was trained as an ENT surgeon. Then they two did the fronto-orbital molar approach, a very complex approach to remove a large craniopharyngioma or a tackle vascular lesion. But I feel now flattening the orbit, drill the orbital rim from behind without causing cosmosis difference. The resection of the pterion, this is the most important that was described by Professor Yazarjid. It gives you near access to your lesion, and you can handle any lesion in that area nicely, and even the counterpart, you can decompress both optic nerve from this approach. So if you apply, of course, for meningioma, the 5D principle, arachnoid respect, it's your friend. You should not damage it, because most of the neurovascular structure are protected with it. And in some of these cases, I feel it's essential, especially tuberculum cell meningioma, I remove the optic nerve bilaterally or unilaterally on the site of more lesion, because it gives you the chance to manipulate the optic nerve without being tethered at the falciform ligament and causing ischemia. So this is a perfect approach, and you can retrieve any tumor tongue going in the optic foramen. These are example pre and post, as it's not touch. You see, as a wonderful approach, because it's very minimally invasive in this sense. This is a case of tumor removed, and I now use the endoscope as a tool to assist, and it shows that I removed the tumor. This is pterional approach. I'm seeing that this tumor capsule is removed. You see the carotid on the other side, optic nerve, and this is under the endoscopy. I felt I have a complete resection, but when I turned the scope a little bit more, I saw the stalk, and behind it there was a residual tumor that I could retrieve and see it and take it out. It was not shown for me very well under the microscope. So tumor endoscopic assisted tumor resection from above is still of a great tool and value to use it. And this is pre and post resection. This is a case of craniopharyngioma treated with poucher resection from below and radiation therapy in France. Patient came after 3 years with a recurrence, cystic, and he has a heavily calcified tumor to start with. So I elected to go from above, and you see that tumor, this is the optico-carotid triangle, and you see here that tumor, how severely attached the calcification to the branches of the basal artery, that I could dissect it safely and remove it. Imagine you are putting this one from below, and the catastrophe will be waiting for you. And this is putting the scope inside. You see residual calcification next to the stalk that you can retrieve it without damaging the stalk itself. And this is a pre and post-op showed you the complete resection, even the complex calcification of this tumor. Going to the other important approach is the retromastoid approach. And we have adopted in the recent year. I'm not doing the sitting position because in my place, anesthesia, they don't like the sitting position. But that position I'm showing you here, and I show it in several meetings, it's almost a semi-sitting position, but in lateral. So because a fracture table, the new table, you can fracture it in the middle, you can elevate the head, you can put the head down so you avoid pneumocephaly, and you can do the benefit of gravity for the cerebellum not to be retracted. And this is the resection, and I have complemented this one and adapted this approach from Professor Sami, who was published several years ago, called the suprameatal approach. Is a partially infra-supra, unilateral, lateral, and with the retro sigmoid approach. This is a fantastic approach when it comes to meningioma especially, and some schwannoma that goes along the tentorium high up. This is an example. I was planning to do a pre-sigmoid approach, but when I saw the prominent sigmoid and lateral on that side, I elected to go from behind and see how the situation. When I went in, tumor was partially resected, and then I put the endoscope and I could do 30 degree, and I could retrieve this tumor completely out without exposing the patient for a second approach, so with some anterolateral approach. And this is the pre and post. Look always to the coronal, because if you notice, although it's going almost 2.5 centimeters high up the temporal fossa, but it's still within the boundary of the tentorium, and that's why, like my colleague Professor Benish, he liked the infra-supra. This will give you a good access, and you do dissection in pieces. I'm not going to put the video for the sake of time. Epidermoid is another indication for a simple approach. This tumor, I call them the creeping tumors. They go along all systems, respect no vessels and nerves. They go around them. And when you put the endoscope, you can use the chopsticks technique, taking piece by piece, and the empty space you are initiating will give you an ample of place to use your endoscope to retrieve any residual, like here. And next to the jugular foramina, there was some deposit I removed, and you see now the vertebral artery free, the facial nerve free, and the sixth nerve and the depth is free. Pineal region. Now, with the invention of the endoscopy used in pineal region and the unilateral approach, I think this approach became very less invasive, and it has some limitation, but unilateral give you away from the midline where the vein of Galen and the steepest portion of the tent is there. If you go more lateral, it's more flattened, and you can go there and do some hanging stitches on the tentorium, and then you go there, and this is wonderful. I'd like to show the video, the advantage of now we put the endoscope from almost an extended unilateral approach, reaching almost to the midline, and I am there, and you see the massa intermedia, thalamus. This is a tumor here. Try to move it fast. Aqueduct, enlarged foramina, plexus, massa intermedia. And I start now using the curette to take it like a pituitary adenoma from behind. So I'm lifting the tumor with the curette. Sorry, jump to the other case. Okay. Now, going to the petroclival region and foraminal magnum tumors, all these nice approaches entailed a lot of bone removal. When I did the pre-sigmoid combined approach following Hakupa's technique, but we modified it a little bit. We don't skeletonize the semicircular canal because even in the 6 cases he published, there were 4 who lost their hearing by just taking the bony decortication of the semicircular canal. And we don't do the transposition of fallopian canal of the facial nerve. This will give you for sure a facial palsy in 60 to 70%. We'll do only Troutman triangle be exposed and cut the petrosal vein, the superior petrosal vein, and the tentorium. It gives you a wide space to the petrous apex from below and from above, and you are working more on an anterior approach. But this approach still at 12 hours, 10 hours exposure, this is where your energy will be depleted toward the end of the day. Some people has done it in 2 stages. Some people has done the flap in 2 pieces. And now the trend, I go from below, use the endoscope, the 30-degree to go high up, inside the tentorium from below, and then it give me the reach without having the complex approach. It doesn't mean this approach should not be learned and taught. It should be used whenever it's important, and taking in consideration the anatomy of the sigmoid and the vein of Labbe to avoid any venous problem. The far lateral approach, I abandoned the transposition of the vertebral artery. You spend time doing a hemostasis because of the venous plexus. It gives you not that extremely wider exposure. And you can take most of the tumor by working within the tumor, inside the tumor to decompress it, and then you go around it. So cutting the ligamenta denticulata, it gives you relaxation for the spinal cord. And the most important, as I mentioned by Professor Victor, the anterior spinal artery should be paid attention. These approaches focus to take more an anterior approach, but still hypoglossal nerve is an issue in these cases. And drilling the condyle, you drill as needed, and I call it the tailor drilling if it's needed. In most of the cases, you don't need to do that. This is an example I mentioned to you that chordoma, like this one, was taken completely by a simple approach, transfemoral extended endoscopic approach, and this meningioma was removed through the transclival approach through the nose, binostride. I was encouraged because of the basal artery was completely displaced to the contralateral side. I have no vessels in the middle, and that tumor was very soft to retrieve it completely, and this is post-op with the complete resection of this tumor. Patient was operated about 6 years ago and still no signs of recurrence. Yet we did not resect a margin of dura around it as it's supposed to be for Simpson grading. So the selection of an approach should be short and direct. This is what we all agree about. Should offer multi-avenues, provide excellent depth and panoramic views, compensated now with the endoscopy, minimal manipulation of neural structure. Taking a more bone, a wider exposure does not privilege you to have more exposure in the depth per se, especially when you are using a microscope and endoscope. And it negate the need for complex reconstruction, and we should consider always the cosmetic result on these cases and cost effectiveness. These are the factors influence the approach selection. There is an inherent bias in neurosurgical training, depends who is training you and which center, and the span of your experience. When you are young, everything is operable. When you are at the plateau, you will be very selective, and when you are at the end of your career, you will be very conservative. Surgeon preference plays a major role, because if you don't have the experience in some of these approaches, let somebody else do it perfectly better than if you are not acquainted with. Rigidity does not help. Don't stick to your opinion if you feel there is a better opinion on yours. Be flexible with the approach selection. Don't say, I always do it. There is never, ever, always. Cost and logistic plays a major and dictate sometimes the situation. Like endoscopy is cheaper to buy now in less privileged country than a microscope. That's why it's fungating. Every center has an endoscopic setup. The practice strength like Chanel and Gucci, people, they want to wear that costume and they want to do, I am endoscopic surgeon. I'm fully endoscopic surgeon. That's what they always say. These are tools. You should not be governed by tools, but you should use them whenever is needed. And of course, there are some of them industrial driven practice is financial issues. The message to take home, simplicity trumps complexity. It is the zenith of long, arduous journey, not to the starting point about simplicity. And the other one, flexibility trumps rigidity. Thank you very much for your attendance.
Thanks a lot, dear brother, for your excellent presentation that we have all learned from it a lot. Is there any questions from panelists? Okay, if there is no question, I have to notify that we have prepared another Zoom link as faculty launch. If there is more discussion or questions, you can follow the link in chat box to get there and
Excuse me,
discuss.
Sam, I'd like to say a word, if you don't mind.
Okay.
Ahmad, we'd like to invite you. We're kind of tinkering with the Zoom. We're starting a Zoom lounge where the speaker goes into the lounge after he finishes to interact with students and other neurosurgeons. I sent you the link. You leave this Zoom and go into the other Zoom. Okay? Okay?
All right.
Yeah, there's people that are waiting to see you.
All right.
Professor.
Thank you.
Amazing presentation. Congratulations.
Thank you.
Very impressive presentation.
Thank
Excellent.
you. Thank you very much.
Okay, see you in the lounge, Ahmad.
Okay, now we will shift to next speaker, Professor Linda B. Please start sharing your screen.
Hi, thank you so much. I think the previous talk may need to stop share and I can, great, wonderful. Thanks so much for inviting me. It's a pleasure to join you in this wonderful Congress for the meeting today. I am just gonna start. Wonderful. I have the pleasure of talking about meningiomas from a neuropathological molecular perspective. I think that this audience knows no introduction to meningiomas as a whole, in which they come in all varieties, flavors, sizes, locations, and most importantly, behaviors. That spectrum of behaviors over the ages since the initial description by Harvey Cushing till the most recent iteration has in general been described by a constellation of histopathologic features. The most recent published version of the World Health Organization grading scheme classifies meningiomas into 3 grades, with 9 histologic subclasses of grade 1, 3 for grade 2, and 3 for grade 3. And in essence, these are divided between the number of mitoses expressed by the tumor, a number of histopathologic features, as well as their characteristic appearance under the microscope. However, these do not capture a tumor like this, which is a patient that we took care of for many years, and even at her 6th and final surgery before her demise, she was still deemed a grade 1 meningioma. I think anyone who was to meet this patient or to see these pictures would consider this a malignant meningioma. Conversely, there are many tumors that we encounter like this that are described as a grade 2 meningioma, but yet after surgery with no adjuvant radiation has durable control for a number of years. So how do we distinguish the sheep in the wolf's skin versus the wolf in the sheep's skin, in the words of Dr. Al-Mefti? Or most importantly, how do we accurately identify meningiomas by behavior? This has been addressed by a number of groups over the years, including with a few molecular features that have been viewed as being quite important, the most important of which includes CDKN2A and CDKN2B loss, as well as the TERT promoter mutation, which is observed to associate with poor behavior in many cancers. On the basis of these studies, the newest version of the World Health Organization grading scheme for meningiomas in 2021 and beyond now officially includes, for the first time in almost 100 years, the inclusion of molecular features in defining meningiomas in their grading. Specifically, that a clear cell meningioma, which is a type of grade 2 meningioma, is defined by SMARC-E1 loss, which can be discerned on just immunohistochemistry. Likewise, grade 3 meningioma is automatically conferred on a tumor if it has CDKN2A2B deletion and TERT promoter mutation. This impacts us in the clinical workflow because we are now, the onus is on us to devise ways to incorporate such molecular testing into the routine classification of meningiomas. However, those events, CDKN2A2B loss, as well as TERT promoter mutation, are extremely rare across meningiomas. So while powerful, they don't affect the large population of tumors that we see on a daily basis. Several groups have attempted to address this by looking at genome-wide signatures. One example is the beautiful work done by the Heidelberg group, in which they looked at methylation signatures. So in this top right corner, you can see a Breyer prediction curve, in which the lower the curve, the more accurate the prediction of reality, specifically recurrence. And so here the comparison is between the WHO classification system, which is in red, versus methylation classification systems in blue and green. And in essence, application of genome-wide classification to meningiomas improves the prediction of outcome. While that is wonderful and better allows us to address patients in terms of prediction of how they will do, the challenge with many of these proposed classifiers is that they're fairly high-tech platforms that are not universally accessible, and they rely on black box algorithms that require proprietary knowledge to do. So how do we overcome this? Because ultimately the most useful and the most important classification system has to be aligned in being accessible by the world at large, wherever the clinician and the patient is. So we looked at this with our prospective experience at the Brigham and Women's and Dana-Farber over the last 10 years to think about how we can take high technology to transform it to a more accessible basis and to ultimately create something that was simple, accurate, scalable, transparent, and most importantly, accessible so that it can be useful. We did this because of the wonderful resources endowed by our pathology and neuro-oncology divisions to allow every meningioma resected at the Brigham and Women's Hospital over the past decade to be molecularly profiled for their copy number. And so that prospective experience of now over 1,200 cases allows us to look at something like this. So this is a complex figure of a heat map in which every single vertical tick mark is an individual patient, and each row is a chromosome 1p down to 22 with CDKN2A and 2b at the very bottom. The presence of a color indicates the alteration, the loss or the gain of a chromosome arm in blue and red respectively. Neutral background is a normal genome. So what you can notice in the WHO grade 1 meningiomas, which are to the left compared to the WHO grade 2 versus grade 3 meningiomas, respectively on the right, that a majority of the grade 1 meningiomas have a neutral background. You can ignore the stripe of reds right now. Those are a specific subtype of meningiomas, the angiomatous meningiomas that have a distinct signature. But you can see that there's about almost 20% of so-called grade 1 meningiomas that have a number of blues and reds, or in other words, they are just as messed up as the grade 2 and grade 3 meningiomas to the right. Conversely, there's a population of the grade 2 atypical meningiomas that have a neutral or a normal genome in this pale yellow stripe right here. So we formally looked at this because it has been long recognized that chromosomal abnormalities are a signature of higher grade meningiomas, as opposed to unique mutations that are more frequently observed in grade 1 or benign meningiomas. And so we looked at every possible clinical, molecular, and histopathologic feature available to us and put it into univariate analysis to come up with a shorter list that was associated with recurrence after controlling for surgical resection. And these are all primary tumors that did not have prior adjuvant prior radiation, or they are not radiation-induced meningiomas. Upon doing that, we came up with a shorter list of what we considered high-risk molecular alterations. We preserved the wisdom of the ages from the WHO by keeping mitotic count, as being a feature in this integrated grade, and we took away histology, which is the most variable from observer to observer across pathologies, across centers, and across selection of tissue within the tumor, and came up with a new molecularly integrated grade, which is 1, 2, and 3, based on these simple features. First, how does this perform compared to the traditional WHO grade? Well, both in comparison to both the existing 2016 WHO grade as well as the upcoming 2021 or 2022 WHO grade, we see a significant crisscross of tumors. From the left is the traditional histopathologic grading system. The right is our molecularly integrated grading system. And you can see in particular that overall about a third of tumors will change to a higher or a lower grading scheme. But in particular, the atypical meningiomas, which are the most variable in their outcome, about a third of them are graded as a lower integrated grade, and a third of them become a higher integrated grade, distilling these atypical grab bag of meningiomas into a more concrete categories. When we looked at tumors head-to-head comparison, it was even more striking. The so-called malignant meningiomas that are WHO grade 2 and 3, the molecularly benign, integrated grade 1, shown in the blue line here, almost did not recur over a long period of observation, compared to the so-called benign meningiomas, WHO grade 1, that were molecularly aggressive, integrated grade 2 and 3 in the red. So on this Kaplan-Meier curve for recurrence, you can see the dramatic distinction between and the impact of integrated grade compared to the histopathologic grade in these discrepant cases. Moreover, when we looked at brain invasion, which has been in and out of the WHO grading scheme over the past century, what we noticed is that those, again, integrated grade, molecularly benign, molecularly favorable tumors with brain invasion, which automatically would classify these tumors as being at least a grade 2 in the current scheme, did a lot better compared to the integrated grade 2 and 3 tumors that were noted to be brain invasive, shown in red. So again, another striking difference for a feature that has been somewhat confusing and controversial across the decades. When we looked at this across statistical models over time, what we noticed is that the longer the observation period, the better molecular prediction got. So shown in blue is the integrated grade, and shown in red is the WHO over two robust statistical models, time-dependent AUC and time-dependent average precision. And the longer the observation period passed, the better the integrated grade performed compared to the WHO grade. This is particularly reassuring in a tumor like meningioma, whose outcome frequently requires years of observation to declare itself, as the recurrence is in the setting of an excellent resection or excellent treatment. The recurrence is frequently slow and not rapid. Moreover, as I mentioned, the motivation for this study is that we can take the knowledge of something with a transparent model but apply it universally. And we took quite some pains to show that this copy number can be derived from a number, it's a common denominator from many, many molecular platforms. You can derive it from methylation, from expression, from genetic mutation sequencing, from basically any available molecular profile can derive copy number. However, even if none of those platforms are available, one can still do FISH for focal features. And what you can see here, when we tested the hypothesis, for example, for something that most pathology labs would have, which is the ability to assess 1p19q, since it's so common in the classification and necessary in the classification of gliomas, specifically oligodendrogliomas, even the addition of single, 2, 3, or 4 features, with every additional feature included, the prediction of meningioma outcome got better and better compared to the WHO. So that even if one does not have access to a genome-wide profile, one could choose common high-risk incidents and, for example, do FISH or other assays for this. So what is the implication of that in treatment? Well, first and foremost, in the receipt or the determination of adjuvant treatment, of adjuvant radiation specifically. So for us, because of this data over the last decade, if a patient, especially a young patient, has a grade 2 atypical meningioma with relatively reassuring molecular feature, we do not recommend or give adjuvant radiation. Conversely, an older patient with a grade 1 meningioma, but with multiple chromosomal alterations that we think are high risk, we would recommend and advocate for adjuvant radiation. This also has implications for clinical trial design as well as recruitment, as unfortunately one of the shared features across most meningioma clinical trials to date is that they have not been universally successful. And perhaps one reason is that we are including high-risk patients as patients who are perceived as being high grade or high risk who are actually benign, and conversely, patients who are higher risk are being excluded. And that could wash out the signal in a patient population that's relatively sparse, like meningiomas. So how else can we use this in daily life? Well, I'll take the example of radiation-induced meningiomas. This has been recognized to be more aggressive, in general across the literature for many years, but controversy still resides on exactly how aggressive these tumors are. And one of those things when we take a look at that is the fact that it's frequently cited that there are a number of so-called benign or grade 1 meningiomas. And so the initial receipt of radiation is sometimes cited as being equivalent to the initial molecular alteration, like a loss of NF2, and not necessarily additively more aggressive. We looked at this using our new molecular grade, and we observed that amongst the WHO grade 1 meningiomas, which are on the left in this pale blue stripe here, over 2/3 of them were molecularly higher grade, shown in this yellow box here. And even among those that are integrated grade 1 and WHO grade 1, a good number, greater than 50% of those, have at least chromosome 1p loss, which is for us the equivalent of an atypical feature of a slightly higher risk, but not quite as high as the accumulation of other features. So this put together would argue that even if one does not routinely profile meningiomas in general, that to consider at least profiling the radiation-induced meningiomas, as those can significantly differ between their molecular features and their actual histopathologic feature. And shown here, this demonstrates that radiation-induced meningiomas compared to our sporadic meningiomas, a far greater number, especially among the grade 1s, will stratify to a higher molecular grade. So what does that mean ultimately for diagnosis and management? So the one thing that I will point out is, despite the power of biology, surgery remains one of the single most important thing that we as neurosurgeons can do to delay recurrence and potentially to offer cure. So here I show the difference between the benign integrated grade 1 meningiomas and a more intermediate integrated grade 2 meningiomas. And you can see that even after controlling for the molecular biology of the tumor, that especially amongst the benign tumors, those that have a better resection still did far better than those with a lesser resection over time. So biology does not replace the adequacy of treatment and especially surgery. Furthermore, when we encounter patients on initial consultation, what is the likelihood that their tumor is aggressive or not? And we looked at a constellation of our clinical series and classified them by their anatomic origin. as we are quite familiar with. And what you can see is that as previously suggested in various papers, the anterior midline skull-based tumors, olfactory groove, planum, tuberculum, clinoid, are by and large benign, shown in red here. That, especially when you look at their molecular profile, even more so than their histopathologic profile. Conversely, the falcine parasagittal and the intraventricular tumors are far more likely to be grade 2 or grade 3, either by molecular features or by WHO features, allowing us to assess the risk of progression and perhaps the need for timing of intervention based on the anatomic location of these tumors. I will point out that the literature has an assortment of studies which say that skull-based meningiomas are more or less benign or aggressive than convexity meningiomas. But many of those tumors, many of those papers cluster falcine parasagittal meningiomas with convexity meningiomas. And I would like to change the thinking, instead of thinking about skull-based or non-skull-based, rather to think of meningiomas, at least biologically, by 3 categories. That of the midline anterior skull base, which are by and large benign, as seen in green here, that of the falcine parasagittal meningiomas, which are far more likely to be aggressive, and everything else. Everything in the petrous sphenoid origin with the rest of the convexity are not statistically different in their likelihood to be either more or less aggressive. But those 2 unique subsets of midline anterior skull base and falcine parasagittal are. So rather than thinking about skull base and non-skull base, to think of it as 3 classes. The falcine midline parasagittal, kind of midline convexity, the midline anterior skull base, and everything else. So with all this, one might think that if we found a tumor in a 35-year-old that was WHO grade 1 but had 3 high-risk features and molecularly grade 2, we would recommend a radiation. But that is actually not what we do and not what we propose. So I'll give this example of a grade 2 meningioma patient who at age 45 underwent excellent resection of a right frontal meningioma, and a few years later had this very small occurrence near the midline. She underwent radiation and had another recurrence 2 years after that. At this point, she's barely into her early 50s, and we would anticipate has 30 more years of life to live. So what do? Do we consider observation, reoperation, or radiation? Well, the consideration in the issue of recurrent meningioma is why recurrence? Is it due to that of inadequate prior treatment, whether it's surgery or otherwise, or is it growth of residual that's microscopic and biologically more aggressive? And so depending on this, we looked at a series of about 1,000 MRIs in 40 patients with multiple recurrent meningiomas. And we, in essence, observed the same pattern throughout, which is one, a tumor is truly aggressive, regardless of the type of intervention, whether it's surgery or radiation, there is a durability to the timing of control. And so what does that mean? That means that if we think a tumor is in a young patient in particular, might be more aggressive, whether it's because of how they've grown, their pattern of growth over serial MRIs, or the molecular profile, or the WHO grade, we might actually tend to favor observation as a powerful tool to stretch out the natural history, because ultimately we're not treating the MRI, we're treating the patient and trying to maximize the durability of disease control for as long as possible to their natural lifespan. So with that, thank you very much for your attention.
Thank you, Lina V, for this excellent presentation. Is there any questions from panelists? Thanks a lot. I think it was very informative that there are no questions from anyone. Thank you, Lina V. Now we shift to
Yeah, I think someone's trying to ask a question, Sam. Go ahead, Zainab.
okay, we will shift to next speaker,
Okay.
Professor Roberto Herrera, please start sharing your screen.
As you order, Sam.
Professor Roberto, are you here?
He was here. I must have stepped away.
Yeah.
I'm texting with him now. No está. ¿Y hay otro presentador? Sam, is there another presenter, Sam?
Give him just a minute, then we will shift to next speaker.
Okay, maybe we'll take a coffee break, Sam. Hold on, Sam. Oh, he lost his connection. Oh, Sam?
I am here. Just give him more seconds.
Yeah, Roberto lost his connection. Oh, okay. He's having internet problems. Okay.
Okay, we can get 5 minutes rest. Then we will start again.
Yes, Sam, he's had connection problems. He's working on it. He said a few minutes. Okay. Okay, Sam, what would you like to do? Did
5
Sam
minutes
go to-
coffee break.
Oh, just wait a couple of minutes?
Yep. We will wait him.
Okay. Well, Victor, it's time for a ranchetta.
Hello.
Yeah, Roberto's having down in Buenos Aires, he's having a hard time for connection. But I texted with him, he said it'll be a few minutes.
Yes, I think so. He lost connection. Sometimes it happened in several times, in several places.
Yeah. It used to happen a lot in Mexico, right? I can remember.
Yeah.
But it seems getting better. The wireless connection is getting better worldwide. I've seen the difference.
Question, please.
Hello, Zanab, how you doing? You're from, he's from Africa, a small country, Gambia, right? Gambia, Zanab, correct? Okay. So there's no one to present here now, Sam, or you want to just wait? Okay. Oh, okay. He wants the link by email. Okay, he's on his way.
Okay, John, we will take just 10 minutes rest. If you want to have a cup of coffee.
I think he's coming in now. He's got the link. Good evening,
Hello,
Vlad.
hello, Vlad. Hello, Vlad. How are you? What time is over there?
I don't know if he can hear you. Well, actually, Sam, we haven't had many breaks, right? It's been a straight shot. Well, I might as well I'll tell everyone about the Zoom lounge. Vlad, are you there? Or Hisham or any other speakers? Byron, Baya Batson from Mongolia. No one wants to talk to me, Victor. I don't know. Vlad, are you there? Okay, we're expecting Roberto Herrera from Argentina to come back momentarily. He had some internet problems in Argentina, but he's working on it. Oh, okay. Okay, Roberto is back. Let me let him in. Roberto, ¿está allá?
Okay, I'm here, John.
Okay, vienen.
Ah,
Bienvenidos.
excuse me for the delay because the weather is bad here in my country.
No problem.
Hello,
Okay,
Robert.
Sam, do
Hello.
you want to introduce Roberto?
Yes.
Go ahead, Sam.
Can you see my screen?
Yes.
Okay. Okay, can you see?
Yes, let me briefly introduce you, Roberto. Roberto has been working a long time on neurosurgery education. He's one of our first adopters of it, and we really appreciate him being there. Welcome, Roberto.
Thank you, Sean. Thank you, Professor Sami Hassan, for inviting me. Thank you, Sean, for your work in this meeting, and thank you for all my friends in this conference, in this meeting. I'm going to talk about complex posterior fossa tumors. Our experience in Buenos Aires in our institution. The first of all is the anatomy. As in every pathology, in every surgery, the anatomy is very, very important. We try to study the anatomy to have a good anatomy knowledge, operate this kind of pathology. Here you can see a cavernous malformation in the posterior fossa, and we studied anatomy, the localization of this lesion. I know before surgery that this cavernoma is located in this area. We did anatomical study before we are going to operate the malformation. This lesion would be located in this area here. We decided to operate this patient in sitting position with this unilateral approach. It is a simple and quick approach described by Professor Johan Niemi. I love this kind of approach for some pathologies, simple pathologies, because this is the patient in position. Ernest Niemi approach. It is necessary to do only one burr hole here, and then in a few minutes you can get this craniotomy. This is the lateral sinus, posterior fossa, occipital lobe here, we opening Duramater here. This is the view of the access, our wake of work. Here we are coagulating veins from the superior surface of the cerebellum, the arachnoid. Here we open the arachnoid in the way to the cavernoma. Here we are removing it. It's typical, the technique is the same. You remove the cavernoma here. This is the movie. Here you can see the forenerve in this position. And this is the way, this is our corridor, unilateral, parasagittal approach. And this is the area. And it is very important, the anatomical knowledge before we are going to operate in deeper areas of the brain, of the posterior fossa, of the brain stem. This is the same. Here the superior cerebral artery. This is after removing the cavernoma, complete resection of this pathology. And this is the closure, the craniotomy, only one bulb hole, easier craniectomy, and very practical for this kind of pathology. This is the postoperative MRI, no remnant of the cavernoma. This is cavernoma. This is the patient a few hours postoperative, very, very good neurological states. This is the same, similar pathology, but we use another approach. We use, this is cavernoma in mesencephalo too, but we use the typical traditional approach. I think this big craniotomy, I think we, in the future, we must to avoid this big craniotomies last in the past decade. This is typical supracerebellar infratentorial approach for pineal region lesion. Here you can see the cavernoma in this location. Here it is. Removing the cavernoma, and this is MRI with complete resection of the pathology and the patient with normal movements of her eyes. Neurosurgical tools, neurosurgical instruments are very important in the new neurosurgery. We have the possibility to use intraoperative MRI in our apartment. In some cases, it is necessary neuronavigation, brain mapping, neurophysiological monitoring, avoid patient surgery in possibility in some cases. The use of exoscope, I'm going to show you exoscopes, intraoperative ultrasonography, all of them could be useful in determining in some surgery in complex pathology, mainly in complex pathology. But the cranial nerve neuromonitoring in posterior fossa pathology is one of the most important things that we need. This is our operating room with intraoperative MRI. We are changing this machine nowadays. This is our old operating room, but I hope early in the next year, in February or March, we can have the new equipment, new intraoperative MRI for which in some cases could be useful too in posterior fossa. This is the operating theater. Here we are checking the step of the surgery with the new control. The position of the patient is very, very important in posterior fossa pathology. And we can choose different position in different kind of tumors. Prone position, supine with head turn, lateral position, concord position, sitting, park bench position. The most important, the key concept is the that the neurosurgeon be in the line of sight. The pathology will be in the line of sight of the neurosurgeon. Supine with the hand turn, this is pathology position, concord position, the park bend position, prone, different. You are going to choose one, depend on the pathology that you are going to operate. I'm going to show you some cases, some other cases. For example, this far lateral approach in huge meningioma. This is a big chapter in posterior fossa pathology, the meningiomas, a big chapter in the neurosurgery, meningiomas of the posterior fossa. And this is the far lateral approach, typical far lateral approach with the exposition of the vertebral artery, dura mater here. Here you can see vertebral artery, loops. This is using this approach, you can remove completely this meningioma. This is the patient with light facial weakness, but very good condition a few days after surgery. But I prefer, nowadays I use far lateral approach, classical, typical, only in few cases, in selected cases, but I prefer this approach, that it is a foramen magnum meningioma, a big tumor in this location, and of course, first of all, the anatomy knowledge, to know the anatomy of is it essential, and we use in these meningiomas another Johannes-Niemi approach, far lateral approach, enough far lateral. I think this approach is enough. You don't need bigger exposition to remove this meningioma, and this is an approach very much easier, very much quicker than the classical and typical far lateral approach. And you can remove this meningioma without you need to do a bigger approach. Here we don't know. Here we are removing the tumor between the cranial nerves and cervical spinal nerves. This is the surgical field after removing completely the tumor. This is the same vertebral artery here, brainstem here. This is the resection, and this is MRI a few days after surgery with complete resection using far lateral, enough far lateral approach from Professor Juha. Here you can see this, another similar case, foramen jugular tumor, meningioma. This patient was operated by this medial way in another apartment. We use enough far lateral approach. This is the meningioma. And here you can see the tumor, and after removing it, complete resection of the lesion. Only with this enough far lateral approach, more simple approach. Another case is a tumor. It is located immediately above the foramen magnum. We use enough far lateral approach, and we could remove completely it. This is the position of the patient, and this is the CT scan after removing completely this tumor. Inside, in same meningioma like this, we use pre-sigmoidal approach, other complex approach, big approach, but everybody know this pre-sigmoidal possibility for treat this, for operating on this kind of meningioma, and this is after removing it completely too. We are using progressively the exoscope, and some simple lesson, for example, this cyst in the pineal region. This is the operating room. Here is the screen of the exoscope. We are operating here. We are watching the screen here. This is Professor Ledesma with me operating. This is the image. Here you can see this is the operating theater, and this is the high definition image of the exoscope. Could be a good tool to remove some kind of pathology. The glomerular tumor could be these tumors could be the most difficult tumors to remove in the cranial, in the skull base. I like so much this surgery because it is a very anatomical surgery. You need to know the anatomy of the neck and the head, the skull base, to remove these tumors. I'm going to show you. You can see here this glomerular tumor here. This is the preoperative angio-CT. This is the patient in surgical position. This is the skin incision. Here is the patient. The shoulder is down in order to the surgeon can get the best side of view of in the line of the tumor. And the first step to remove glomerular tumor is going to the neck and go to the neck and expose and repair the main vessels in the neck. Here you can see the jugular vein, common carotid artery, internal carotid artery, external carotid artery. You have to localize, to repair, and take care of this vessel. And then you are going to go up to the neck, to the head, following this vessel. This is the neck approach. The neuronavigation could be important in this surgery because you can have control of the bone points, some bone points that could be important to have as references in different times during the surgery. It is neuronavigation. I think it is useful in this kind of surgery. This is the skull base. Here you can see this stick occluding the sigmoid sinus. This is sigmoid sinus. This is lateral sinus, posterior fossa, temporoccipital area. This is the petrous bone. This is jugular vein. This is the same. Here you can see the tumor. We open the jugular vein. Here you can see into the jugular vein the tumor, and this is the tumor into the petrous bone. This is the tumor, and this is after removing it, complete removing of the tumor. It is important to drill the petrous bone. This is the patient a few hours after the surgery. This is his CT scan with complete resection of this lesion. And this is the patient again. And this is the patient 6 years after removing the tumor with very good neurological condition, with completely normal life. And he is working normally now. This case, this was this was very important, very nice case in our series, because this was a young man, 39 years old. He was operated on twice and was embolized on 3 opportunity previously to came to our apartment. Finally, he was considered inoperable, and radiation therapy was proposed to simply wait for the end of his life. 39 years old. But here you can see this is the the glomerular tumor, a huge tumor, operated on twice time. And here you can see a big tumor. This is the digital angiography. You can see digital angiography here, with many muscles branches of the artery and veins. And he presented with this clinical symptoms, dysphagia, dysarthria, ataxia, intracranial hypertension, weight loss, extreme weight loss, extreme weakness, stupor, hydrocephalus, in very bad condition when he came to our apartment. We the first surgery was to put him derivation of the cerebrospinal fluid, and this is the surgical position. Here you can see the previous incision because your previous surgery, and this is the surgical incision we programmed. This is the same, and here the same. We localize and repair the vessel in the neck. This is the skull base. I'm going to pass quickly this. The neurosurgeon must be prepared for a very bloody surgery. No, in all of the cases, but it is a surgery in which we can have very blood. Here the tumor is under control. The tumor is under control with coagulation, with Surgiflow. We use Surgicel or Surgiflow too, and we remove piece by piece this tumor. We are removing it piece by piece, slowly removing it, removing the tumor. Here we are finishing. And this is the final aspect of the surgical field, with excellent resection of the tumor. It was important surgery for the patient. And this is postoperative CT scan. This surgery was made almost 10 years ago. This is a postoperative CT scan. And this is the patient a few days postoperative. This was the aspect of the patient a few days postoperative with tracheostomy. He needed tracheostomy. And this is the patient 7 month postoperative. Full recovery, very good neurological status. And this is the concept. Jugular glomus tumors can be removed and patients can live a normal life. That's why we have to treat, have to operate, and have to remove this tumor in one or two surgery, but it is necessary to operate and remove this tumor. This is the patient nowadays, almost 10 years after surgery, with normal life, with his wife, with his motorbike. He is healthy, plenty healthy. Acute neurinoma surgery, acute neuroma surgery is a classical pathology in the posterior fossa. And there are some of these tumors easy to operate, and there are some that are very difficult to be removed. Surgical position that we use is park bench position. We prefer this. We don't operate in sitting position this pathology. This is the classical park bench surgical position, and we use retromastoid, retrosigmoid craniotomy. This is the typical craniotomy. The same here. You can do it bigger or smaller, but this is the approach we choose. How to open dura mater following the lateral and simul sinus. And one of the most important steps in this surgery is removal of cerebrospinal liquid. I think this is the first step and slow step in this surgery to get access to the cerebropontine cistern. Then we have to examine the tumor, examine to localize the anterior posterior pole of the tumor, his surface. Then we have to do the reduction of the volume of the tumor with electrocoagulation, with bipolar coagulation, or with ultrasonic cavitator. The last step is drill the acoustic pore. And the technique is that all of you know. This is different step. Drilling the acoustic pore. This is the final view after removing the tumor. This is the same here in a small neurinoma. Here you can see the neurinoma into the internal auditory canal. We need some microdissectors, curettes, different tools, different instruments to remove the tumor from the internal auditory canal. This is the final view. And some cases in big neurinomas, you can see this neurinoma here on the right, the facial nerve here, facial nerve after removing the tumor. This is the patient, CT, MRI with good resection, and the patient in very, very good condition. In this surgery, it is very important, I repeat, the facial nerve neuromonitoring. They are our specialists, our neurophysiologists in neuromonitoring. This is a young woman, another case, complete resection. And this is a bigger tumor on the left in a young man too, with complete resection and preservation of the facial nerve function. The closure of the craniotomy are very important too, to prevent cerebrospinal leaks. You can do, this is the closure of the craniotomy. This is a simple tumor in posterior fossa, and with very nice picture for finish my presentation. Some lesions from doing posterior fossa surgery and complication. It is important to know the complication, possible complication, CSF leaks, pseudomeningocele, tumor remnant, and we can have some emergencies as tumor hemorrhagia, brain swelling. It's important that we know this complication because they exist. And neurosurgeons who are going to operate a posterior fossa, neurinoma, schwannoma, or another kind of pathology in relation with the facial nerve must be prepared to do macroanastomosis between hypoglossal nerve and facial nerve to repair the function of this so important nerve of the face. Here you can see this patient was operated in another apartment twice or 3 times before us, and we will be able to remove the tumor, and then, but we couldn't preserve the facial nerve. We did this anastomosis. Here you can see complete resection of the tumor and very nice recovery of her aesthetic aspect of the face. Okay, excuse me because the delay, because my internet connection is bad for the weather in my country. Thank you again. Thank you, Sean. Thank you, Professor Sami Hassan, and thank you everybody for your attention.
Thanks, Dr. Diboso, for this excellent presentation. Any questions from panelists? Okay, thank you, sir.
Okay,
Now
Sam,
we
Sam,
shift
do
to-
you mind if I just talk about the Zoom lounge? We're inviting Roberto to come to the Zoom lounge now to answer questions and to meet people. We're trying to improve the networking part of this technology of Zoom and trying to get people to get to know people. There's some students waiting now for Roberto, but anyone from the panel is welcome to join the Zoom lounge. The link is in the chat room, and you're welcome to come in, and you can come back to the webcast.
Okay.
Sam's going to continue now, but Roberto's taking a respite to the Zoom room. Okay, Roberto, I left the
Yes,
link is in.
okay. I have to leave and
Yeah, exactly. You leave this
Come
Zoom
again.
and go into the Zoom lounge room, okay?
Okay, thank
And
you.
Sam will continue the conference. Okay, Roberto, we'll see you there in the lounge.
Yes,
Okay,
yes.
Sam, it's back to you.
Okay, now we will start the lecture of Professor Amir Dadashi. Please say start sharing your screen.
Dr. Anmorsi, how are you?
Fine, thank you, sir.
Do you see my slide?
Yes, it's okay, and sound is clear.
Okay, very good. Should I start?
Yes, sir, please.
Thank you very much. First of all, I would like to thank you for inviting me again in your panels, and I have to really give this credit to you to do this word education. This is something really invaluable. And I was just listening to the previous speakers, nice pictures and videos, and I really wish I had this opportunity during my training and very early career, because this is really an unbelievable resources for neurosurgeons to learn from the more senior surgeons, for master surgeons, and compare the different techniques. And you can get all of them in a setting of a day. This was something impossible to do before. And thank you for continuing to doing this, because now that we are kind of getting past COVID, that might become less relevant and less common, but I think it's important to continue that. And that's a very good thing that you're doing. So you had asked me to talk about some contribution of bypass surgery and a skull base. And I thought that this in the posterior, actually you had asked me to talk about posterior fossa. And I thought the talking in bypass in posterior fossa probably is a very good combination of both open vascular surgery and skull-based surgery. And I do believe that's the future. The future means that, all of the open vascular surgeons should be a skull-based surgeon as well, and vice versa. That's where the field is going. And things that I'm showing in the next 20 minutes are obviously extreme cases and are rare cases. This is not the daily practice. But if you have an open vascular and a skull-based practice, you will get to do these kind of cases, and you need to be prepared for these kind of cases. So the bypass option for posterior fossa, and I'm going to simply focus on a few, but you can read by yourself. These are different options that we have from using the posterior cerebral artery as a recipient to SCA, ICA, PICA, and the vertebral artery. All these vessels can be used as a recipient. And depending on where the aneurysm is, all the options that are listed in this list that you can see from SCA to PCA, vertebral artery graft and PCA, ECA to PCA, internal maxillary artery to PCA, and so on. You can read by yourself. All these options exist. And I have done all of these options that I mentioned here, but I'm going to just focus on 3 particular cases that is a good combination of a skull base and open vascular surgery in the posterior fossa, and then talk about a little bit of the principles of these. Obviously, the principle of bypass always should be to make it as straightforward and as simple as possible. The simpler the bypass is, the less likely that you get into trouble in terms of bypass occlusion, and easier to fix if there is a problem. The more complicated the bypass gets, the more number of bypass that you have to do, then there is a higher chance of problems and the complications during the procedure. So starting with this case, that this is a large calcified basilar tip aneurysm in a patient, 60-year-old, and this patient came to us with this, as you can see, very dysplastic base involving the right PCA. So obviously, this was not an aneurysm that I would consider direct clipping. It has calcified base on it, and I thought the mortality risk in this case is very high. This is an unruptured aneurysm. My endovascular colleague felt pretty comfortable treating this aneurysm, double wide stent and coiling. And when they did try to do that, they had a very hard time to pass a stent into the right P1. So we came to the conclusion that the right P1 has to be sacrificed, or else this patient will not be able to have a appropriate treatment of this aneurysm. So the problem was that this patient does not have a right PCOM, or a very tiny right PCOM. And the goal here was to do a bypass to PCA, and then we will exclude the P1 by a clip. And the advantage of clipping on the P1 is that you can selectively clip an area that is perforator free. And then that aneurysm will become a sidewall aneurysm. And the endovascular team can go through and just put a stent into the basilar to left P1 and coil the aneurysm. So this is the surgery. This is a half and half approach exposure. You can see here, this is the area of the P2. So when I do bypass on PCA, I prefer to do the bypass on P2 segment, which is right after the PCOM. And you can see here that I have the clip on PCA, and I'm checking the flow. This is a flow probe that measures the flow in the artery. And before committing to the bypass, I still wanted to know if there is really a need for bypass, because if you put the clip on P1 and for some reasons, and there is collateral supply and the patient gets enough flow, there is no need for bypass. You can just clip the PCA, and this way we can turn this aneurysm into the sidewall aneurysm. But this patient not only dropped the flow on PCA, but within literally 30 seconds or 45 seconds of clipping, there was some decrease in somatosensory evoked potential, which made us feel that this patient needs a bypass. We cannot sacrifice this. So the clips are positioned on the PCA. Use this back cutting knife, the long one that is good to open the vessel. And the microanastomosis here, I was using a radial artery, and I'm connecting a graft to the P2. And obviously, this is as deep as a bypass can probably get, because this is really deep in the carotid oculomotor cistern. Still better to do the bypass on PCA here, as opposed to doing it in a subtemporal location, because there is not much retraction on the temporal lobe. And the patient tolerates that, in my opinion, much better. So here we're using a combination of the running, and I usually run one side of the bypass and interrupted suture for the other side. And these are 9/0, has to be 9/0. We cannot use 8/0 or 10/0, is too big or too small. And now the clip is released, and you can see this is the bypass on PCA. Now, this video doesn't show it, but I did connect this graft to MCA also to have a short graft. So I created a jump graft between MCA to P2. And now now that we have the clip on the PCA. Now we're putting the permanent clip on the P1, and you can see the aneurysm in the background. And now the clamps are removed from the graft itself. So the PCA has been replaced by an M2 to P2 graft, and the aneurysm has been basically partially trapped by clipping the P1 beyond the perforator zone. A week after this, after I was comfortable to put the patient on Plavix, in addition to aspirin, the patient went into stent-assisted coiling of the aneurysm. And this is what we get at the end. You can see this is the graft, M2 to P2. Aneurysm was stent coiled and basically cured. This patient had a third nerve palsy that lasts for about, as far as I can remember, 2 months or so, but went completely back to normal. All this third nerve palsy because of this approach, as long as we don't injure the vascular supply to the oculomotor nerve, improves to normal. Next, I would like to talk about the internal maxillary artery. This is one of my favorite, if not the favorite donor for bypass. And this is a great complication avoidance, in my opinion, because when we have to go to the neck and use a very long graft, that's already put you at risk for having a high rate of complications. You can see the IMAX is positioned whether lateral or medial to the medial pterygoid muscles. Identification of the IMAX, we have modified our technique. This is what we published recently last year in Neurosurgery, and you can see how we can find the IMAX is really at the pterygomaxillary fissure, just behind the medial pterygoid muscles. Literally within 5 to 10 minutes of dissection, we will always find the IMAX. And it's very consistent. Now, the course might be a little bit tricky, but the location of it is very consistent if you look at the pre-op imaging. And by cutting the zygoma and detaching the lateral pterygoid muscle, you can easily find the IMAX, liberalize it in its second segment, which is the pterygoid segment, mobilize and use as a donor. Here you can see, this is what we published. And here you can see the modified technique that we changed since 2 years ago. I have changed the technique for IMAX, and you can see here, this is the drilling of the base of the temporal lobe, just to be flat enough, but you don't need to be too flat, it's not necessary. Here you can see the dissection. This is a left side approach. This is a dissection in the pterygoid, lateral pterygoid plate, and this is the pterygoid muscle. This is the medial pterygoid and lateral pterygoid muscles. What I do here is that you stay subperiosteal and you cut the attachment of the pterygoid muscle just behind the maxillary sinus at the level of the pterygomaxillary fissure. And by doing so, you separate those muscles and you stay on the bone, and then with the help of the Doppler, and if you want also navigation or augmented reality, one or the other, you can identify the main trunk of the IMAX. And you can see, this is almost a non-edited video, almost. And you can see it's, since I started this dissection until I get to the vessel, it takes literally less than 5 minutes, and the IMAX is identified. And it's important to separate the IMAX, make sure that you don't injure the adventitia during the dissection, and we will put a loop around it. This is the pterygoid segment, is very long. Cut the branches, it becomes very redundant and easy to mobilize. And this is one of the branch, for instance, this is the temporal branch that goes laterally, and there are other branches, infraorbital branches. All those branches can be cut if needed to mobilize and separate the IMAX. And then the IMAX is free. Then you put a clip on it, you can cut and bring it up bypass. Now, usually when I expose the IMAX, I don't cut it. I let it be, and then I do the rest of the surgery. When I'm ready to do the bypass on IMAX, then I cut it at that point. But here, that's the moment that the IMAX is ready to clip proximal and distal. You see, we cut the internal maxillary artery. Again, this is the pterygoid segment, and you bring it up into the field. And it's a little bit deep, but it's not that deep. And it stays sort of medial to those muscle structures. And you clear that of its adventitia. And you end up with a very nice donor, definitely bigger than superficial temporal artery. And the IMAX can give you up to, you can see the flow here, I'm opening it to just get the flow out. It can give you up to 120 ml per minute of flow. I do not use the IMAX to replace the whole carotid artery, but for anything else, IMAX is perfect. So this patient with a giant basilar artery aneurysm came to us with symptoms of gait disturbances and some weakness of the left extremity. She underwent web, coil, and stent placement in the left P1 to basilar. So she got a stent, and then she had coil and the web. And this is the status after this treatment with residual. We couldn't treat that last part because it was in the back wall. And initially she did well after this treatment. Obviously there is a residual. What I would like to show you is that we were planning to do a follow-up angiogram on this patient 6 months later, but she came a little bit earlier because she was not feeling well. She was becoming cognitively impaired. And you can see that's the MRI, that's the angio before and after the treatment. You can look here at the lateral aspect of the oblique picture of this angiogram showing the residual that could not be treated endovascularly because otherwise you would have lost the right P1. We could have not done a Y stent again because of the angle of the P1. And I have seen, and you can see how the angle of the right P1 is complicated here. And the SCA is coming from the P1. So what we did here, and you can see when the patient got worse, we did this MRI and shows that massive edema. This patient did not have this edema before, but you can see such a significant edema. And at this point, I decided to stop further endovascular treatment with this patient because obviously the edema was getting worse. The plan here was to do a bypass on right PCA and replace the top of the basilar and sacrifice the basilar artery. So this is again IMAX exposure. We're going from the right side. So because I showed you the IMAX, I'm going to pass on IMAX here. IMAX is identified and prepared. This is again a half and half approach. You can see the carotid artery. This is the optic nerve, identification of the basilar artery. You can see the stent. That's the Elvis Jr. stent. And now I need to open the carotid-oculomotor triangle, and I'm doing a transcavernous approach by exposure and opening of the oculomotor canal because I need room for placement of clips. So here, this is the cavernous sinus that I'm opening. And obviously, if there is a bleeding, we can inject a flow seal. You can see the third nerve is identified in its whole course. And this is the SCA coming off the basilar artery, off the P1 and the basilar artery. And here we have the basilar trunk. This is our graft. This is the anterior tibial artery graft that I have used in this case. And we start doing our bypass. The same thing I showed you earlier. This is a bypass done in the P2 segment at the level of the carotid oculomotor triangle with a half and half approach, using the back cutting knife to open the P2 and doing the bypass the same way that I showed you earlier with the anterior tibial artery graft, a combination of running and interrupt the sutures. Now, in this particular case, I decided to do the bypass on IMAX in an end-to-side fashion because it was set in a way that it was easy to do it, or relatively easy to do it end-to-side. So we, instead of sacrificing the distal IMAX, we just kept it in continuity and did a bypass end-to-side. So we have an anterior tibial artery that goes from the IMAX to the P2, and that's the bypass at the completion. And that's, you can see here, the ICG with the angiography shows that the graft is open. But at this point, we have a competitive flow from the PCA. So I'm going in to finalize the treatment by putting a clip on the basilar artery very low, below the oculomotor nerve that I had opened the canal earlier. I put a permanent clip on this Elvis Jr. on the basilar. Initially it was okay, but after about 30 minutes, we were about to close, that this patient presented with decrease in left motor potential. Flow excellent in the bypass, but the patient is failing. Neuromonitoring is going down. So I went back and 4 times switched the position of the clip on the basilar. But unfortunately, this patient, for some reason, couldn't tolerate the basilar occlusion. So I couldn't finish the initial plan of a full Hunterian ligation. So we changed the plan And I felt that at this point, the only thing I can do is to clip the P1, the same thing that I did on the previous case. So this is the SCA, and I make sure that the SCA is patent and is not compromised, and I put a clip on P1 and left the basilar artery connection to the PCA open. So this is at the completion with the open graft going to the right PCA. And this patient had again, a third nerve palsy for about 6 months until she completely recovered. It was recovered to probably over 50% at 3 months, but at 6 months, she was 95% back to normal. But most importantly, her exam dramatically improved. And look at the edema. The edema is completely gone. The aneurysm is completely shrunk. I don't have the very last MRI, but on the very last MRI, the aneurysm doesn't fill anymore. This was done, MRI done about 4 months after the surgery. And you can see edema is gone completely. And at 7 months after surgery, the aneurysm is completely gone. So that confirms that this is a strategy of flow diversion, surgical flow diversion really was the solution for this patient who was getting really worse after the endovascular treatment. This video demonstrates the treatment of this plastic. We can use the occipital artery to vascularize ICA in a patient who has had a subarachnoid hemorrhage with this aneurysm that you see here. Initially treated with endovascular coiling, was a residual. We couldn't get the vessel completely. It's an ICA-PICA. And if we get this vessel in a complete fashion, then the patient will end up with a massive stroke in the posterior fossa, including the brainstem, because there are branches going to the brainstem. So the indication here was to do a bypass on ICA and then sacrifice the vessel endovascularly. This is where the occipital artery comes up at the occipital groove just behind the mastoid groove. And that's where I used the navigation and Doppler right at that location that is shown in this picture. And what we do is that I make the flap in an L-shaped fashion, but I don't look for the occipital artery at all. We bring the flap all the way back subperiosteal, expose the occipital groove right here, and then we start the same way that we dissect the superficial temporal artery. We dissect the occipital artery inside out, and we follow the occipital artery and go up and identify the occipital artery this way. Then we need to do an extended retrosigmoid craniotomy, which means that you really need to skeletonize the jugular bulb. In order to do a bypass on ICA and have this view, that is a beautiful view and unobstructed, you need to have a skeletonized jugular bulb. And once you have that, then it's a matter of dissecting the ICA out of the horizontal fissure, use your occipital artery with a very good flow. And this is the ICA. It's a very deep bypass also, but the same technique. Using here, I'm using a tenos sutures because ICA and occipital artery both are small vessels, and connecting these two together. And this is a bypass that is done in a matter of about 30 minutes or so. And the clips are relieved and the bypass is flowing nicely. At this point, I had decided that this patient will go immediately to angio suite for closure of the proximal ICA. I didn't want to expose that region with coils and previous subarachnoid hemorrhage. This is the completion of the bypass and nice flow going to the graft. We kept the patient intubated. This is the bypass that is open before we close the ICA. That means that there is competitive flow coming from the ICA. And look at the dramatic difference after we close the ICA. And we have now the bypass running. And you can see here, this is all the, basically the whole cerebellum is now fed by the bypass. And the aneurysm is permanently cured. Even the perforators that you can see here on the ICA is preserved in a retrograde fashion with the bypass. And this patient did well without any new neurological deficit after the surgery. You can see all the main trunk and the branches that are preserved. And finally, I want to show you this case quickly. Is the patient with a subarachnoid hemorrhage with a fusiform second segment, lateral medullary segment pica aneurysm, for which there is really no other option than a bypass because this patient doesn't have a good contralateral pica. We don't want to sacrifice this vessel because that's a very early segment of pica, and there is no good occipital artery. So the only option for this would be a VA pica bypass. And what we do here is the forolateral exposure of the right side, transposition of the vertebral artery. There are lots of venous plexus around the vertebral artery that we have to transpose. and we have to control with coagulation and with surgery flow. And this is the pica exposed in the tonsillar medullary segment. Here I'm using a radial artery graft, connecting the pica to the vertebral artery. Same technique, using a combination of running and interrupted sutures, opening of the arteriotomy, extending with micro scissors. And once the pica done, then we go into the vertebral artery, cut the graft always a little bit shorter than what you need, because you don't want the graft to be too long and create a kink when it's the flow is released. So you do the initial sutures with a little bit of a tension. That's okay. It's better that than having a big loop on your graft, because then it's going to kink when the graft opens up, especially radial artery or saphenous vein. And this is the vertebral artery. I had to do a little arterectomy inside because there was a plaque, but nothing significant. And then you just connect the artery to the radial artery to vertebral artery. And this is at the completion. I release the clips on pica and the vertebral artery, and the graft is flowing. And now I go and distally clip the aneurysm. The aneurysm has perforatory involvement at the proximal, so I can't fully sacrifice the aneurysm. I put a clip just distal to the sac of the aneurysm on the pica. And this is what we get at the end. And now the clip is removed on the distal pica to let the flow from the bypass goes all the way back to the aneurysm clip. And this is what we have at the end, with the ICG showing the nice patent flow through the graft to the bypass. And you can see this patient also had this severe spasm, as you can see, but you can see the graft flowing and giving all the flow to the pica territory and coming all the way back, as you can see on these pictures. The flow is all the way back to where the clip is, and obviously the proximal pica is felt in an anterograde fashion, and the perforators remains open by default, and the aneurysm is not visible anymore. So the experience that I had with bypass, this is up to, we have done now more than 220 bypasses, 250 bypasses actually totally, but up to January 2020, we had 40 bypasses for aneurysm, and you can read the result by yourself. And the important point is that, you know, the combination of this treatment, every patient is treated in a selective fashion. Not every treatment was the same for everyone. You can see every potential strategy exists, as this slide shows. 9 patients had combined endovascular and bypass treatment. Immediate bypass patency was 95%. Immediate aneurysm occlusion was 83%, because some patients were treated with a retrograde flow strategy, so we needed time for the aneurysm to occlude. There was 2 mortality in this group, one because of the severe spasm, one because of the pulmonary emboli, but none was because of the bypass itself, but still mortality of surgery, obviously, because it was during the first 3 months period. And we had 4 new deficits, 11%. And the follow-up shows that 91% bypass patency, and most importantly, in this very complex group of patients, 30 patients had MRS of 1 or 2, which would be 84%, which is a good results for these very complex patients, for whom, for every single patient, we discussed and maximized any possibility for anything else than bypass, including endovascular or surgery, but that was their last option, and that's what we did. And you know, we have to be dedicated to bypass. I think bypass remains in our field. This is the papers that my team and my fellows and residents have published over just the past couple of years. And this is a field that I'm really dedicated to, among other stuff, in open vascular and skull-based arena. And the future is bright for this field. We need to have people who are interested, because this really necessitates a significant amount of dedication, passion, and effort for us to be able to continue this field and promote our field and have good results. Thank you very much.
Thanks a lot, dear Professor, for this excellent presentation. Is there any question from panelists? Okay, I have an announcement. We have now registrations so far, about 600 registrations for first day, and we have prepared a separate Zoom link launch for more questions and discussions with speakers. Link is available in chat box. And now we will shift to next speaker, Professor Zada. Please start sharing your screen.
Thank you very much. I stop
Thank
sharing. I say hi to Gabrielle, my very good friend. Looking forward to your talk, Gabrielle.
Thank you. Thank you, Professor Hassan. Amir, great to see you. Phenomenal videos and cases you showed there. It's always a pleasure watching your work. I'd like to thank the EWNC and Professor Hassan for allowing me to speak today, and I'll be talking about endoscopic approaches to the anterior skull base. In the interest of time, we're doing residency interviews today, so I'll have about 15 minutes or so, but I thank you for your attention today. So I hope to review the current catalog of minimally invasive and endoscopic approaches to the anterior skull base, highlight some of the benefits that endoscopy and keyhole surgery provide for anterior skull base surgery, and review some of these approaches. Really an amazing evolution of neuroendoscopy, a very powerful tool we're all aware of, really coming to its own in the last few decades, but several people have contributed to this, including Nietzsche and Walter Dandy, Harold Hopkins, contributions from our program at USC, going back to the 1970s, describing the angled lenses for a variety of pathology. And then, of course, pure endoscopic approaches to the sella have hit their quarter-century mark. This is the first video I know of on the left, courtesy of Professor Capabianca, demonstrating the use of the endoscope by Professor Guillot in 1962 through a speculum. And then you, of course, to see how far we've come with optical technology and instrumentation, and on the right for a transclival approach for a chordoma with brainstem involvement, dissection off the basilar artery. So really become its own field. And now we have access via minimally invasive and keyhole approaches, not only to the skull base, but a variety of anatomical compartments. And we, of course, really try to do procedures this way when pathology lends itself to doing so. We've developed a very robust service line based on adult neuroendoscopy, whether it's pure endonasal or assisted keyhole craniotomy, or the latest, which is port-based techniques as well, where we're incorporating the endoscope. Of course, we can access the entire midline and to a large degree, the lateral skull base as well. In our practice, we do about 2/3 direct pituitary cellar pathology and 1/3 extended approaches, while maintaining the general principles of skull-based surgery. And so obviously for pituitary tumors, this is the go-to. We treat a variety, of course, of macroadenomas, but in cases of Cushing's disease, we try to perform extracapsular approaches. We find that this is often dictated by the consistency of the tumor in terms of this particular technique, but we do find that this does have better endocrine outcomes as well. And so this is for a small left-sided Cushing's adenoma. And moving to more complex pathology, even large macroadenomas with suprasellar extension rarely require an extended approach for a variety of reasons. The waist in the diaphragma cell is often large enough, and the consistency of the tumor is often soft enough that we can get this suprasellar component to descend. Although in more firm tumors, we do need adjunctive techniques. So the angled endoscope is one where we can look not only superiorly, but into the cavernous sinus, make sure that we've decompressed the optic apparatus or removed the cavernous sinus component of the tumor. And then in more firm tumors, we even in macroadenomas, this is where we focus on the extracapsular approach. It doesn't really make as much sense for softer adenomas, but we grade the consistency and we validated this. And so in the higher consistency tumors, we routinely perform this technique of tumor resection. Sometimes craniotomy is still valid, even for pituitary tumors and a variety of other skull-based tumors. This depends on prior approaches they've had or relationship to the neurovascular structures. particularly lateral extension into the sylvian fissure and past the plane of the cranial nerves and carotid artery it can be a telltale sign of this. But again, consistency, if we can predict this, often can guide or tailor the approach required to treat these tumors. We find that it's associated with extent of resection and intraoperative complications. Of course, with extended approaches, we can treat a variety of pathology that you can't treat with direct approaches. Really has expanded our ability to treat complex skull-based pathology. And for anterior skull-based surgery, we have to be mindful that there's still a variety of valid approaches, whether it's a transsylvian pterional OZ approach, a bifrontal approach, rarely used, although for much larger tumors, still required for the occasional olfactory groove meningioma. We love using the supraorbital approach, whether it's via an eyebrow incision or standard hairline incision, occasionally an interhemispheric approach, and then of course the endoscopic endonasal approach. You have to have all your instrument ready to go. If any of these are lacking, this could threaten the entire surgery, whether it's the instrumentation or pedicled flap or repair, etc. And in this video, we're treating an epidermoid tumor of the petrous region and cavernous sinus. So focusing on the anterior skull base and moving from anterior to posterior, along the cribriform and olfactory groove region, we find the occasional encephalocele, whether it's iatrogenic or spontaneous. And so this is a great way to start, as suggested by the Pittsburgh group, where a lot of these approaches were founded. And so repair of an encephalocele or meningoencephalocele is something that we'll encounter. They can be ethmoidal or sphenoidal, of course. Moving on to more complex pathology, such as the olfactory neuroblastoma. These can be very invasive, and occasionally when they're too invasive, depending on the Kaddish score, they'll recommend neoadjuvant treatment. But when we think it's resectable, we'll go for it. It's important to understand this anatomy of the anterior skull base, including the anterior and posterior ethmoidal arteries, and of course the orbits. And so this is a very large olfactory neuroblastoma in a young man in his 40s. We of course prepare a pedicled nasal septal flap and make sure that the margins are free of tumor. We'll do a drill out of the frontal sinuses along with my otolaryngology colleague, and then remove the bone around the tumor, and then really go for an en bloc resection of the intracranial component. Here we're removing the crista galli and then working around the tumor to dissect it away from the olfactory bulbs and tracts and the orbital frontal vessels. And we're able to remove this intracranial component in its entirety, and then focus on reconstruction. In this case, we would use a fasciolata graft without any rigid buttressing, followed by a pedicled nasal septal flap. Moving more posteriorly along the skull base is the transplanum, transtuberculum approaches. The classic pathology for this are craniopharyngiomas, which really lend themselves to this approach for a variety of reasons. Also, of course, tuberculum cellum meningiomas and planum sphenoidally meningiomas can be treated this way when they're carefully selected. Here we're opening the suprasellar dura after cauterizing the superior inner cavernous sinus, debulking the tumor, and then really focusing on dissection laterally away from the PCOM artery and third nerve, and then working superiorly to dissect the tumor away from the superior hypophyseal artery, posteriorly away from the mammillary bodies and basilar apex. And then this is a view that many of us are used to seeing nowadays, this beautiful unobstructed view into the third ventricle. And in this case, we're doing a gasket seal closure as described by Schwartz and Anand. And here you can see the complete resection of the tumor, although in many cases, sparing of the pituitary stalk is not possible or recommended. We have to be comfortable with addressing this pathology from above via craniotomy or from below. And I always encourage our trainees to do that. It's a matter of anatomical perspective. And so I mentioned earlier that we rarely have to do extended approaches for pituitary tumors. Here's a case where we did have to, because the tumor is growing over the tuberculum sella into the anterior cranial fossa, also some extension into the oculomotor cistern. So this patient presented with vision loss and a right third nerve palsy. This is something we would employ an extended approach for, but I'll always try to figure out ahead of time what the consistency of the tumor is, because sometimes you don't need the extended approach to be able to turn corners and suction out a very soft tumor. This one was not amenable to direct approach. So now we're opening the suprasellar dura and careful two-handed microdissection of the tumor away from the carotid arteries, as you see here, and from the optic apparatus. Make no mistake that pituitary tumors can be densely adherent and even invasive, even though they have a pseudocapsule, as you see here. So careful intraoperative judgment is mandated. And here again, we're doing a gasket seal closure. I favor this closure when we don't have direct open exposure of the carotid arteries or optic nerves. If we do, I will usually avoid any type of rigid buttress or implant. This patient had a complete removal, preservation of the gland, and improvement in vision and the third nerve palsy. I mentioned craniopharyngiomas and why they're amenable to these techniques. The long axis of the tumor plus the cystic components make themselves really perfect for this. So I've shown one. The workflow is essentially the same. Open the suprasellar dura and arachnoid, debulk the tumor to slacken the capsule, and then work circumferentially. Careful two-handed dissection away from the optic chiasm, lateral structures, and of course, when they extend into the retrosellar region is when they really require careful dissection away from the basilar apex and thalamoperforating vessels. So I'm going to go, just in the interest of time, to an example of a more complex, craniopharyngioma. See if we could get this to play. So this is a very large craniopharyngioma in a young patient. You can see the retrocellular and suprasellar extension. Here we've done the transplanum, transtuberculum exposure, and now we're doing our dissection away from the optic apparatus. We've removed the bone of the dorsum sella and posterior clinoids so we can access the retrocellular and basilar apex region. Now we're doing our careful dissection away from the third nerve, SCAs, PCAs, and thalamoperforators, of course, which are absolutely critical in craniopharyngioma surgery. We're now using a 30-degree endoscope to remove the capsule from the third ventricle. And once it's slackened and completely dissected, you can remove the tumor en bloc. And then we'll use a fat graft, single layer of fascia lata, and in this case, no rigid buttress, but a large flat. I still like using a lumbar drain for these cases just for 48 hours, and there's good level 1 evidence to support that. With tuberculum cella meningiomas, I believe case selection is absolutely critical, because in some cases, I still think a craniotomy is preferable, especially for meningiomas. This was a perfect case for an extended endoscopic approach with vision loss. I'm just going to skip through this. My ENT partner performed a flap. We then proceeded with bony removal, Dopplering, cauterizing the sinus, devascularizing the tumor early with bipolar cautery, debulking the tumor, and then working over the tumor with careful, sharp dissection away from the optic apparatus, and then laterally from the carotid arteries and posteriorly from the pituitary stalk. This is a case where you definitely want to preserve stalk and gland function. And on to a more complex meningioma, this one with hyperostosis and a dural tail, mandating a transplanum, transtuberculum approach. I wouldn't fault anyone for doing this with an open craniotomy either, but to get a true maximal resection, this is the favored approach. So similar workflow, we've devascularized it. You can see this one is more calcified. And so now we're able to thin it down to a shell and then carefully dissect the capsule and shell away from the optic chiasm. This one we also took out laterally to the medial optic canal to ensure that we could remove tumor. and then careful dissection away from the ACOM complex. And we were able to get a complete resection of this tumor, including the optic canal component. And then again, allograft followed by a flap, and you can see the resection and gland preservation there. So in some cases, I feel that an endonasal approach is not preferable. If I'm worried about reconstruction, or if it's a patient preference, or I feel that the patient could go home post-op day 1 or 2, I love doing an eyebrow approach for that. Whether it's an eyebrow incision, or in women, we'll sometimes use a hairline incision just for cosmetic reasons to avoid a scar in the eyebrow. The supraorbital approach gives a great anterior to posterior trajectory for tumor removal. It's almost akin to that of an endonasal approach or an OZ, a much improved approach compared to a standard terional for this. And we'll do a single burr hole at the anatomical keyhole, 3 by 2 centimeter craniotomy. So here's an example of a planum and tuberculum meningioma that we treated with a right-sided eyebrow approach. I like using these low profile Lone Star retractors, do a McCarty keyhole, turn the flap, and then drill out the undersurface of the orbital rim, open the dura, retract the gyrus rectus, and then start debulking the tumor after identifying the optic nerves. Careful two-handed microdissection away from the chiasm and nerves. And this really gives you a great view of the contralateral left-sided optic nerve and carotid artery to work in this occasional blind spot and remove the tumor. And then of course the closure. And these patients tend to do really well. Just some examples of some supraorbital approaches here. You could see gland preservation and stalk preservation and complete removal there. They tend to heal very well. This is a gentleman who underwent an eyebrow approach, and the scar tends to do very well there. This was a patient with a very firm and complex pituitary tumor that had already undergone a repair with a flap, and we did not want to go back in given the consistency of the tumor. So we followed this up with an eyebrow approach, and were able to remove it completely. Another example of a broad-based planum meningioma resected via a supraorbital technique. And then finally, just in closing, I'm a big believer in versatility of approaches. I think that each of these optical tools offer some benefits, so we'll use them interchangeably. Here we're using an angled endoscope via an eyebrow approach to look behind the optic nerve and really maximize the tumor resection and decompression of the nerve. It just gives some additional data and a different perspective and view of the canal to really maximize tumor resection. You have to be careful with the light source here and turn your light and heat way down on these approaches when you're near the any kind of cranial nerves, but particularly the optic nerve. So again, versatility is key. We use microscopes, we use endoscopes, and we use exoscopes. We use them interchangeably, and whatever it takes to treat each tumor and patient individually. So I hope I've shown you a catalog of approaches to the anterior skull base, both open, minimally invasive, and endoscopic. And I think that this affords the best outcomes for patients. The keyhole craniotomy is a very viable alternative to endonasal procedures. So with that, again, thank you to the EWNC and Professor Hassan and all the attendees. Thank you for having me today. I'm very honored. Appreciate it.
Thank you, Professor Zada, for this excellent presentation. It was a great pleasure for us to join such eminent faculty like you. Thank you.
My pleasure. And I see my good friend, Dr. Barkudarian, on here too. So Garni, great to see you, man. And thanks for having me, everyone.
Is there any question from panelists?
Great. Thank you so much.
Okay.
Take care.
Thank you.
Good to see you, Dr. Zada. Well, thank you.
Let me to next speaker. Professor Garni, please start sharing your screen.
I'm going to work on that right now. Okay. Can you see my screen?
Yes.
It's okay and sounds clear.
Excellent. Well, thank you very much, Dr. Hassan, and to the Egyptian World Neurosurgical Congress for inviting me to speak. I'm honored to be featured among such esteemed panelists and to follow my good friends, Dr. Dadashti and Dr. Zada. It's truly humbling. But I hope to talk a little bit about my perspectives on endoscope-assisted posterior fossa surgery and what value there is with the endoscopy. These are my disclosures, none of which are relevant. So really the main concept is about keyhole surgery. And you've heard a lot already from Dr. Zada and others about this. But the idea is really to remove tumors via smaller, more precise openings to minimize brain retraction and collateral brain injury, as well as soft tissue and bony disruption. And we have a number of keyhole approaches. You've heard about the endonasal endoscopic and the supraorbital eyebrow approaches that Dr. Zada mentioned. But of course, there's the transfalcine endoscopic assisted approach. And the two that I'll talk about today at some length are the supracerebellar sitting operation with the endoscope, either transtentorial or towards the pineal region, or the retrosigmoid approach. So these two I'd like to discuss with regards to posterior fossa endoscopy. Of course, for keyhole surgery, many aspects need to come together, and this has been discussed ad nauseum, but I'll just go over a few things. We really need to have a refined set of instruments that are low profile and bring the hand out of the way from the endoscope such that there's no conflicts. The ultrasound is very helpful in verifying approach and confirming navigation. And the Doppler probe is extremely helpful in helping navigate the vascular supply and avoid any vascular injury, carotid injury, or otherwise. And of course, endoscopy. Endoscopy is the workhorse for some of the approaches, and it is an assistant in other approaches. And I think that they can work well complementarily. These are the instruments that we tend to use, and there's many different options out there on the market, and they're all very good in really getting us to deep and narrow areas. The concept of applying an endoscope, this is taken from Dr. Laws in my review a few years ago. You know, the idea that initially when you bring in an endoscope, especially to a foreign area, say the posterior fossa, the first is maybe you finish the operation and then you bring in the endoscope and you look and you see what you can see and learn about the anatomy from an endoscopic perspective. Then later on, perform an endoscopic assisted removal of that tumor or lesion. And then finally, if it is amenable to fully endoscopic resection, then apply that. But there's a learning curve that needs to be applied. And one must not give up the traditional microsurgical tenets, including two-handed microsurgery, and of course, all of the precautions that we take. So we do not give that up to compromise, but rather we use that in addition to endoscopy. Many of you have seen some of the values here, so I won't belabor this too much, but bringing the endoscope beyond an aperture gives you a more panoramic view. And so this is an example, and I wish I was there with you all in Egypt right now, but when I was visiting a few years ago to you, I encountered the pyramids, and here you see us going through this keyhole, and we see one of the pyramids. And it isn't until we put our head through the hole that we can see that there's so much more than just a pyramid hiding behind this area. And we can introduce an angled endoscope, and we can look towards the side and see structures that we weren't able to see before. So there's a lot of value in endoscopy, both for endonasal as well as traditional keyhole approaches. So let's talk about the supracerebellar sitting operation. This is by no means a new approach. This has been published for many, many years now, almost 20 years has been published and reported. And it's a good approach for pineal region lesions, as well as posterior midbrain and tectal lesions. And then one can go through the tentorium from below to above, as you can see in the image, to reach medial temporal or medial occipital lobe tumors. And I'll give you some examples. This is the setup. We perform a sitting operation. The patient is in somewhat of a reclining chair position so that the legs are above the pelvis. And the idea being that the blood will flow down to the pelvis and help with cardiac return. We flex the neck as best as we can so we can get an angle, because usually the angle is very steep like this, and you want to bring this as far forward as possible. You see a resting area for our arms, because anyone who's done this knows that there's a lot of fatigue with how your arms are held. And then, of course, we want to monitor for air embolism. So here in this case, we have a precordial Doppler, but we've actually moved to transesophageal echocardiography with a central line axis to see very early on if there are any air bubbles coming in. And in conjunction with navigation and Doppler, it is a useful way of performing this. One caveat is that one must check and make sure the patient does not have a atrial septal defect in the heart or a patent foramen ovale. And if that's the case, then an air embolism could result in a stroke or a heart attack. And in those situations, you want to perform these operations in a prone position. So we perform an echocardiogram with bubble study before any procedure to make sure we don't put the patient at increased risk for those more serious aspects of air embolism. Well, here we are with the microscope, and you can see the typical setup. The microscope has volume and depth of about 2 feet. And that means when you're sitting in an extended position, your arms are at full extension. It decreases your range of motion. It's an uncomfortable position. We're hunched, and it actually does not lend to great ergonomic positioning for a long operation. And many of these operations are quite long. So that can result in surgeon fatigue and could make certain mistakes come apparent. Whereas here I am with my partner, Dan Kelly, and you can see the one surgeon is holding the endoscope and also another instrument or an irrigator, and the other surgeon is using 2 hands. So we still use microsurgical approaches, microsurgical techniques, but we have a 2-surgeon approach here, and it's much more comfortable with our arms in a more ergonomic way. This is an example of a surgery fully endoscopic for a pineal parenchymal tumor of intermediate differentiation, which was diagnosed with an endovascular intraventricular biopsy. But of course, it requires full resection based on the discussions we've had with our neuro-oncology colleagues. So this is a small craniotomy performed just at the junction of the occipital sinus and the transverse sinus. And here we're looking at the top of the cerebellum. We come right up to the transverse sinus, and we want to make sure we visualize this well. We protect the cerebellum. There's usually a few bridging veins, and we want to preserve them if they're large. We sometimes even place some glue on them, but here's a view of that, one of the bridging veins that we support with some muslin gauze and glue. The key part of the operation is removing these adhesions of the superior part of the cerebellum. And then you see this thickened arachnoid. This arachnoid is always very thick. It looks concerning, but very easy to come through. There's usually not a lot of vessels immediately behind there, but of course, a few millimeters deep to that, you'll encounter some of the deep draining veins. We usually work on one side of the cerebellum for these locations, and here we encounter the cyst already there and the tumor behind it. And then again, now we just perform our typical microsurgical techniques here with bipolar and 2-handed approach, dissecting it off the vasculature. And then just in the interest of time, I'm just going to speed through this portion of the resection. You can see us dissecting it away from the midbrain. The midbrain here is at the bottom here. And then we finally enter into the posterior aspect of the third ventricle there. And then we're able to come around this tumor effectively in a partially en bloc way to remove this tumor as best as possible. This is a collagen sponge we place into the third ventricle to prevent blood going in. And then here you see the third ventricle and then the cerebral aqueduct in this location. And this patient did quite well, had some transient visual obscuration due to the posterior commissure, which resolved within a couple of weeks. And did well returning to work at that point in time. So this is a great approach for these lesions in this location here. And here you can actually see when we close, we put an inlay collagen sponge, and then we put an onlay, and you don't have to actually get to a fully true watertight closure because this is all you really need. It's a small exposure, it's above the cerebellum, and even though you went through the ventricle, this is all that you really need. And having done many of these, we have not had a single CSF leak through this small exposure. So this is a typical approach. Here's an example, just an external video showing the ergonomics of the operation. So this is a midbrain cyst that we went through, again, similar approach. This is, again, my partner, Dan Kelly and one of our fellows, Aaron Cutler. And you can see Dr. Kelly is holding 2 instruments and operating. Dr. Cutler is holding the endoscope with 2 hands, making sure to protect all the structures in this area. And it's very relaxed, very ergonomic. The arms are about 90 degrees. And you can see that it's a much more comfortable approach than using the microscope, which having had to do that a few times is a bit more uncomfortable. And this patient did quite well with this cyst fenestration. This is an example. These are some articles that we published. This was one about the medial, temporal, and occipital lobe tumors and lesions with this approach. And we actually go through the tentorium, and I won't show too many videos on this topic in the interest of time. But this is an example of a lady with metastatic melanoma with a solitary metastatic tumor. And the traditional approach would be just a subtemporal approach to get to this tumor, or maybe an interhemispheric approach. But the concern is that the optic radiations are just hugging this tumor on the lateral side. And we were worried that we would be disrupting too much of those optic radiations coming in from that location. So we opted for a sitting transtentorial approach here. And this is, sorry, the video is not going to be able to play on this case, but basically shows that we can come through the tentorium and then accomplish a gross hole resection in this location by cutting through the tentorium, and the cerebellum is very favorable in that location. So what are some of the pearls and pitfalls? Of course, I mentioned a preoperative echocardiogram with a bubble study is absolutely necessary to make sure that this is a relatively safe operation. And the intraoperative air embolism detection techniques, we prefer the transesophageal echocardiogram and a large lumen central line for access and good communication with the anesthesiologist. The positioning is key with the flexion of the neck as best as one can do. And angled endoscopes are very helpful. So either using 2 surgeons or 1 surgeon and an endoscope holder, but definitely you want to have 2-handed surgery for the actual dissection. And of course, there's many ways to reach a lesion. So if this does not appear to be the best way to do it, one should not force this approach. We really use this only when absolutely indicated. The second part of this is about posterior fossa retrosigmoid approach. And I want to credit Dr. Daniel Piper, who passed away a few years ago. He actually had one of the largest series of endoscope-assisted and fully endoscopic cerebellopontine angle operations. And I visited him. I had the pleasure of visiting him in Michigan a few years ago and adopted some of his techniques. So one question is, is this a gimmick? What are the advantages? Is there truly a value in using an endoscope for cerebellopontine angle, or is this just a marketing technique people are using? And so here's some literature that was published. This is actually from Dr. Piper's group from more than 12 years ago, and demonstrated that they had the comparable results with microvascular decompression for trigeminal neuralgia. They showed, of course, the typical response rate was comparable to a traditional open approach. They did not have any increased complications. This is another study from Dr. Reddy that showed for cerebellopontine angle vestibular schwannoma resection, they had actually very good facial outcomes. I think there was a little bit of a selection bias. Some of the smaller tumors were being treated with this, but certainly there's at least comparable data suggesting that there's some safety here. But from my perspective, these are the conditions I think that can benefit with endoscopy. So trigeminal neuralgia, I think, is key, but more importantly, actually hemifacial spasm, and I'll show you an example of that. For vestibular schwannoma surgery, many of you in the audience have done a lot of these, and you know that you can see the majority of the tumor very well. It's really just the intracanalicular portion. Even with the endoscope, you still need to have access to that area, so you still need to drill out the internal auditory canal. So the endoscope doesn't give you too much of benefit from that perspective. One thing that a few of my colleagues have mentioned are that once you do resect the intracanalicular component, you may have entered into some air cells medially, and that may have some value with endoscopy to identify those air cells and seal them up, although many people still put a fat graft there anyway to prevent that from leaking. So unclear about the value of that. Meningiomas, again, sometimes meningiomas and other tumors can enter into the jugular foramen or other foramina like the Meckel's cave. And so there may be some value there. I think this is still a question to answer. And then epidermoid cysts actually are very favorable for this, and I'll show you an example of that. But we should talk about the risks of endoscopy. And so we always worry about injuring our patients. So certainly an inadvertent facial nerve injury or obscuration that just doesn't let you see the critical structures, perhaps even at a critical point in surgery, resulting in hematoma. Those are all things that we'd be worried about. So just discussing endoscopy alone, so an endonasal operation has very minimal structures at risk. You know, for a true endonasal, you really don't have a lot of issues that the endoscope itself can injure. If you go into the sella, into the suprasellar area, yes, of course, the optic nerves and potentially the other cranial nerves in the cavernous sinus. Once we move to the supraorbital approach, as Dr. Zada mentioned, of course, the optic nerves, the olfactory tract could be at risk by introducing the endoscope. A transfalcine or supracerebral approach can affect some of the veins. We talk about air embolism. But once you enter into the retrosigmoid portion here, you now see many of the critical nerves here, 4, 5, 6, the 7-8 complex, the lower cranial nerves, as well as vascular supply that can be affected. And an inadvertent slight shift of the endoscope, or if the endoscope holder slips just a few millimeters or a centimeter or so, could result in significant injury. So one must take this into consideration. And I'd prefer to do this with 2 experienced surgeons to make sure we have 4 sets of eyes, or 4 eyes and 4 hands, and 2 people always paying attention to the scope as well as the resection. Well, how do we set this up in surgery? So much like we've done in endonasal surgery, and here are my partners, Dan Kelly and Chester Griffiths. This we've published many times, where we show that the endoscope is situated in one nostril, and then you have one instrument down low on the left and one instrument in the other nostril on the right. Well, so this was published by Dr. Kelly 15, 20 years ago, demonstrating this triangle at 11 o'clock, 8 o'clock, and 4 o'clock. And then John Lee from the University of Pennsylvania demonstrated the same concept with this triangle in a posterior fossa, where you have the endoscope at the top and your 2 instruments at the bottom left and bottom right. And by doing that, your instruments will stay out of the way from the endoscope, and you won't have too much of this sword fighting that you can have in the depth in that location. That said, when we looked at our cadaveric analyses, looking at access to Meckel's cave, for example, access to, from a retrosigmoid approach, did not demonstrate a significant benefit for angled endoscopes for either approach. So yes, endoscopy can get you good visualization, but it's unclear how much benefit you get once you use additional angled endoscopes. So this is our typical setup in the operating room. We use a beach chair setup. So the back is at about 20 to 30 degrees, and the neck is in line with the back. Head is turned to the left. This is our favored approach. If there's a very stiff neck, or we're concerned about venous outflow, we may put the patient in a lateral park bench position, 3/4 prone position. But this is a nice way, because this positioning allows the cerebellum to fall down and gives you access to that area here. That's a traditional exposure here, relatively small approach. And here's a MVD we're performing for trigeminal neuralgia. And I'm just going to kind of skip through, so that we start with the microscope. And you can see with the microscope, the trigeminal tubercle is sitting right over the trigeminal nerve, and you can't see the cisternal segment here. You see the SCA, which is probably the culprit vessel, but there's also a vein there, and we're not able to see very well down deep. And instead of drilling this tubercle, which is a very appropriate way of handling this, we decided to introduce an endoscope. And we're deliberately massaging the nerve to help with the postoperative pain. But as you see with an endoscope here, we're seeing that there is some vascular compression distally, and it's unclear if this is clinically relevant or not. There's a lot of debate about that, but there is a vessel contacting the nerve, and we might as well decompress it while we're there. So here, during using endoscopy, we're able to introduce the Teflon pledgets beneath that traversing vein, and then we are able to then subsequently decompress the artery that is up against the nerve itself. And this approach that we've adopted works quite well, and we have about a 90 to 95% facial pain resolution for trigeminal neuralgia. But as I mentioned, I think hemifacial spasm is really where the endoscope shows a lot of value here. So this is a patient who had refractory hemifacial spasm. I'm just going to skip through the approach again. Again, we start with the microscope. We bring in the microscope. We always work down to the lower cranial nerve. So here's 9, 10, 11, and the conflict is going to be down there, down behind the 9th cranial nerve. So the root exit zone of 7 comes all the way down behind the 9th cranial nerve. And this is where the endoscope is very helpful, because with an angled endoscope, a 30-degree endoscope, now we're finally seeing the facial nerve, and we're seeing the point of conflict down here, and we lift this vessel up, and we're able to separate it with the Teflon pledgets in that location. And this is a view that is very difficult to see with the microscope without either significant dissection or brain retraction. And the endoscope allows us to visualize this very well. We're also able to come above the facial nerve by the trigeminal nerve, make sure that there isn't any other points of contact. And it's a nice versatile tool for us, especially when you have that very deep sulcus in which vessels can live. I did mention epidermoid cyst. So this is a patient who had mild hearing loss and a growing epidermoid cyst. This is a fully endoscopic approach. And you can see just, there's no bleeding, obviously, with epidermoid cysts. They're very kind to endoscopy. And it's very, because they enter into the various nooks and crannies in the posterior fossa, the endoscope is very nice to look around these corners. So here's epidermoid that's in that sulcus below the flocculonodular lobe there. And you can see how we're able to work around these nerves and access these cyst components. And then even here, we're able to look down deep around the sulcus there and aspirate some of these contents and able to remove the majority of that epidermoid cyst with good resolution of the patient's symptoms. So the epidermoid cysts are very responsive to posterior fossa endoscopy. And then finally, this is an example of a hemangioblastoma. So hemangioblastomas are very vascular, as many of you know, and you can't just enter into the tumor and debulk it as you would a vestibular schwannoma. This one, you have to come around it, and so the endoscope is helpful. This is the initial part is performed again with the microscope, but we need to bring in the endoscope to help get behind the tumor, disconnect it, and then verify you have good hemostasis and resection of the entire hemangioblastoma, which is hard to see above the cerebellum with the microscope, and the endoscope gives you good visualization. And part of the operation was performed with the endoscope, but I think the video only captures that final part here. But it is a very helpful tool. So to conclude, what are important aspects of posterior fossa endoscopy? Clearly, patient selection. The positioning is absolutely critical, and you want to use gravity to your advantage. You could use an endoscope holder like we have here. I don't really use an endoscrub. We just use hand irrigation, and the armrest is helpful as well. Of course, knowing the patient's anatomy is very critical in avoiding any sort of surprises in the operating room. Sometimes a 2.7 millimeter endoscope is a little bit better than a 4.0 millimeter because it's slightly smaller and you can work between, say, the 9th and 8th cranial nerves. And again, don't compromise. If this is not appropriate for endoscopy, then you don't need to bring it in. And I feel you need to perform this with 2 experienced surgeons who know how to handle endoscopy. So my interim conclusions, as this is really a technology or an approach in evolution, I think for microvascular decompression of trigeminal neuralgia, unclear if there's any clinical benefit, but it's nice to see the vessels to decompress. For hemifacial spasm, I think there is clear benefit with using endoscopy. I don't think there is a significant benefit in vestibular schwannoma surgery other than to make sure that there isn't any air cells entered. Epidermoid cysts, as I mentioned, are very helpful, and some of the extraocular tumors are helpful as well. So I'm happy to answer any questions. I thank you again, Dr. Hassan, for inviting us, and me particularly for this presentation, and I look forward to answering questions now or later on. Thank you so much.
Thank you, dear friend, for your excellent presentation. Is there any question from panelists? Thank you, Sam.
Excuse me, Sam. I'd like to invite Garni to the Zoom lounge. I put the link in your chat. Just leave this Zoom and go into that Zoom. We're trying to improve networking, Sam. Okay, onward, Sam.
Okay, thank you. And now we will shift to next speaker, my dear friend, Professor Jean de Oliveira. Please start sharing your screen.
I hope you are seeing my screen.
It's okay, and sounds good.
Okay, for any reason, the picture that was right here is not appearing, but no problem. I'd like to thank you, my dear friend, Dr. Sameh Hassan, for this kind invitation to be part of this beautiful Congress, especially because it's about skull base. I have no disclosure. I would like to talk about skull base approach for aneurysms. Every one of you knows that aneurysms, as well as the other cerebrovascular lesions, has something in common, which is cure. Aneurysms can be cured, and there's no doubt that the best way to cure an aneurysm is using microsurgical clipping techniques. There is a very strong evidence in the literature that the chance of cure is too much higher using clipping than any other endovascular techniques. Obviously, the morbidity and mortality also has strong evidence showing that no difference between clipping versus coil regarding morbidity and mortality. So, I may have some technical problems right here. Let's see. I have to close my PowerPoint, open again. Just a minute, please.
It's okay.
Seconds. I think something wrong is running over here. Let's see. Okay. So are you seeing my screen?
Not yet, not yet.
So I have to share again, right?
Yes. There you go.
Okay, let's see. Sorry about that. Okay. So this is a Transylvian approach showing the completely Sylvian fissure open, and you see the anatomy, and also you have the assessment of the flow using ICG in few seconds, and also you have the functioning in the same procedure. So there's no other procedure where you have so many technologies and so many assessments of the anatomy, the microsurgical technique, the analysis of the flow, as you can see right now, and the function using intraoperative monitoring. So this is the safest way to clip aneurysm. Of course, it's not easy to expose one aneurysm, so it's very important to master the skull-based techniques in order to have the better exposure to clip these lesions. I have a pleasure to introduce to you this new book in which I am very honored to be part of this editor committee along with Professor Luis Borba. In this book, you can see all the approach, and I'm gonna show you for you the most common ones. Start with the Teniono approach. This is a multiple intracranial aneurysm case where you can see here a ruptured MCA in several small aneurysms in the carotid artery. So using a regular transfusion Teniono approach, you can reach easily open the Sylvan fissure, clipping the MCA ruptured aneurysm, and go using ICG, analyzing the flow, going down and see the anterior choroidal artery aneurysm. You see the origin of the choroidal artery right here. And you put the clip in an oblique way in order to preserve the origin of this anterior choroidal artery. And you see right here another aneurysm projecting upward, put a clip, and now you have aneurysm arising from the medial and posterior aspect of carotid artery. In this case, we have to using skull-based technique for removing the clinoid process. So we are removing the dura from the clinoid, to drill the clinoid process, to expose the clinoid segment of carotid artery, to open the distal dural ring. So it's a step-by-step procedure. So you see the drilling of anterior clinoid process. So this is part of cavernous sinus unlocking. So you can see right here the clinoid. You can see the clinoid segment of the carotid artery. You see here cutting the distal dural ring. You have to cut it in the circumferential way. Easily stop the bleeding using fibrin glue, and now you can mobilize the carotid artery easily, and using fenestrated clip intended way, you can occlude completely these aneurysms. So we put 2 or 3 aneurysms parallel in order to occlude completely the aneurysm and also to preserve the flow in the carotid artery. So it's mandatory to have some kind of technology to analyze the flow. In this case, you use ICG, as you can see here, the preservation of the flow in the carotid and the complete occlusion of all aneurysms. So Teniono approach is the most used approach. So even when you have a large or giant aneurysm like this in the left side and this in the right side, with the patient present with a visual deficit, you have to use skull-based techniques like we just presented, but the anatomy of the skull base is very important, especially the points where the clinoid process is attached, and also some situations too is necessary to open the optic canal. So this is extremely complex anatomy of the cavernous sinus to understand where you can cut, where you can dissect to expose this small segment, which is the clinoid segment of the carotid, the origin of ophthalmic artery. And so it's mandatory to go to the lab and practice the anatomy, practice the techniques. Is the only place where you can improve your technique. So for cases like that, we do not extend the head. You see the head is parallel to the ground. It's very important to have the control in the neck. So carotid exposing the neck, and then you perform, for this case, a Teniono approach. So we start for the left side. You see a large aneurysm. This case illustrates that not forever single case we need to remove we have the neck of the aneurysm exposed. So I'm gonna skip here. So you see the aneurysm clipped, suction of the aneurysm. It
it's a good strategy to open the surgical field and the occlusion of the remnant in the posterior aspect of the carotid using a fenestrated clip. So coagulation of the aneurysm also is important. And you see here a remnant right here and occlusion of the total aneurysm. Regarding aneurysm surgery, you have to have the postoperative angiography to make sure that you have the carotid preserved, the ophthalmic preserved, and there's no remnant of the aneurysm. You see that this is the same patient. It's right side where she had a posterior aspect of the carotid was having an aneurysm arising from. So it's the same technique, different from the left side where we didn't need to open the cavernous sinus. So in this right side, we have to open it. This is anteroclinoid process. We like to expose the bone completely. Here is the third nerve, the free border of the tent. And so now you have the whole anteroclinoid process exposed. We're gonna start to drill it. Sometimes we have blood coming from the bone, so you can stop it using bone wax. When the bleeding comes from the cavernous sinus, you have to use fibrin glue. Be careful of the tip of the anteroclinoid process, because sometimes it's very, very puntiform, like you can see here, very sharp. So be careful with that because you can perforate your carotid. Now we have the exposure of the clinoid segment. You can see right here the distal ring of the carotid artery. So you have to cut it using a micro scissor in the whole circumference of the carotid. Be careful in the medial wall and superior where the ophthalmic artery arising from. So in this case, we are doing a little bit more of the optic strut in order to expose the medial wall of the carotid and the lateral wall of the sphenoid sinus, like you can see here. Now you can see the ophthalmic origin in the carotid. So you have to continue to cut the distal ring, and now distal to the ophthalmic artery. So after you cut the whole circumferential distal ring, now you can mobilize the carotid artery in order to expose the whole aneurysm and the whole cerebrovascular anatomy. Now we have space to put a temporary clip right here in the clinoid segment. I'm doing a trapping, and now we start to put the clips using a fenestrated clips. That aneurysm was a broad based, so we had to use one more clip, fenestrated clip, preserving the origin of the posterior communicating and also anterior clinoid, anterior choroidal artery. So you see here I'm checking the flow using a microdoppler in the posterior communicating, and right here the origin of the choroidal artery. After that, of course, you have to decompress the optic nerve and decompress the pituitary stalk that was compressed. Here you can check the flow in the origin of the ophthalmic, and after suction the aneurysm, you see the compression and relief of the mass effect of optic nerve, and also the pituitary stalk right here that was compressed. So this skull-based techniques to open this cavernous sinus is very important to treat this kind of aneurysm and to reach a complete occlusion, not only but also the recovering of the visual deficit. Trigeminal approach can can be used for small aneurysm arising from distal part of the basilar artery, as you can see here. After you open the Liliequist membrane, you can see the basilar, SCA, P1, some perforatings right here, this small aneurysm, perforating contralateral, SCA, P1, contralateral. So depending on the position of the distal part of the basilar artery in the anatomy, you can see small aneurysms like this and clipping in this very small space between the carotid artery and optic nerve using a regular pterional transfusion approach. So you see the complete occlusion, this postoperative angiography. But when you have aneurysm very high, in a very high position like this one, so you have to use different kind of skull-based approach. Again, in this book, we describe a stepwise procedure. In this case, you use a pretemporal approach, which provides different routes to reach the skull base. So for this kind of aneurysm, you can try to go in this small pace, in the space, in this area of the bifurcation of the carotid artery, between the carotid artery and optic nerve, and also between the carotid and the third nerve. I'm gonna keep this. So you see in this case, a broad-based aneurysm anterior communicating artery, and this aneurysm in the tip of the basilar artery. Look at how high this aneurysm is in relation of the posterior clinoid process. So this requires the orbital-zygomatic pretemporal approach. So this is the way how we do that. It's very similar to pterional until you reach the exposition of the zygoma and the lateral part of the orbit. It's very important to reconstruct the skull base using this vascularized flap. So this we don't cut the muscle, we just detach the muscle. We don't remove the zygoma, we just cut anterior posterior and pass the muscle through this window that open. We keep the zygoma attached to the masseterian muscle, and this is the beautiful exposure where you have the whole lateral aspect of the brain. Of course, just a minute. Of course, you have to open the Sylvian fissure very wide, the wide fashion, in order to reach the cistern, exposure of the bifurcation of the carotid. Remember that this patient had a anterior communicating artery aneurysm. Here you can see the interhemispheric dissection, fissure dissection. And now we have the exposition of the A1, this side, ipsilateral. Now you can see the both A2. Using a fenestrate clip, I'm occluding the base of the aneurysm, preserving both A2. You see right here. Checking the flow using microdoppler. And now this is the end. Of course, we had very high basilar tip aneurysm. So opening the Liliequist membrane, you can see the basilar trunk. You can see the posterior clinoid right here, but you cannot see the aneurysm using the transfusion road. So we have to change the angle for that. So now we are starting to sacrifice small veins from the temporal lobe. We're gonna change our pretemporal transceiver approach using now pretemporal temporal polar approach route. So this is very important because when you go in this way, you cut the arachnoid that attach the temporal lobe in the freeboard of the tent, and now you are starting to expose the third nerve right here. So we are enlarging the window, and now you can see the freeboard, the third nerve, P1. This is carotid in the trunk of the basilar right here. But look at how it's important to change the angle of the microscope, and now we start to have more space in this window, so you can start to see the aneurysm right here, because it was almost on the floor of the third ventricle. So you can see here the posterior communicating artery and several perforating arteries arising from this origin. So I avoid in this case to sacrifice the posterior communicating artery, which could be very interest to enlarge the surgical field, but we try to keep it. So here you can see contralateral SCA, contralateral PCA here, a small perforating arising from P1. And you also gonna see the contralateral third nerve, which is gonna appear right here. You see right here the contralateral. So this is a beautiful approach, but still having a narrow space for the aneurysm. So the ipsilateral side, there is no perforating. You see right here the aneurysm. And now we're gonna looking for a perforative free zone in order to put a temporary clipping in the basilar trunk and start to dissect the aneurysm. So removing the temporary clipping and put the definitive clip in the aneurysm, checking the flow, checking if any perforating was included, and punct the aneurysm and suction it. This is the postoperative angiography, show complete occlusion, the anterior communicating also in the basilar tip. So using the orbital-zygomatic pretemporal approach can provide a very, very good space, including for complex aneurysms like this one, large, projecting posteriorly with a broad base like this. So when you use the same approach that I presented previously, you can see this, but sometimes you have a calcified aneurysm like that with sclerosis in the wall. Several very difficult case. So after you put a temporary clip, the aneurysm start to become more soft, so you can smooth, so you see if the perforating arteries are free. Additional clip. So after you put the clip, you don't see any aneurysm remnant. Oh, sorry. So, but you see the perforating ipsilateral and also contralateral right here. Arteries were preserved during the clipping process. So this is very, very important to have intraoperative angiography. So you see the whole perforating branches preserved. And here the postoperative angio-CT. basilar trunk aneurysms, it's a very challenging aneurysm. So in this case, we had a small aneurysm, so we use a transpetrosal anterior petrosal approach. This is the position monitoring, intraoperative monitoring. It's mandatory to know the anatomy of this region, especially this part of this piece of bone, which is the area where you're gonna remove. You use the drill. I like to start. This is a frontal region. This is a temporal region right here. I like to start before I start release the CSF from the cistern of the carotid in optic carotid. After that, we try middle fossa and start to here coagulating the artery. And start to peel in the middle fossa. We just coagulated the middle meningeal artery and start to peel. Put some stitches to retract the dura. And hit the exposure of V2, V3, the petrous apex. Sorry?
2 minutes.
Okay, the petrous apex. So I'm gonna accelerate that. So drilling the petrous apex, open the dura to expose the fifth nerve. Now we have the fifth nerve right here, and you can mobilize the fifth. So now we have to drill a little bit more. Here you can see the sixth nerve, the basilar artery, the aneurysm. We are lateral to the fifth nerve. Now we are medial to the third nerve. So you can see the whole aneurysm right here. You have a proximal and distal neck of the aneurysm exposure. And we're gonna put the clip to occlude this. I'm gonna skip it. This is the postoperative angiography. This is the root. And I'd like to finish about this is far lateral for pica aneurysms. This is step was in the book. This is the exposition. For aneurysm arising from pica, you have to work between the nerves. So we have to know this anatomy. Sometimes you have to use extended approaches like we publish in neurosurgery. And after the exposure, you can see here the vertebral artery, the aneurysm right here, the pica, and the importance of use ICG is a good example. You put the clip, you have no flow into the aneurysm, but we don't have flow in the region of the pica, and the flow is coming in the retrograde manner. So for preserve the pica flow, you still have a small remnant right here, and additional clip can solve this problem. And now we have a complete occlusion and preservation of the pica. So again, I like to to thank you all the organization committee. This is the Santa Casa from São Paulo. Any one of you is most welcome to visit us here. And this is C. Camargo Cancer Center, also in São Paulo, and where we have a great pleasure to meet you. So Sami, again, thank you very much for this kind invitation.
Thanks a lot, dear friend, for this excellent presentation. Is there any questions from panelists? Thank you, Professor De Oliveira. And now we will shift to the next speaker.
Excuse me, Sam, once again, I'd like to invite John De Oliveira to come to the Zoom lounge. John, are you still there? Perhaps not. Okay, Sam, onward.
Yes, I'm here. I'm here.
Okay, I sent instructions to your chat. Okay?
Okay, thank you.
Okay. Thanks, Sam. Onward.
Okay, we will shift now to Professor Yasha. Professor Yasha, please start sharing your screen.
Hello, can you hear me? Can you see my screen okay?
Yes, it's okay.
Okay, excellent. Thank you very much for this opportunity to speak, and pleasure to speak after such a great comprehensive conversation on management of aneurysms. I'm going to focus my talk on one approach and variations of it, the orbital-zygomatic approach, and some of the applications of this approach, including sort of a step-by-step algorithm for how this can best be performed. I apologize, I just want to make sure that I have no disclosures. Here's just a brief outline of my talk today. I'm going to talk about indications of the orbital-zygomatic approach, how different exposures can be tailored for different lesions depending on lesion location and lesion extent. And then I'm going to focus on a step-by-step algorithm for performing the OZ and the mini modified orbital-zygomatic approach, followed by just a few case examples of the versatility of this approach and the types of anatomy that could be tackled using this approach. So, quick note on indications. I put these up front in the talk because I think it's important to remember where this approach has a role. It certainly is not an approach that should be used for any and all lesions, but there are certain lesions where this approach provides real benefit. And it's also important to understand the limitations of the approach and the potential complications associated with using this approach, because there are certainly reported complications with the additional bony removal that's encountered, and the patients need to be advised about this upfront. But this approach is really an extension of the frontal lateral or the pterional craniotomy. You can add removal of the orbit for an inferior to superior view and access, and you can remove the zygomatic process for a middle fossa exposure. And really, the variations that I'll talk about today make use of these two facts and look at the pathology, look at what portion of the approach you actually require, and then perform the osteotomies that are necessary to do this safely. Together, this bony removal gives you better illumination. It results in less brain retraction, and in most cases, you can completely remove the use of a fixed retractor for pathologies, and it can improve angles of surgical attack. And there are several great anatomic studies that have demonstrated the added operative exposure that's afforded by this approach. This is really ideal for a few pathologies, and I'll touch on these. It's ideal for high-riding basilar apex aneurysms, and again, especially those not amenable to endovascular treatment, or those cases of endovascular failure where microsurgery is necessary for these posterior circulation aneurysms. It's great for anterior communicating artery aneurysms, even small ones. Definitely those that are tucked away into the interhemispheric fissure and may be more difficult to leach. Using this approach for anterior communicating artery aneurysms means that in most cases you don't need to remove the gyrus rectus to obtain the necessary exposure that you need. And finally, it's useful for cavernous sinus and anterior middle cranial fossa tumors. A less well-established use of this is for accessing the ventral midbrain for select ventral brainstem cavernous malformations. And I will talk about one case of that later today, showing how this approach, as well as knowledge of safe entry zones to the ventral midbrain, can allow you to remove regions in this area. I think it's important to start this conversation by talking about the skull-based paradigm and the skull-based approaches. One of the tenets of skull-based surgery is additional bony removal will enhance exposure and minimize brain retraction. Yet what we see is in most cases, despite extensive skull-based approaches, a lot of surgeons still place fixed retractors to improve their view and illumination and retract the brain. And one sort of questions whether this is always necessary, especially with the additional approach. And I think this is where the orbital-zygomatic craniotomy comes in over the standard use of pterional craniotomy for accessing circular Willis lesions. This illustration here demonstrates that the approaches to the anterior and middle cranial fossa are a spectrum. And often pieces of these approaches are combined together to get enhanced exposure depending on where the lesion is. For example, an orbital-zygomatic approach can be combined with a Kawase if you need both the subfrontal, pretemporal, and middle fossa exposure that's necessary. And you can combine these and different skin incision variations to expose lesions based on the extent of pathology. But you have to really think upfront about what it is that you're approaching and whether you need the bony removal that you're seeking. For example, a standard subfrontal exposure gives you a subfrontal exposure, and that's about all. The illumination, the depth of the surgical field, and your trajectory doesn't really allow you access to much else other than that pure subfrontal corridor. When you take the pterional craniotomy, especially with splitting of the sylvian fissure, it gives you access to the anterior middle cranial fossa, but because of the collapse of the lobes and because of the bony anatomy often and coning of the light from the operative microscope, illumination at the depth can be quite difficult. That's where the additional of the orbital and the zygomatic osteotomies comes in. So with the orbital-zygomatic approach, you get really three different corridors to the depth of the skull. You get a subfrontal exposure from removing the orbital rim. You get a middle fossa subtemporal exposure by removing the zygomatic arch. And then you get, more importantly, a pretemporal half-half approach by splitting the sylvian fissure and retracting the orbit inferiorly to be able to access lesions that are both high, deep, and really in most cases in the posterior fossa with mobilization of the nerves and the arteries around their arachnoid bands, a deeper exposure into the top of the posterior fossa. So let's look at this. So I mentioned this briefly. The areas afforded via this exposure are the entirety of the circle of Willis. This includes all of the anatomical structures that you see here anteriorly, obviously not for the more posterior lesions. You can expose aneurysms of the ICA, and its various segments, the middle cerebral artery, the anterior cerebral artery, even some A2 aneurysms from this approach, and as well as the basilar apex SCA and proximal PCA aneurysms can be afforded from this approach. Looking at the approach, I just want to go over this briefly. This is sort of a schematic drawing of the standard skin incision for what is the full orbital-zygomatic approach. Really, the application of the full orbital-zygomatic approach is currently fairly rare, and I think it's limited for deep bypasses at the top of the basilar, clipping some high-riding basilar apex aneurysms, and maybe select giant anterocommunicating artery aneurysms, and of course, extensive skull-based tumors. But really, you have to, again, decide whether you need the zygomatic osteotomies in every case, because the removal of the zygomatic osteotomy is not without complications, especially some TMJ and chewing problems for the patients. So we'll talk about the full OZ, but again, I just want to stress that application of a full OZ, even in a busy surgical practice, is by no means routine, and they should be really selected for specific cases. It starts with the skin incision that's demonstrated, and at the depth of the surgical field, based on the bottom picture, is the area that's exposed. The key to this approach for the full orbital-zygomatic craniotomy is effective mobilization of the temporalis muscle, because really temporalis is what's going to limit your site of visualization. And this depends on how you elevate the temporalis muscle up and out of your way. There are different descriptions. There is the interfascial and the subfascial descriptions that have been afforded, but ultimately the goal is to obtain this type of a view where you've got full access to the zygomatic as well as the lateral orbital bars, so that you could make cuts necessary to remove this bar and then remove this temporalis muscle either inferiorly or anteroinferiorly, depending on the corridor that you're seeking. Once that mobilization is performed, then comes time for the zygomatic and orbital osteotomies. So the first piece of the procedure involves removal of a pterional frontotemporal flap, followed by removal of the, again, orbital and zygomatic osteotomies. And this involves 6 different individual osteotomies to do this effectively. And they're demonstrated here. And this approach has been described in the laboratory, and many of the trainees and neurosurgeons who use this routinely have done these osteotomies. But it involves the osteotomy of the zygomatic arch. It involves osteotomies of the anterior inferior frontal floor. And then these can be performed with reciprocating saws and obviously augmented with osteotoma mallets. But ultimately, removal and performing these 6 osteotomies affords one this exposure, okay? The top left-hand picture demonstrates removal of the orbital and zygomatic unit in one piece. This can be performed in a single piece or in multiple pieces, and fragmentation of the osteotomy. The cosmetic outcome diminishes with the increased number of fragmentation procedures that are done, but sometimes you need to fragment the osteotomies to give the patient a safer approach. Ultimately, though, in the bottom right-hand picture, you can see that the orbital-zygomatic provides you the 3 approaches and views that I mentioned before. It provides you a subfrontal exposure by removing the orbital rim and retracting the orbital content inferiorly. This obviates the need to place pressure and stress on the frontal lobe, especially for lesions on the left side where you might be mobilizing and compressing the dominant left frontal lobe. Most of these damages to these areas are silent, but in the dominant hemisphere, you can really see cognitive deficits in patients who have had prolonged retraction of the frontal lobe. Excuse me. You additionally get a similar exposure, although enhanced illumination, that you would get with a pterional route. The addition of the zygomatic osteotomy gives you a subtemporal view to the top of the basilar and to the cavernous sinus region. And of course, splitting the difference between the subfrontal and the subtemporal views, this gives you a half and half or a pretemporal view, which when combined with splitting of the sylvian fissure allows you to expose the entirety of the circle of Willis and the top of the brainstem region. And these drawings have illustrated this, and I will illustrate them with dissections as well as with some case examples later. But here is the demonstration of the splitting of the sylvian fissure and the anatomy that is immediately visualized upon opening of the basal cisterns and the dissection of the arachnoid. But you observe the optic nerve and the internal carotid artery, the branching of the internal carotid artery. And then if you trace more posterolaterally, you can identify the oculomotor nerve, and you can trace the oculomotor nerve all the way back through the membrane of Lilliquist to the posterior fossa and the top of the brainstem and the basilar artery. And this picture on the bottom left actually nicely illustrates one concept which we'll talk about in case examples. This exposure of the ventral midbrain is very difficult from the front, but the orbital-zygomatic exposure allows you to not only visualize both optic nerves and the tracts going posteriorly, but it allows you to visualize the mammary bodies, the oculomotor nerve, the trochlear nerve at its lowest extent. And then it allows you to expose the ventral motor tracts. And it's important to remember that in the brainstem, the corticospinal tract travels in the anterior 3/5 of the midbrain. And here it is highlighted in red, and this area is readily exposed from this approach. So here is an animation of the orbital-zygomatic craniotomy before we go through a step-by-step exposure and talk about the case examples. The patient is positioned supine with the head turned. Depending on which region you need to expose, you can turn the head. And here is what is considered variations of the orbital-zygomatic craniotomy, the modified and the full, depending on if you include the zygomatic osteotomy, opening of the dura overlying the frontal and temporal lobes, and then, of course, splitting of the sylvian fissure augments exposure at the depth. And not only does it augment exposure, it allows for better illumination and visualization of the deep contents of the entire circle of Willis, as well as here, in this case, illustrated the brainstem and different areas in the brainstem that can be accessed from this approach. And again, we'll talk about one particular example of it shortly. But let's talk about just briefly, step-by-step exposure of the OZ and the osteotomies. Standard frontotemporal skin incision with the head turned to the contralateral side. This can be performed with the patient pinned or on a horseshoe. Mobilization of the tissues to allow for exposure of the temporalis. Again, critical to augmented visualization from this approach is what you do with the temporalis muscle and how you do it. So you can do interfascial or subfascial mobilization of the temporalis. Ultimately, the exposure should allow you to pull the temporalis either inferiorly or anteroinferiorly with fish hooks, depending on where you're trying to access. Once this is performed, performing a burr hole to expose the contents of the anterior fossa and the orbit, stripping the dura as well as the orbital contents to make sure that you can minimize injury to the periorbita, which will cause significant swelling of the patient's eye postoperatively and may hinder their being able to see with that eye for sometimes several days. Stripping of the dura to perform, in this case, this is a two-piece OZ, so we're performing the pterional craniotomy separate from the orbital and zygomatic osteotomies. These can all be done together. Cosmetic result is better. The exposure requires you to do blind osteotomies, which can sometimes be unsafe. Definitely unsafe if there's extensive tumors or hyperostosis of the anterior or middle fossa bones. You want to do this in a piecemeal fashion in those cases. Once the pterional piece is removed, the 6 osteotomies of the zygomatic and orbital bones that I mentioned to allow mobilization of this orbital-zygomatic unit as one piece, followed by, in most cases, osteotomies using mallet and craniotome, or osteotome, I'm sorry, to allow you to remove this piece. Many practitioners suggest you pre-drill the plating system ahead of time so that you get better cosmetic results and are able to put this bone back at the end of the procedure to give the patient the minimal denting of the temporal and subtemporal compartments that are sometimes seen as the temporalis muscle wastes away. But ultimately, this is the exposure afforded. You can get less extensive visualization of the same approach from a pterional craniotomy. If you do a good pterional craniotomy and you drill the sphenoid and bring the exposure down to the meningorbital band, as is done here, you can get much of the same approach. Really, the OZ, depending on if you're using the O or the Z, the orbital or the zygomatic osteotomies, affords you the enhanced exposure by removing the soft tissues out of the way. And hopefully, therefore, you avoid needing to use a fixed retractor for the portions of the procedure that you are seeking to do. What about the modified or the mini approach? I mentioned this. You have to think, look at this picture here at the anatomy. You have to ask yourself ahead of time, what of this approach what of this exposure do I need? Do I need the subfrontal exposure? Do I need the subtemporal exposure? Do I need the pretemporal exposure? And which osteotomies must I absolutely do to get the exposure that I need without harming the patient? So if you don't need the zygomatic component of the exposure, and you often don't need for most aneurysms, unless perhaps a giant basilar apex aneurysm or an aneurysm at the top of the basilar that requires a deep bypass like an STA to an SCA bypass, you really don't need the zygomatic component in most cases. So in those cases, you can focus your orbital-zygomatic approach to what's described many different variations of this approach with different names to a mini modified orbital-zygomatic craniotomy, which is essentially a limited terional craniotomy with orbital osteotomies that allow you to get the pretemporal and the subfrontal exposure afforded by this approach. So here are again the osteotomies and the cuts. This can be done as one piece or as a two-piece exposure, a terional craniotomy followed by orbital osteotomies to allow for you to detract and pull the orbital contents inferiorly. What does that do? Well, as the picture in the bottom right-hand corner shows, when you pull the orbital contents inferiorly, it gives you an enhanced inferior to superior view. And this is critical, again, for those basilar aneurysms that are high-riding, for those ACOM aneurysms, which may be large or giant, or just a small standard ACOM aneurysm that may be residing high in the interhemispheric fissure, requiring extensive dissection of the fissure to get the distal neck or the distal outflow vessels to the aneurysm exposed. A lot of times, providers deal with this by resecting the gyrus rectus and putting a retractor on. But again, the hope here is that the additional bony removal and splitting of the fissures and release of CSF will obviate the need for a fixed retractor during the case. So again, going back to basics of tenets of skull-base surgery, remove bone and avoid retracting brain. Again, just very briefly using cadaveric examples before we get to a few case examples of this. A smaller, much smaller incision doesn't need to go down to the zygoma. It's about 1 centimeter anterior to the tragus, and it can extend to the mid-pupillary line. You mobilize the soft tissues, and again, here you don't need to remove or mobilize the entire temporalis muscle. So this provides a much better cosmetic outcome because the wasting of the temporalis is more limited. You mobilize the temporalis minimally. Often you can just cut the temporalis at the superficial temporal line and retract it with retractors to get the McCarty keyhole area exposed, to put the foot plate on, turn the craniotomy, and expose, after you've removed the terional component, the frontal fossa floor to be able to peel the frontal lobe away. Next, you peel the periorbita from the orbital rim, and when you do that, it allows you to demarcate the bony exposure that you need, and then use, again, osteotome and mallets or reciprocating saw to remove this lateral orbital rim frontally, and then the lateral wall of the orbit laterally, using osteotomies to get you a flush view of the frontal fossa floor. And if you remove some of the frontal fossa bone over the orbit, you can then use stitches to detract the orbit inferiorly, and again, obtain that inferior to superior view that this approach assists with. And again, here is a case, excuse me, case example of the exposure. For many people using these smaller exposures up front, this may be daunting. You ask yourself, can I really get all the anatomy that I need exposed at the depth of the surgical field? Can I get the illumination that I need? What if the aneurysm that I'm tackling ruptures and I can't obtain control? But really, even with approaches that are this small and limited, you can expose all of the anatomy that you need to get the job done. So here's an example. I just want to illustrate of an approach from one of those small minimal exposure approaches. The same approach you would get from an extensive terional or from a larger modified orbital-zygomatic craniotomy. You get the subfrontal view, dissect down, identify the cisterns. Here, expose and release cerebrospinal fluid from the contents of the basal cisterns to arrive upon the optic nerve and the carotid artery. And this is a relation that is ingrained in most surgeons' minds, the relation of the optic nerve to the carotid. And then really, if you need to get even more posteriorly, follow the optic nerve or the choroidal artery back to the basilar artery and expose the contents of the posterior fossa. The pertinent anatomy that's afforded is illustrated here. These are beautiful anatomic dissections by Dr. Khan Yagmarlu, who is kind enough to share these with me. But you can see that after the orbital-zygomatic craniotomy, as I illustrated earlier, the entire circle of Willis can be visualized, and the aneurysms arising from the carotid artery, top the basilar artery, the SCA, PCA, ACOM complex can all be approached, exposed, and surgically treated. I want to talk about two quick examples of variations and uses of the OZ that are perhaps not common. One is the use of a contralateral orbital-zygomatic craniotomy, so expose the depth of the surgical cavity from the opposing side. And here's an example of it that we published a few years ago, approaching lesions that are located in the ventromedian mesencephalon. A contralateral orbital-zygomatic approach allows you to work between the basilar perforators to open into the brainstem ventrally. And it turns out in the intrapeduncular fossa, there is a paucity of fiber tracts traveling that area. Therefore, you can expose lesions that are located in the ventral midbrain through this contralateral orbital-zygomatic approach with really very little deficit to the patient. This is one of two commonly used approaches, the other being use of the working corridor between the PCA and the SCA just lateral to the third nerve to expose lesions in the ventral midbrain. A second, and again, these are again anatomic dissections from Dr. Yagmarlu in another case of a giant mesencephalic pontine cavernous malformation that was exposed using this intrapeduncular fossa approach, and working here, as you can see in D, E, and F, in between the corridors of the perforators rising from the dorsal basilar wall. A couple of other areas of access that are often not thought about is using the corridor between the lateral lenticular striate arteries at the top of the carotid and the middle cerebral artery to access the anterior perforator substance. Again, what the orbital-zygomatic adds here is that inferior to superior view, allowing you to access these deep regions of the brain that are perhaps not easily accessible from some of the other approaches. So I just want to talk about two quick cases using the orbital-zygomatic craniotomy. Here's one which I used not too long ago for a basilar aneurysm that was previously treated. This woman had a prior subarachnoid hemorrhage in 2015. Had this basilar aneurysm, which was coiled by another practitioner. The patient on follow-up imaging was noted to have a regrowth of this aneurysm and several smaller aneurysms off the circle of Willis. And because of the multiplicity of the aneurysms and the fact that this aneurysm required stent-assisted coiling and complex maneuvers, and this patient was not a reliable person to take dual antiplatelets, I ended up clipping these aneurysms. You can see here the orbital-zygomatic exposure. Here's one smaller aneurysm, ophthalmic aneurysm that this patient had that comes into view immediately under the optic nerve. Again, I'm here exposing the deep contents, and really to visualize the top of the basilar, you have to use the working corridors that are available to you. And often the working corridors are limited, small, not well illuminated, but that's about all you have. So to expose the basilar apex, sometimes you have to work above the carotid. Sometimes you have to work between the carotid and the optic nerve. Ultimately, you follow the choroidal artery back, mobilizing minimal arachnoid to arrive upon the basilar apex. Here you can see coils within the basilar artery. It's a tight confines, but you can see there's no retractors used for this approach. I've removed the necessary bone to not have to put a permanent retractor system to be able to obtain the working corridors that I need. So dissected the PCAs off the base of the aneurysm and defined the neck. And here with a single straight clip, clipping the remnant base that has grown since the coiling. And once the clip goes on, it's important, of course, to ensure that within the tines of the clip are not the PCAs, SCAs, or most importantly, the basilar perforator. So inspecting around the clip. And indocyanine green angiography can be useful, but again, its utility drops at depths, and often it can not demonstrate everything that you need. Here's a CT demonstrating the additional smaller aneurysms which were clipped on the way out. And here is the angiogram demonstrating occlusion of the aneurysm without violation of the perforators, which you can see on the lateral angiogram. The patient was neurologically intact and discharged. This next case is one that I just performed very recently, so I apologize. The editing may not be as clean. This is a patient who had previously subarachnoid hemorrhage, had an anterior communicating artery aneurysm, which was coiled, and the patient presented with a vague constellation of symptoms, including multiple territories of infarction. We ended up performing a lumbar puncture. Sure enough, this patient had rehemorrhage from this previously coiled anterior communicating artery aneurysm. You maybe make a small visualization of it on the CTA and the MRA, but certainly what you see is the multi-territory infarction that is caused by cerebral vasospasm in this patient. So I took the patient to the angiography suite with the thoughts of considering recoiling it. Here you can see the cerebral angiogram demonstrates evidence of vasospasm in multiple territories and regrowth of the aneurysm adjacent to the coil mass. Certainly you can consider recoiling this aneurysm. You can consider stent coiling this aneurysm, although not a great option, especially in the setting of subarachnoid hemorrhage, especially in the setting of vasospasm. Then you also have the traditional option of just taking this patient and clipping this aneurysm. And my strategy with previously endovascularly treated aneurysms is fairly simple. If I can have a standard endovascular treatment option for it that is straightforward and doesn't involve additional risk to the patient, I will certainly perform an endovascular treatment if I can get a good durable result. But if I'm going to have to start stent coiling or flow diverting and coiling lesions in order to get a good durable result, especially in the setting of recurrent subarachnoid hemorrhage, I prefer surgical treatment if I can do it safely. And that's what was considered and performed for this patient. So modified orbital-zygomatic craniotomy, a generous skin incision, because I know the brain is going to be swollen in the setting of subarachnoid hemorrhage, but no need to remove the zygomatic bone. Performed a pterional craniotomy and a second piece orbital osteotomy to give me the inferior to superior view. And here you can see again, even in the setting of a pretty extensive subarachnoid hemorrhage, no fixed retractors are necessary because I've removed the bone to be able to get the surgical views that I need. And in most cases, there is really no need to place a fixed retractor to do this. Splitting the fissures, releasing blood and cerebrospinal fluid to get some brain relaxation. Now I know that the anatomy is going to dictate how I approach this aneurysm. This aneurysm is going to be located between the optic nerves, immediately adjacent to the optic chiasm. So I release the arachnoid and I open up the cisterns widely to release blood and CSF to get the brain to relax so I don't have to put a fixed retractor in. So here is the anterior communicating artery complex coming into view, and the aneurysm's rupture point based on MR angiography and formal angiography is anterior. So as long as I don't manipulate the bleeding point and define the rest of the anatomy of the aneurysm, I'm going to be fairly safe and I won't need to put temporary clips. And that's, again, another benefit of this additional working corridors and exposures. You can hold off in most cases on placing your temporary clips and decrease ischemia time in the patient. So exposing the contralateral A1 and A2 and the ipsilateral A1 and A2. And here you'll see shortly the coil mass from the prior treatment is going to come into view. Here it is. So now I've defined the neck of the aneurysm. There is the inflow and outflow vessel in the contralateral side being retracted using the 6 dissector. And I've already exposed the ipsilateral inflow and outflow vessels. So again, leaving the bleeding point alone, I've defined the neck and I'm going to use a single straight clip to obliterate this aneurysm completely. And of course, the post-clipping inspection to make sure that the paired vessels arising from the anterior communicating artery complex or contributing to it are not included in the clip construct mass. And as was mentioned previously by other speakers, ICG is going to be critical. Here you can see, again, that operative picture, despite not using any fixed retractors, and even in the setting of subarachnoid hemorrhage, the brain doesn't look terrible. Because again, I have removed the bony piece over the orbit here and the pterional piece overlying the frontotemporal operculum and retracted the eye. You can see the stitch held over the dura overlying the eye. Retracted the eye out of the way to get the working corridors that I need to do this safely. And here is the postoperative angiogram demonstrating complete exclusion of the aneurysm. So with that, I'd like to thank you guys for allowing me this opportunity to speak about the orbital-zygomatic approach and its applications. Thank you all for listening.
Thanks a lot, dear Professor Yashar, for this excellent presentation and cases. It was a pleasure for all of us to get such a great lecture. Thank you.
Thank you,
Is
sir.
there any questions for? Is there any question from panelists? Thank you again, Professor Yashar. And now we will get to the end of this day. I'd like to thank all eminent faculty and speakers that join us today. It was a great pleasure to be with you and enjoy all this nice presentations and cases, videos of eminent speakers. Thanks, dear John, for your effort. It was
Sam,
very,
can I make
very
a
long
remark,
day.
please? Can I make a remark?
Okay.
Yeah, you know, Sam, you put a great lineup together. I mean, just a super. Could you go over the schedule tomorrow, please? Could you screen share it?
Schedule tomorrow.
Can you screen share it and go over it, please? Because we got some really good names. Really good names.
Okay.
Oh, you want me to do it? I can share it. Here, hold on.
Oh.
Okay, go ahead if you want to do it. Go ahead.
Yes, I will share now the rest of schedule. Okay, you can share it. You can share it.
Okay, let me share. Let me share
You can share
what
it.
I got. Yeah. Let me just give me a second.
I know to stand for 12 hours.
The schedule is really good.
Okay. I'd like to thank also all the attendees who have stand for 12 hours, which is a great effort from all of them. Thank you.
Okay, Sam. Let's see, we start.
Okay, we will start tomorrow at 1 p.m. Cairo, which will be 12.
Oh, okay, there we go. Yeah,
time.
bone anatomy of base skull, right?
1 p.m. Cairo tomorrow.
Okay, is it right here? Musa Croc, Sirac?
Yep.
Okay.
Okay. Thank you, Joe.
Okay, then Khan, then go to Takeo Sanjiva. I've heard of him. I'm sure he's big. Paul Gardner, of course, Pittsburgh. And Vlad's speaking tomorrow. I'm pretty sure he'll come in the lounge. Okay. And then
it will be great. We have a lot of eminent speakers for tomorrow also.
Yeah, Matthias, Hisham, Sebastian Froelich, Alvaro Campero, Pablo Arher, James Leo. Wow, you got some good names. So,
yes.
Okay, Sam, I'll sign up to you. It's up to you to close.
Thank you for your effort. See you tomorrow.
Bye, everybody. Thank you.